first session. The first invited talk is from the Dr. Mohammad Iqbal, Ma'am Alam Saab. The topic is why PRP and PRP for the trauma surgery. Dr. Mohammad Iqbal, Alam Saab.
ये कहाँ से इसका क्या करना अच्छा थैंक यू ये सही है कैसे हेलो ओके स्टार्ट बिस्मिल्लाहिर्रहमानिर्रहीम अस्सलाम वालेकुम and welcome everyone. My name is Captain Dr. Iqbal Alam. I am an orthopedic trauma consultant working at Chinoor General Hospital for the last 20 years. Very unusual topic I am talking about, the PRP. Although many of the people, doctors know that what is PRP anyhow. Now, I will just give one brief thing, how I got into the PRP. Back in 2016, September, one of my friends, he is a plastic surgeon, he had some knee problem. And he called me, Akbar, can you come and see me when you are free in the evening? I went and saw in the clinic, और उनको नी और एक्सरे करवा लिया था, he had some osteoarthritis हुआ थे. तो हमने कहा यार osteoarthritis से क्या ट्रीटमेंट है? वर्ल्ड वाइड तो ये पेन किलर लें, फिजियोथेरेपी करवाएं, नथिंग और ब्रेस वगैरह लगाएं. कहते नहीं अखबार, I cannot नमाज नहीं पढ़ सकता हूँ, and I am taking this medicine, not benefiting me. तो हमने मैं बताएं क्या करूँ? मुझे कहने लगे एक बार देखो मैं PRP लगाता हूँ स्कैल्प वगैरह में, हेयर फॉल में, why did you do this for me? हमने कहा if you see, on his insistence I did the PRP to him, joint में, knee joint में, right. And after 1 week he calls me, Akbar, I'm actually absolutely I'm very fine, मैं नमाज पढ़ सकता हूँ, ये करता हूँ, why didn't you take over? तुम चिनौर में वहाँ करते हो, you get lot of patients there, why don't you take over PRP, you start doing there. After that I took over in 2016-18 में, अक्टूबर में शुरू किया हमने चिनौर जनरल हॉस्पिटल में the PRP thing. And I started doing the PRP, started the knee joints. And I got a very positive response from the patient. एक हफ्ते बाद आके बताया, sir, I'm 60%, 70%, much better now. 2016 में, December में, I got one patient from Afghanistan. He had a rotator accident, open fracture tibia fibula का था, and he was on external fixator. उसको वहाँ 1 महीने से ट्रीटमेंट हो रहा था वहाँ इसमें अफगानिस्तान में. After 1 month, the doctor over there, they said that there's nothing you can do, you have to do the amputation of the leg. Then he came all the way from there to my hospital, Chinoor General Hospital. और कहते डॉक्टर साहब मैं बहुत दूर से आया हूँ, money is no problem, I don't want my leg to be amputated. आप जितना पैसे ले रहे हैं हमें सही कर दें, मेरे टांग नहीं कटना चाहिए. ऐसे फाइन, मैंने देखा होगा, हमने कहा ठीक है, उसको एडमिट किया. That was the first PRP thing I have done for the trauma cases. I believe I kept him for 1 month. डिब्रीमा करता रहा, PRP लगाया, एंटीबायोटिक वगैरह. After 1 month, then wound got back, settled down, remove the external fixator, put the interlocking किया उसमें. उसी sitting में I did the skin grafting. I believe me, left hospital walking. That was the first trauma case I did. Now osteoarthritis is worldwide. It is a problem all over the world. And इसके treatment क्या है? Nothing. The painkiller and physiotherapy कराते रहे. Wait for the till age of 65, then you go for the knee replacement. And believe me, in this hospital, I have done 1,300 cases of PRP I have done. That includes knee joints, for osteoarthritis, intra-arterial soft tissue injuries like meniscus, ACL tear. But then I have done lot of wound, diabetic foot crush injuries. I've saved their leg, limbs from the amputation. And I've done AVN, non-traumatic AVN, avascular necrosis of the femoral head. I have saved many patients from total hip replacement. The standard. Hello? Hello? Yeah. Should I hold it? Hello? Yeah. The standard treatment of AVN, non-traumatic I'm talking, not trauma. Standard treatment, do decompression वाला करें आप, and just see this last final result is a total hip replacement. And for a person of 25, 30 years, if you do total hip, उसकी ज़िंदगी तबाह हो गई ना, तबाह हो गई, विचार क्या करेगा? Total hip कर देंगे वो. So since I have done so many, by the time काफ़ी हमने PRP knee में किया, I got a very positive response. हमने कहा why should I not try this one? Decompression करता था मैं, and उसमें PRP लगाया हमने hip joint में, head and neck में, all under the Siam guided. And believe me, I have done about more than 10 cases and got a very good result. Very good result of that decompression and PRP of the head and neck femur AVN cases. Now, ज़्यादातर हमने जो PRP लगाया mostly the knee case, knee joint में, knee joint osteoarthritis plus interarterial soft tissue injury, meniscus injury, ACL tear वगैरह में. Osteoarthritis में 80% patients I got a very good response really. They are very happy. Very good response. How you find the response? Patient themselves कहते हैं डॉक्टर साहब जो मुझे तकलीफ होती थी चलने में नहीं होता है, I can नमाज पढ़ सकता हूँ मैं, स्क्वाट भी कर सकता हूँ. अब अल्हम्दुलिल्लाह I feel much better now. इसी तरह से मैंने about 60% जो हमने जो PRP किया नी जॉइंट में और about 10% हमने जो इंटरआर्टरियल सॉफ्ट टिश्यू मेनिस्कस इंजरी ACL tear में किया. I believe me, पहले 2016 से पहले I used to do arthroscopy in my hospital, the Chino General Hospital. Since I got into the PRP, I stopped doing the arthroscopy. I said no way. I did this PRP for meniscus ACL and I got a very good result. But 12-13 लोगों को हमने, they come for the actually arthroscopy का दूसरे सर्जन करते हैं arthroscopy करना पड़ेगा तुम्हारे meniscus injury है फलाना. They come my opinion, I say no, stop it, don't do arthroscopy. I'll save your knee without operations. I have done more than 10 cases. Patients का हमने arthroscopy बंद किया हमने, इस PRP से हमने got a very good result PRP से. And another thing is this, there are many patients हमारे पास traumatic आते हैं, crush injuries, being went to different hospitals, they say that इसको काटने के अलावा कोई हल नहीं है. They brought to me, I say fine, I'll try to save, but time factor, you have to have the hospital for 1 month, and I'll give this, and I have done save many patients' limbs from the amputation by, of course, wound debridement करते antibiotic, plus I have done the PRP. I'll show you some of the pictures. You can see. Many patients diabetic foot being treated outside. They say it's a काटना पड़ेगा. They were brought to me. I said no, forget about काटना. I'll save it. Now I would like to show some of the pictures then. Hello. देखा है picture? No, PRP. Sorry, PRP होता क्या? What is PRP? Platelet rich plasma. Now you take out the blood from the patient, about 18 cc blood लेते हैं, 2 ml of anticoagulant. They mix together. करने के बाद एक special PRP tube होते हैं. 2 tube उसके अंदर डाले 10 cc blood डालने के बाद you put in the centrifuge machine for about 8 minutes. After that you stop that and see this, the plasma thing is up bottom tube में ऊपर plasma होता है, settle down cell नीचे होता है. You take out the plasma. 2 syringe में डालते हैं, then activator होता है. The important thing is that बहुत लोगों को देखा कि वो blood निकाल के plasma लेके डाल देते हैं. This is not proper thing to do it. You must activate. Activate करते 15 दफे इधर 15 दफे activate करने बाद क्या? What happened? The platelet get charged. Platelet function then become work like a growth hormone. The जहाँ भी degeneration है, the platelet जो है charge हुआ, they work like the growth, they regenerate करते हैं उसको. This is how the function of this PRP. Area. Now this is the C. Okay, move, keep moving. Keep moving. Now this is the trauma injuries cases. Keep moving. See the traumatized wound. Keep moving. करते जाए. And this is they are doing the PRP now. See? ये हाथ की severely traumatized wound. Keep moving. Move on. Move on. And move on. करते जाए. करते जाए. Now this is another severely traumatized wound. पूरा हाथ क्रैश हुआ हुआ है, मशीन में आए थे, and he was taken to the hospital. वो कहते हैं काटने के अलावा कोई हल नहीं है. It has to be amputated. Then he was brought to me, and gradually, anyhow, देखते जाए. Finally, I saved the thumb, a part of the index finger, and did the skin grafting. This is another case of, lady about 60 years. She was taken to different hospitals. They said amputation का अलावा 3 hospitals, different hospitals गए. वो कहता below knee amputation का कोई हल नहीं इसका. Anyhow, they were brought to me. I said, okay, fine, I'll save it. Just see the condition of the leg. Now you see, I'm doing the PRP as well. This patient as well did the PRP. Okay, just a minute. And finally, I did the skin grafting. I saved 4 toes. Big toe was amputated, and she's on full weight bearing. This is another diabetic foot. Just see this condition of the wound. Finally, I've done the skin grafting. This is another foot. This is another patient, deep-seated abscess, leg and thigh. पूरा देखें. Snake bite. This patient came from other part of the city, not from the Karachi. एक महीना पहले सोच शायद snake bite वाला कुछ some kind of bite. With this condition came to me, and he was treated for 1 month. I don't know what they were treating with this patient anyhow. I took over it, fine, I will save it. Just keep seeing it. पूरा पस भरे हुए हैं. Why is not moving? And now after 1 month, with that man, we sent the limb. Skin grafting किया हुआ है. Now we are showing the PRP of the knee joint. Taking the blood. No, this is the one I'm showing that AVN के लिए. AVN में वैसे necrosis of the femur देखिए small cut दे रहा है वहाँ पर under C-arm के करके वहाँ पर. ये token base में वहाँ से. You see this. This is drill machine. Drill कर रहा वहाँ under C-arm all. Drill, you see, making the decompression of the head and neck of the femur. Now this is, see this, उसके साथ निकालने बाद then we putting the PRP लगा लो उसके ऊपर. No, I'll show you some videos. Can you show that one? Bilal? Hello? Bilal?
Yes, go.
The video देखा है? Now the few I've taken many videos as well. This is pretty much I can show you. We have types of videos that on the different journey of the patient and the hospital. But I got few to show to you. This is lady.
These डॉक्टर्स आई शोड मुझे कहा नी रिप्लेसमेंट के लिए और बल्कि इनफैक्ट जब देख 3-4 दफ़ा मेरे पास उनका विज़िट हुआ, फिर उन्होंने मुझे एक्सरे वगैरह कराए, सब कुछ देखा और फिर मुझे एडमिट करने के लिए सब कुछ दे दिया पेपर और कहा कि अब सुबह के एडमिट हो जाएं। मगर इत्तेफाक से ऐसी बात है कि हमारे नेबर जो है डॉक्टर इलियास, जब उनको पता चला कि मैं एडमिट होने वाली हूँ नी रिप्लेसमेंट के लिए, तो उन्होंने मुझे सजेस्ट किया कि उनके एक फ्रेंड है डॉक्टर इकबाल जो पीआरपी करते हैं, तो उन्होंने कहा एक दफ़ा मेरे कहने पे अगर आप ना करवाएं ऑपरेशन और उनको दिखा दें, और वो चिन्नौट पे बैठते हैं, चिन्नौट हॉस्पिटल में। तो मैंने डॉक्टर इकबाल से मिली वहाँ जाके, तो उन्होंने मेरा पीआरपी वहाँ पे पहली दफ़ा मैंने जब दिखाया उनको, तो उन्होंने कहा कि आपका पीआरपी होगा और आपके प्रॉब्लम है, तो फिर और इंशाल्लाह ये बिल्कुल सही हो जाएगा, यू डोंट नीड टू गो फॉर अ नी रिप्लेसमेंट। इन्होंने मेरा ट्रीटमेंट किया और अल्हम्दुलिल्लाह अल्हम्दुलिल्लाह मेरे लिए बहुत आसानी हो गई। जो मेरी कंडीशन थी और मैं चल नहीं पाती थी, मैं सीढ़ी नहीं चढ़ पाती थी, लोग मुझे अक्सर पकड़ पकड़ के ले जाते थे, तो मुझे बहुत प्रॉब्लम होती थी। मगर जब से मैंने पीआरपी कराया तो मुझे अल्हम्दुलिल्लाह आई एम मच बेटर, बहुत बेहतर है।
अस्सलाम वालेकुम। आपका नाम क्या है?
मेरा नाम है गुलजेब ज़ेबा।
ठीक है, आपकी उम्र कितनी है?
मेरी उम्र 57 साल है, 57।
ठीक है, आपको क्या तकलीफ है? आप किस तकलीफ के साथ यहाँ आई हैं?
मेरे जो दोनों घुटने हैं इनके अंदर सिवियर आर्थराइटिस था काफ़ी सालों से,
ठीक है,
15-18 साल से, जिसके लिए मैं इंग्लैंड में रहती हूँ और मैं लंदन में रहती हूँ, और वहाँ से मैंने बहुत इलाज कराने की कोशिश की, लेकिन वो लोग ऑपरेशन नहीं करते और सिर्फ पेन किलर देते हैं और बड़ी सख्त किस्म की पेन किलर देते हैं, जिससे खाने के बाद आपको और दूसरी किस्म की तकलीफ़ें हो जाती हैं। कराची आना हुआ मिलने के लिए रिश्तेदारों से, तो मेरी एक बड़ी बहन जो है महजबीन उस्मान, उन्होंने मुझे बताया कि डॉक्टर इकबाल आलम चिन्नौट हॉस्पिटल में वो रिप्लेस कर देंगे आपकी नीज, क्योंकि शी हैज़ डन बाय इकबाल आलम दिस प्रोसीजर सक्सेसफुली। एंड मेरी जो मदर हैं उनका भी इकबाल आलम ने दोनों घुटनों के ऑपरेशन किए और अगले दूसरे दिन चलवा दिया उनको, यानी नी रिप्लेसमेंट करके। फिर ये है कि उन्होंने मुझे कहा कि आप वहाँ जाइए, वहाँ हम आपको लेके चलते हैं। फिर उन्होंने अपने बेटे को अकम्पनीट किया, मेरे साथ किया। फिर जिस दिन हम यहाँ पे आए हैं, क्यों तो बड़ी लंबी थी, लेकिन जैसे ही इकबाल आलम ने मुझे देखा उसी दिन उन्होंने जो है ना पहला मेरा इंजेक्शन, ये जो प्लाज्मा है पीआरपी है ना, उन्होंने पहले दिन प्रोसीजर किया मेरा। ब्लड लेने के बाद वो मशीनों में डालना, फिर उसके अंदर कुछ इंजेक्शन डालना, फिर वो तो पहली दफ़ा। और मेरे साथ ये प्रॉब्लम था कि मैं चल नहीं सकती थी, अनएडेड स्टिक लेके चलना होता था। इंग्लैंड में मैं स्कूटर पे चलती हूँ, जो मोबिलिटी स्कूटर होती है अपाइजों की। लेकिन अब ये आलम है कि 2 दफ़ा मुझे लग चुके हैं। एक मरतबा जब लगा तो मुझे 20% फ़ायदा हुआ, वरना मैं अपने आप को स्टेबल नहीं कर सकती थी, किसी के साथ चलती थी या फिर अकेली नहीं चल पाती थी। सीढ़ियाँ चढ़ना तो सवाल ही नहीं पैदा होता था।
ठीक है।
पहले
उठना बैठना कैसे होता था?
उठना बैठना बहुत मुश्किल से होता था, बहुत सहारा करके, बहुत मुश्किल से। घुटनों में बहुत तकलीफ होती थी, बहुत ज़्यादा। खड़ी हो जाऊँ तो फिर 5 मिनट तक खड़े हो गए, लेकिन किसी के साथ चलना पड़ता था, अकेली नहीं चल सकती थी, गिर पड़ती थी 10 कदम के बाद। पहले की दफ़ा में मुझे कोई 20-30% फ़ायदा हुआ।
ठीक है।
फिर दूसरे इंजेक्शन लगे 1 हफ्ते के बाद, तो मुझे आप यकीन करें कि 60-70% आई वॉज रिकवर्ड। आई फील माई सेल्फ मच बेटर देन एवर आई हैड बीन। सो उसके बाद अब तीसरा इंजेक्शन लगने वाला है, जो कि लास्ट है, और 2 हफ्ते के बाद बुलाया था। इकबाल आलम एक अमेजिंग सर्जन है, जिनकी बहुत शोहरत है। अल्लाह ने उनके हाथ में इतनी शिफा रखी है, इतनी शिफा रखी है, जिसका कोई अंदाज़ा नामुमकिन है, बयान ही नामुमकिन है।
Now, what is PRP stand for? It is called platelet-rich plasma. You take the blood 18 cc ब्लड लेते हैं हम 20 सीरीज में और 22 ml हम एंटीकोगुलेंट लेते हैं। एंटीकोगुलेंट से रहता है ब्लड क्लॉट निकल जाता है। और उसके बाद हम उसको मिक्स करने के बाद 2 ट्यूब्स होते हैं पीआरपी एक्टिवेटर, पीआरपी कलेक्शन ट्यूब्स होते हैं, उसको हम 2 ट्यूब में डालते हैं 10 ml 10 ml। और एक साइंटिफिक मशीन होता है उसके अंदर हम डालते हैं होल ब्लड को 10 cc इसमें हो गया 2 ट्यूब में, और उस मशीन को ऑन करते हैं फॉर अबाउट 8 मिनट्स के लिए। आफ्टर 8 minutes के बाद that machine stop, you take out the tube. What happened now? Maybe I can show you बाद में, हो सकता है अपने वीडियो बनाई हुई है, you can see how things work. तो ब्लड जो होता है नीचे बैठ जाता है, ऊपर व्हाइट वाला चीज़ है सेरम प्लाज्मा जिसको बोलते हैं, येलोइश टाइप का होता है। We take out that plasma, सीरीज में लेते हैं, एक सीरीज में दो सीरीज में लेते हैं उसको, और वो कहते हैं that plasma is called platelet discharge. That is the important thing for us. Platelet is why called platelet discharge? Platelet is very important. Now I'll tell you what happened now. उसको एक्टिवेटर होता है, प्लास्टिक नुमा चीज़ होती है, उसके सारे सारे इंग्रेडिएंट्स होते हैं, कैल्शियम मैग्नीशियम पोटेशियम वगैरह सारी चीज़ें होती हैं, उसके अंदर एक्टिवेट करता है 15 दफा फ्रॉम दिस साइड 15 टाइम फ्रॉम दिस साइड करने बाद देन वी करेक्ट इन द सीरीज। व्हाट हैपेंड नाउ, प्लेटलेट को वो जो एक्टिवेट किया तो प्लेटलेट बिकम चार्ज हो जाता है, दैट बिकम ग्रोथ हार्मोन। जो डॉक्टर्स है वो आर इन्वॉल्व, दे नो व्हाट इज ग्रोथ हार्मोन क्या होता है, इट हेल्प इन द ग्रोथ ऑफ द बॉडी। इसी तरह से क्या होता है, कार्टिलेज जो डिजेनरेशन होता है उसको रिजेनरेट करता है बिकॉज ऑफ द प्लेटलेट दे बिकम वर्किंग एज ए ग्रोथ हार्मोन नाउ, एंड दिस इज हाउ फंक्शन। No, the first lady you saw is before this one. She was due to be admitted in Aachen Hospital for knee replacement next day in the morning. And she lives in the Gulshan Iqbal. Unki neighbor hai, doctor hai, he knows me. And he said, oh, why you are going? कहते हैं मुझे knee replacement मुझे दाखिल हुआ फिर सुबह और knee जोड़ बंदी करवाना है आगन में. Then he said, why don't you go and meet Dr. Iqbal? He's a friend of mine. He's doing a lot of things there, PRP. But insist करने पे फिर she came here. बाकी तो आपने सुन ही लिया हुआ. The other lady, she lives in UK. She's a very qualified PhD वाला है वो. बाकी आपने तो वीडियो देख लिया. What I say now, in this hospital, I've saved 10 patients from knee replacement से बचाया हमने. बहुत से पेशेंट आते हैं हमारे पे ओपिनियन लेने के, सर वो दूसरे डॉक्टर ने कहा जोड़बंदी करवा लो, different 10 patients. I say no, forget about knee replacement. I will not do that. I'll save your knee without doing surgery. I have saved 10 patients from knee replacement बचाया by doing 3 PRPs, and they are very happy. There are many, हमारे पास काफ़ी इंटरव्यू हुआ है हमारे पास videos. I wish I could have shown. Many patients I have saved from arthroscopy. मैंने भूल जाए arthroscopy नहीं करने की जरूरत है. You will save without doing arthroscopy. मैंने arthroscopy मतलब 1 लाख 1.5 लाख रुपया खर्चा होता है. और PRP hardly 30-35,000 cost. So money wise you should take that one. वो कम पैसे में काम होता है, why should go for the excess money? And it's काम मुल्क के हालात भी ऐसे money economically. Anyhow, now what I am saying that I want to give message to my orthopedic colleague. Please minimize your knee replacement. Minimize करें आप. Try this PRP. It will work very well. Very well. मैं अपना एक्सपीरियंस बता रहा हूँ. 1300 पेशेंट का हमने PRP लगाए in this Chinook General Hospital in last 7 years, and I got very excellent result. Minimize your knee replacement. Minimize your arthroscopy. Go for the PRP. Don't go for arthroscopy right and left. Another thing is that don't go for total hip replacement for AVN के लिए मत जाए. Try this one जो मैंने यहाँ शुरू किया हुआ. Decompression and go for the PRP. That will give you good result. और result इससे patient खुद कहता है सर जो मुझे तकलीफ होती थी वो नहीं होता है. I can sit now within few days. एक हफ्ते के अंदर because the patient themselves I'm feel much better. Don't go for any amputation of the knee limbs की diabetic हो crash injuries को. Don't try for this. PRP करें, but at the same time you have to do debridement of the wound as well, plus antibiotic. And 3-4 हफ्ते में इंशाल्लाह, see this, I've shown you the old picture. I have plenty of pictures of this. I wish I got shown you many things. Anyhow, thank you very much.
Thank you, Brent sir. Such a nice talk. Any question? Yeah, Mike. Sir, questions है अभी.
So you
Yeah. बोले
so you showed a couple of patients. What grade of arthritis they were in when you injected PRP, and when we are to go for total knee replacement, there are clear-cut indications. So how can we say maybe we can delay the TKR, but how the statement that we can save a patient from TKR may be a big understatement. So your comments on this?
लेकिन ऑर्थोआर्थराइटिस जो है वो गेट माइल्ड मॉडरेट सीवियर यूजुअली जो करते हैं आप टोटल नहीं करते सीवियर ऑर्थोआर्थराइटिस में पूरी दोनों कंपार्टमेंट में वायरस में किया हुआ ग्रॉस होते ऑर्थोआर्थराइटिस नहीं जान माइल्ड मॉडरेट में तो नहीं करते हैं प्लस मेरे एज फैक्टर ऑल्सो वी शुड कंसिडर जो लेडी देखो वो आई थी इंग्लैंड से शी वाज सेड नो यू कैन नॉट डू नी प्लेसमेंट बिकॉज यू आर 57 ईयर्स यू कीप टेकिंग कहते मुझे सुना होगा आपने लेडी जो फ्रॉम यूके पाकिस्तानी है वो कहते डॉक्टर ऑर्थोपेडिक से कहते नहीं यू कैन नॉट डू रिप्लेसमेंट बिकॉज यू आर टू यंग 57 ईयर यू वेट टिल यू बिकम 65 देन यू विल डू द नी रिप्लेसमेंट देन शी सेड व्हाट अबाउट माय पेन कहते पेन यू जस्ट टेक डिफरेंट मेडिसिन तो ये पेन इज द वन फैक्टर जो कि ये जो लोग यहाँ पर जो करते हैं ना नी रिप्लेसमेंट में पेन बट व्हाट आई एम सेइंग नो माइल्ड मॉडरेट में हमने जो PRP 1 और 2 करते हो सीवियर जो होता है ऑर्थोआर्थराइटिस जिसको नी रिप्लेसमेंट 10 पेशेंट को जो हमने वहाँ बचाया है नी रिप्लेसमेंट 3 PRP करता हूँ एंड आई गॉट ए गुड माई ओन यंगर ब्रदर ये देखिए नेवी का वो है सब मेरीन में कैप्टन है वो ही हैड ए नी प्रॉब्लम ही वाज advisor for knee replacement. Then he contacted me. I said, I mean, forget about it. That in 2016 when I started the PRP, no, forget about knee replacement. I saved his knee from the knee replacement by PRP. So I advise you for please try this. It will get a very good result. And you could save many patients from knee replacement. Okay?
Good morning, sir. Apologies, I caught the letter at the end. That was my bad. I was just wondering when you say that you have saved the knee, what was the time limit? Like, I'm not a knee surgeon, but definitely I would have seen knee arthritis people. At times, they would be symptom-free for, even with a tablet of paracetamol for a good few months. You give them 2 tablets paracetamol for PD, they would be symptom-free. And most of the time, they would be symptom-free without any medication. So I was just wondering what was your criteria when you say that they were saved from total knee replacement? For how long did you follow them up? Was that the winter period that they were symptom-free because they were symptom-free from the placebo effect of PRP? As an upper limb surgeon, to me, I have been very liberally using PRP and lateral epicondylitis, and to be honest, there is no difference for me with dry needling, local anesthetic, steroid injection, and most of the world literature, meta-analysis, they would support me in the upper limb. So I was just wondering, what was your time limit when you say that you have saved them from total knee replacement? Thank you very much.
They get a PRP, I don't think it's really common still worldwide. मैं यहाँ शुरू किया 2016 में. I don't think other hospital was doing. I'm the first one to start this PRP in Pakistan, I think. Anyhow, even in the abroad, recently they have also started PRP in USA में. And they have how much it costs? $5,000 लेते हैं वहाँ पर. वो पूरा regime बनाते हैं. Physiotherapy होगी 3 हफ्ते 4 हफ्ते, admission blah blah blah. Anyhow, there are many patients has come. One lady came. She was a nurse, Pakistani origin. उसके वीडियो बनानी है ना. That is, I could have shown you a picture. कामरान वो है वो वाली कैनेडियन लड़की थी वो जो नर्स थी वहाँ से कनाडा से आई थी वो बिलाल नहीं है. She was also came and इसी तरह से that these people went back and they told वहाँ भाई PRP वहाँ करवाओ सस्ता पड़ता है जितना पैसे $5,000 वहाँ लगते हैं वहाँ से they can have a holiday trip. 6-7 patients came from USA for this PRP के लिए and they had a very good result. They were very happy. कहते हमारा ट्रिप भी हो गया यहाँ पाकिस्तान का फ्री का ट्रिप भी हो गया फैमिली के साथ और हमारा PRP हो गया. 6-7 patients from USA they came. तो ये अब इन्होंने वो USA में शुरू किया हुआ PRP वगैरह And but इसका रिजल्ट तो ये है ना, आई मीन दिस इज रियली हमारी जो हमने यहाँ किया है जितने और ग्रेड ऑफ ऑस्टियोआर्थराइटिस वेरस में वैगस में जो भी है, आई गॉट अ वेरी गुड रिजल्ट, रियली वेरी गुड रिजल्ट.
Actually, my question is, like in a severe osteoarthritis, the patients are only pain-free, or you have any some radiological investigations that knee joint or MRI joint test up you have which showed कि भाई regeneration start हो गई, cartilage regenerate हो गया, and there's no need for the TKR in the future.
या देखें ना इसकी स्टैंडर्ड तो ये है ना, पता है ना हमारे चिनौट में जो किस किस्म में मिडिल क्लास लोअर मिडिल क्लास टाइप के लोग ज़्यादा आते हैं. वॉट्स द इंडिकेटर हमें पता चलता है इसकी कैसी, इसकी रिस्पॉन्स कैसा है. रिस्पॉन्स हर एक्सरे में यू टेक अबाउट 6 months to 1 year लगता है बिफोर यू गेट चेंजेस इन द एक्सरे में. बट क्लिनिकली मोर इम्पॉर्टेंट पेशेंट सेटिस्फेक्शन. पेशेंट कहते हैं नाउ आई कैन स्कॉट, आई कैन, मैं सीढ़ी में ऊपर चढ़ सकता, नमाज पढ़ सकती हूँ मैं. दैट इज द इम्पॉर्टेंट थिंग, दैट वन. फॉरगेट अबाउट द फाइंडिंग क्या हुआ. क्लिनिकल पेशेंट से खुद वो बताएगा आपको, आई एम मच बेटर नाउ. सब पेशेंट कम सर आपने एक लगाए, एक और लगाए, आई एम मुझे काफ़ी आराम है, और एक दूसरा इंजेक्शन लगाए. फिर दूसरे पेशेंट कहते हैं सर एक पॉइंट में हमारे सही है, घुटने में ट्राई आता नहीं. पेशेंट से कम सर देते आप दूसरे घुटने में लगाए. हर ओपीडी में 2-3 पेशेंट जरूर लगाता हूँ मैं किया भी. पेशेंट कम ना हो. जैसे आप, मैंने सुना आप ये करते हैं, आप करें मेरे नी में लगाए. So I wish you people try this one. It's a very good result, really. And in the long run, you will save. एक दफा PRP लग गया, unlikely that he is going to have a knee replacement. देखा ना जो डिजेनरेशन होता है, डिजेनरेट करता है ना. ये PRP का काम ही है ना, प्लेटलेट जो एक्टिवेट वो किया करने के बाद वर्क लाइक ग्रोथ हार्मोन डिजेनरेट करता है सारे डिजेनरेशन को. एंड इट गॉट मोबिलिटी बेहतर आती है, पेन बेहतर होता है. ओके.
Thank you, sir. Thank you very much, sir. Thank you. Acha, sir, one question. One more question, sir.
One more. You have shown a few slides where you have injected plasma into the vascularized tissue, of course, on the margin of the wound. You are injecting plasma in already plasma perfused tissue. What makes the difference? How can you say that it has increased the regeneration? While equivalent to this, you can get this excessive tissue regrowth with vacuum-assisted dressing also very rapidly and within 48 hours. How will you explain this difference?
देखा ना, जब पता नहीं, it works against infection as well. जो हम लगाते हैं PRP, it works against many organisms as well. So it kills the organism, staph वगैरह, E. coli वगैरह, they kill the organism as well. But जब जरूरत होता है, they start growing new granulation tissue. वहाँ new granulation tissue, you can see clinically आपको पता चलने लगता है ना, wound is getting better.
Any question? Thank you, sir. Thank you very much.
Thank you very much.
Our next topic is, by the invited talk, is periprosthetic fracture by Syed Imran Bukhari. Is he here? Okay, now for the free papers, we have Dr. Imran Khan Meher. The topic is closed interlocking intramedullary nail in a humerus shaft fracture, our clinical experience. Dr. Imran Khan Meher.
I'm a senior registrar in the Department of Orthopedic Surgery and Traumatology in the LUMS, Jamshoro. So today I'm going to share our clinical experience in the closed humeral shaft fractures that were treated by the closed intramedullary interlocking nail. So first of all, about 3 to 5% of all fractures are humeral shaft or humerus fractures. Previously, all the fractures of the humerus, they were treated by the conservative means. But nowadays, there is a growing interest to treat such fractures with either plating or intramedullary nailing to avoid the major complications like non-union, malunion, and the shoulder and elbow stiffness. Now, these two orthopedic surgeons, they have really changed the concept and revolutionized the concept in the orthopedics. Sir John Charnley and the Sarmiento. Now coming to the classification of the humerus. So there is an AO classification of the humerus shaft fractures, and in the AO classifications, we are basically confined to the humerus shaft, and we included the fractures, simple fractures like spiral, oblique, and the transverse fracture. They're included in this study. Our goal of treatment is to establish the union with acceptable alignment. Now, what are the advantages of the intramedullary fixation? Now, the intramedullary nails, they offer the biological and the mechanical advantages over the plates and the screws. An intramedullary nail can be inserted without direct fracture exposure. And they are minimizing the soft tissue scarring because the implant is closer to the mechanical axis than the plate, and they are subjected to smaller bending loads than the plates and less likely to be failed due to the fatigue. Now, intramedullary nail can act as a load-sharing device, and they have a cortical contact if the nail is not statically locked. Stress shielding with the cortical, like osteopenia, that is commonly seen in the plates and the screws, is minimizing with the intramedullary implants. Now the recent advantages in the nails, we have nowadays the biodegradable polymers and the nickel titanium shape modified alloys, and intramedullary nail also coated with the BMPs. Now this is the antegrade technique. So material and the methods of this study. The place of study is the Department of Orthopedic Surgery and Traumatology, LUMS, Jamshoro, Hyderabad. And the duration of study from February 2020 to July 2022. The number of patients, the study comprised of the 38 cases that admitted through the casualty as well as from the outpatient department of the LUMS University. And this type of the study is observational study. The inclusion criteria for these, all the means simple fractures, they are included, and the age is about 20 to 40 years of the patients, and fracture less than 2 weeks old. And the exclusion criteria, the cases were having with severe comorbidities or open fractures, and fractures more than 2 weeks old are excluded in. Now, the procedure, the complete routine lab investigations were carried out, and the selected cases underwent intramedullary interlocking nails, and after the treatment, the patients were discharged within a week. And the follow-up, initially, the patients were followed weekly for the 1 month or 4 times, and then fortnightly, and after that, the monthly follow-up up to the 6 months. And the data is also recorded, all the data is recorded. Now the results. Coming to the results, the total male patient in this study were the 26, that is about the 68.5%, and number of female patients were 12, that is about 31.5. Mean age is 35.4 plus 7.5 years. The commonest cause of humerus shaft fracture is the road traffic accident, that is about 21 patients. Then followed by the history of a fall, that is about 11 patients. and assault in 6 patients. And the result, the pattern of the fracture in this study, oblique fractures was 19, about 50% of the patients. Transverse fracture is in 11 patients, that is 29%. And spiral fractures in 8, that is 21%. And the postoperative pain severity, the mild pain in 24 patients, that is about 63%. Moderate pain in 10 patients, and severe pain is 4, that is about 10.5%. And the complication, the infection is only in 1 patient, non-union in 1, and severe impingement of the shoulder, that is in about 3 patients, 7.9%. And adhesive capsulitis is also about 2. In 2 patients, that is about 5.2%. And patient with implant failure, that is 1 patient, or 1 case. While no any iatrogenic palsy of the radial nerve was found in the study. So hospital stay is about from 1 to 5 days. Majority of the cases, about 29 patients, that is about 76.3% that were discharged between the first to 3 days. And then 18 patients, that is about 21%, were discharged between the 3 to 5 days, and only 1 case was found more than 5 days of a hospital stay. So now we have demographic variables. Again, the age, mean age, then gender, we have male 26 patients, female 12 patients. Mode of the injury, mostly road traffic accident in about 21 patients, then followed by the fall in 11 patients and assault in 6 patients. And infection, now coming to the postoperative complications. So infection only 1. There is no any iatrogenic nerve palsy. Implant failure in 1 patient, non-union in 1, and severe impingement in 3 cases, and adhesive capsulitis of the shoulder in the 2 patients. So regarding the hospital stay, again, 29 patients were having a stay of 1 to 3 days, and 3 to 5 days we have only 18 patients, and more than 5 days stay, there was just 1 case. So again, the pattern is oblique fracture in about 50% of patients, and 30% were having transverse fracture, and on 20% having a spiral fracture. So this is a postoperative pain, mild pain in 40, moderate 50%, and severe in 10%. So these are the diaphyseal humeral fractures and treated by closed intramedullary nailing. So our conclusion of this study is the humeral shaft fracture is the commonest in the young population, and road traffic accident is the most important contributing factor, and accident, motorcycle accident is the main causative factor. Our management through by the intramedullary nail is better techniques to treat the fracture humeral shaft because of the having following benefits, that it has a short hospital stay, and early return to the work, good functional outcome, and the complication rate is quite low. So these are references. Thank you, sir. Thank you very much.
Any question?
Thanks very much, Imran Khan. That was kind of very surprising result, presentation with very surprising result. I'm a shoulder and upper limb surgeon. I'm practicing in the West. To be honest, I would love these results to be presented in that part of the world. I'm involved in the design of one of the intramedullary nail. We call it X-Bolt. It's still in the process. That was just, I was kind of astonished that you guys have such few comments. As I said, I have this kind of disclosure to say that I'm involved in that. But so far, the literature, if you open the literature, the gold standard for humeral shaft fracture is the plate. It's not the nail. Second thing is that conservative management, despite the fact that I'm a shoulder and upper limb surgeon, is still non-operatively. I was wondering why you guys were operating all those trauma patients some of them, they could be easily managed non-operatively. And the other thing is that in UK, there are huge amount of research going on, ratio trial and other trial, multicentric trial, which are kind of working on the non-operative trial, and they have shown quite good, excellent results. And if you open the textbook, there are certain indications for nailing. I was surprised that you didn't touch on those. The last thing is that Pakistan is a resource-limited country, and I operate my shoulder and they go the next day home. I have yet to see a patient that is waiting for 5 days, and I was surprised that you were saying that that was a short stay. So upper limb trauma, I don't know why they were staying for 5 days, and if 5 days is a short stay, what would be the longest stay? And what were your indication for putting a nail in those patients? The classical indication for me would be pathological fracture, very obese patient, and patient who are moribund, they don't survive a bit longer operation, so I have to put a nail in 20 minutes. So what were your indication? And to be honest, I would be surprised if these results were kind of validated and they were presented in some other international conferences. Thank you very much. And I may just touch base with you on this because I would quote your paper for my export. Thank you.
Any question?
Hello. Excuse me, the humerus fracture, the doctor before, he was saying that it should not be operated. I don't agree that one. The humerus fracture we have seen, I'm practicing in the Chinook journals for the last 20 years. I've done a lot of trauma cases, fracture, humerus, everything, The nail is a better option than the plating. Plating is not a good option. I've seen being treated with plating, they have come with a radial nerve injuries. And I have many patients being treated from the hospital. They come for check, there is a radial nerve injury. So I think nail is a better option with minimum wound exposure and you do under C-arm. Now, I got a question that one. What do you think about humerus fracture, commited fracture, how will do? What about, can you put the nail if they commited fracture?
So actually in this study we have included only the simple fractures who are having either simple spiral fracture or the oblique or the transverse fracture. We have not included any comminuted fractures in this study. This is just for the study purpose we have conducted.
So spiral fracture, do you think can you hold it? The nail will not hold it. Nail will not hold it. Spiral fracture में nail कैसे hold करेगा? नहीं करेगा ना वो. How do you manage? No, better option I'm telling you. Yes, what I do there, अगर spiral fracture हम nail तो डालेंगे तो hold तो नहीं करें, fracture तो अलग हो जाएगा. What I do, nail डालने के बाद जो spiral fracture को खोलते हैं वहाँ पर, I put a circular wire. 2 जगह circular wire देते हैं, फिर अपनी जगह हो जाता है. This I do very commonly in that hospital. Okay? अगर comminuted fracture, if you want to do nail, you can do the nail, but वहाँ open the fracture or put a graft, bone graft डाल दें. There is still better option than the plating. I like interlocking nail than plating because I got a very good result there. Okay, thank you.
Any questions?
I have a question. If all those patients were given a choice or informed consent that the conservative management is there and you are subjecting them to nail, so were they given a choice or it was your choice?
No, sir. There is an informed consent regarding the the procedure. So this is basically in this study we have calculated all the patients with 38 patients. They have all having informed consent that we are going to operate by this method, and they have all patient they are agreed for this procedure.
For the cost of the operation, it was borne by the hospital or the patient?
Yes, sir, by the hospital, sir. Yes.
Any question? Dr. Imran, one more question. आपने कहा कि spiral fracture और उसमें आप जो nail डालें. What do you think? What was the reason for such a huge complication, impingement syndrome? Like you said, the impingement, that is 30% or 35%. Can you explain, is there any procedure default or what else?
ये हमने स्टडी जो है कंडक्ट की है इनिशियली जो है इससे पहले मतलब हमारे पास नहीं हुई तो हो सकता है सर इसमें ये है कि उसकी वजह से भी जो है मतलब प्रोसीजर की वजह से भी हो सकता है या फिर ये है कि कुछ पेशेंट जो है वो जैसे है कि अर्ली जो है मूवमेंट जो है स्टार्ट नहीं करते ड्यू टू द पेन या किसी और वजह से तो इट कुड बी द दिस इज द रीज़न फॉर दिस.
Okay, what is why you said the 5 days is a short stay, and why not is a long stay? But
ना सर बिल्कुल सर जो क्वेश्चन सरकार में मतलब सर ने पूछा तो ये है कि 5 डेज वैसे तो ये है कि जब हम मतलब ये ओपन करते हैं प्लेटिंग वगैरह करते हैं तो उसमें जाहिर है कि 1 या 2 ड्रेसिंग के बाद हम पेशेंट को भेजते हैं तो दिस इज़ बेसिकली मिनिमल जो है वो प्रोसीजर है लेकिन ये कुछ पेशेंट के उनकी जो है साइकोलॉजिकल मतलब ये कि पेशेंट को उनको थोड़ा मतलब करने के लिए तो 2 या 1 ड्रेसिंग या 2 ड्रेसिंग करके उनका पेन रिलीफ करके या ये कि एंटीबायोटिक्स के हिसाब से तो फिर हम जो है पेशेंट को.
Okay, thank you. Yeah. Sir, my question from you is, being a upper limb surgeon, you said that you are giving the chance for the conservative management for such cases. Why not the surgical? But you take 6 to 8 weeks for union over there, and
This is not, it's working, yeah. That's a very relevant question, and to be honest, I can't quote that it is me deciding that. The part of world where I'm practicing, I have to talk to my patient on the basis of research-based medicine. So as I said, in UK and US, there are huge multicentric trial going on. If you search it, ratio trial, and all those trials, they do recommend that you should give. So my colleague was saying that there was only there was no radial nerve injury. If you open the literature now on your mobile phone, the risk of, so it's not me, it's the literature saying that plate is superior than nailing. So far, the gold standard is plating. Second thing with the plating, there is up to 17% on average risk of radial nerve injury. So you are exposing the patient to 17% risk of their wrist drop. You are exposing them to infection. I'm a shoulder surgeon, violating rotator cuff, and for a trauma surgeon, it is difficult enough to repair the rotator cuff after putting that nail from the top. I totally agree. The impingement syndrome is even bigger in hands that are doing nail quite regularly. So that's not because of the procedure, it's the way the procedure is executed. So all these complications makes it a valid point to consider the non-operative option. And the non-operative option, yes, there are downside to that as well, prolonged like immobilization. But if you consider the ratio trial, they say that you put them in a brace for 6 weeks, and if the patient, the fracture site is mobile or painful by 6 weeks, the likelihood of non-union there is quite high. So that would be the time that you decide to operate. There is no point to keep the patient in brace for 6 months and then coming back and deciding that you are going to operate. So all those factors, higher complication rates in the safe hands. I have my own, like I have some 80 cases and I have 4 cases of permanent radial nerve injury. And in that part of the world, I can't say to my patient that it was God's will. I have to go there to the court and say that, yes, I have done it, and that is still those cases are going on. So because of that, I would still consider non-operative management until and unless there is clear-cut indication for open reduction and internal fixation. I have very limited indication for nailing. And my total practice of operatively managed humeral shaft fracture would be less than 5% managed with nails.
okay. Sir, one question. Yeah.
3 options have been discussed up till now: conservative, plating, and interlocking nail, which is antegrade. I want to ask from the whole audience, don't they have the experience of retrograde Ender's nail 2 or 3 snugly fitting Anders nail. They are working as good. But still, I will say that conservative management is the best management.
Any questions? Any experience regarding the Anderson nails? No, pediatrics, they are doing pediatrics, not in the adult age. Yeah.
To be honest, I would use them very few. And it was the time when I was practicing in Saudi Arabia and I have the liberty to use new things. I have used a couple of them. But to be honest, I would say I haven't seen the Anders nail or the Tan's nails and stuff like that for humeral shaft fracture. And there was a thing that spiral fracture, if indicated, I won't mind to put a nail in a spiral fracture as well, because it is not, you are not walking on your humerus. It's not a weight-bearing joint. The longer the fracture, the comminuted the fracture, if indicated, nail is the better option. So I'm surprised that for me, utterance fracture is an absolute nightmare to put a nail in. Technically difficult to heal, very, very high chances of non-union. If you have a comminuted fracture, long spiral fracture, I would be kind of confident to put a nail in, because that is one of the indications. If you are opening a bag of bone and piece of bone are there and you can't put a plate in. Either you do MIPO, which is not a very viable option. Some certain are talking about MIPO. I can't do it. But yes, nail would be my option if it is comminuted rather than a contraindication. Thank you.
Thank you, sir. For the next topic, Dr. Faraz, is he here? No. Okay, for the periprosthetic fracture, Syed Imran Bukhari. No. Dr. Hazrat Akbar, is he here for the next? Dr. Bilal Hassan, for the range of motion after 3 months follow-up across the wrist fix in distal radius comminuted fracture. Dr. Zegam Bajwa, for the outcome of the distal radius fracture management with a wrist external flexator vs buttress plate. Dr. Zegam Bajwa, is he here? No. Dr. Shujauddin, for the innovative methods of intervention, modified internal joint stabilizer elbow for acute and chronic elbow dislocations. Dr. Shahzeb, for a study of the neglected traumatic hip dislocation treated with the total hip arthroplasty, the journey from the miserable to the happy life. देखते हैं अभी आखिरी को फराज नहीं है अच्छा Sir, I understood. Okay, it's time for the conclusion. So. Sir, I request Professor P. Abdul Latif Saab, please come on the stage. For the invited speaking, I will request Captain Dr. Mohammad Iqbal Alam Saab, please come on the stage to receive your certificate. Captain Dr. Alam Iqbal. चले गए एक मिनट लेते चले गए Dr. Imran Khan Meher, please come on the stage. Sir. Thank you, Dr. Imran. For the panelist, Professor Maya Mohammad Amjad Saab, please, I request Sir Abdul Latif Saab to give a shield to our panelists. Maya Saab. Second shield for me, Dr. Siraj Ahmed Butt. Dr. Shahad Bhutto, please come on.
Bismillah. Now we are starting our second session. With me, panelist is Professor Akhtar Beg Saab and Professor Kashif Tebani. We have two invited talks. One is from Professor Badruddin Seto Saab. He is from Dow University of Health Sciences. And second one is Mohammed Irfan Yusuf. We will start from the free paper. So I am requesting Nida Hamid. His presentation is clinical and radiographic outcomes of the Fuller's plate and the proximal humerus fractures, our experience. Dr. Nida Rashid. Dr. Nida is at present in the spine sessions. She has also paper in the spine session. So now I am inviting Professor Badruddin Seto Saab for his invited talk, functional outcomes of the distal humerus intraarticular fractures using distal humerus anatomical locking plates. Professor Badruddin Seto, he is working as a chairman and head of department, Dow University of Health Sciences.
Bismillahirrahmanirrahim. First of all, I apologize because some of problem with my presentation. I should not waste my time because I lost it that I am making now. But I will try to present some of the concept of this distal humerus fractures and that we have treated with this distal humerus LCP. So Bismillahirrahmanirrahim. Sorry again for delay and some problem with my presentation. But I will try to cover some of this part of this extraarticular and intraarticular fracture of distal humerus. So treatment and management of distal humerus fracture is somehow very challenging and require careful monitoring and follow-up. And it's not that easy that you will straight away go inside and you will put some plate and come outside. I will show you some of the cases with the some good and some problematic results as well. So key is to your aim is to restore the anatomy and the articular congruity, and that we can achieve with दोबारा देखें that we can achieve with accurate and stable fixation. and that will help us in early mobilization and rehabilitation. So this is, AO people have key facts. They have told that if you go through the, this is the key problem, that if you have a stable fixation is very challenging. If you don't fix both the columns, there you have a problem, because they have a very limited bone stock, and patient have at a risk of comminution because less skin around this elbow as well. But sometimes in older age, bone is not that good enough. Even you put 2 plates, somehow you have failure of these plates around this elbow joint as well. So there are some key points elbow, this AO people have told. If you see this anatomy, you have at least 40 degrees of angulation and anterior side as compared to this diaphyseal angle. So we being a surgeon, we don't realize that distal humerus is slightly anteriorly tilted. And if you see this epi view, this triangle is not the symmetrical, is an asymmetrical triangle. If you see this lateral part is smaller as medial is bit higher. And this anatomy, you don't have any cavity in the distal 7 centimeter of the distal humerus. This is one of the most important factors. You have only thin rim of bone on both the sides. This is another way where you think about how to put the plate as well. And if you see this cut, this medial side is a triangular, okay, and this lateral is somehow this oval type, but not that clearly oval. So this so much variable anatomy around the distal humerus. Even you think you have to restore both the columns of distal humerus. So if you don't do it, I will show you what will happen. Even we did on one side, we have failure as well. So we did some intra-articular as well as extra-articular fractures, and within few years we did 73, because every day we are getting 100 plus patients in a single day emergency. So we may get at over 1 or half in 1 or 2 in a single week. So we use the Mio elbow performance score to assess this range of motion, and this is how we can do. But I will show you, most of the time, if I operate, 90% I do triceps sparing approach. Go posteriorly, hang the elbow at the 90 degree in lateral position, always skin open, identify the ulnar nerve first, the first step, and lift both the sides of the triceps. Only few patients I perform with olecraноstomy when I see there's intra-articular combination. Otherwise, I never prefer to go and do the osteotomy. I always try my best to go through the triceps sparing approach. So I will show you some of the cases. So this is one case. If you see, before few years, when we don't have a trauma center, we usually don't do the CT scan. But now in every patient we suspect intra-articular, always do CT scan. So if you see this is simple distal extra-articular, but it's not that simple if you see it. This is a low line, only your distal condyles are there. Once you open it, this line is going inside the joint as well. So this is distal intra-articular humerus fracture. And somehow there is a combination in this metaphyseal region as well. So sometimes we think to put 2 plates is somehow very easy. So sometimes we modify as well. So put 1 plate on one side, 1 screw at the articular surface, and see this medial side is absolutely comminuted. So if you put medial plate, so you need to put on the medial column as well. Then you have this 180 degree plating, or so 90-90 plating. But there's the problem. If you have a combination, you don't have a screw placement. Then you will failure. So when we see this stable fixation, you can achieve 1 or 2 screws, put this one as well. So this is another extra-articular distal humerus fracture. It's not that severe enough, but you see this absolute reduction and you can get good results. So this is another one with distal humerus fracture, all with distal humerus. But see, it's not that bone left behind. If you put some other implant, you don't have at least 3-4 screws in the distal segment. You can't purchase it. If you put simple plate, you only have 3 screws. Again, that was a problem with the failure. So your stable fixation is the key around the elbow joint, so that they have early range of motion. This patient present after 8 or 9 weeks, some sort of non-union around this fracture. But see, this, from here, this fracture is up to this area. So this we open from the posterior side, and we put this plate with the bone graft in this case. Another patient with the extra-articular combination. And this is few of my earlier cases. We see when initially plates come, we try to apply. See this posterior okay, but look at this medial side. This plate is not sitting here, and these two screws is not going to purchase on other side as well. So there is a problem. What will happen? And this later on, this patient develops the ulnar nerve palsy. Though fracture united, but later patient is having problem with this ulnar nerve. Now these plates usually we use when we are training, and even patients we see routinely people are applying. If you apply this plate, it's a pliable. It's not that stiff enough to hold the forces around the elbow. So this ultimately fail. So see this band here. So we remove it, just we apply with the bone graft and this all distal humerus LCP in one column. So this is again big challenge. If you apply the plate and distal humerus with osteoporosis, already failed 2 times, and you applied the plate, you come out, you say, I think it's absolutely brilliantly done, and later on you will see, I will show you in the end, this all plates will come out. So this is another challenge. So this is not necessary that every time you go inside and put some plates and you will get the good result. So you may need some elbow replacement in these kinds of patients. This is another patient, same plates. See this band here. And we applied this. But what will happen, if you see why I am saying 2 column, because we applied with careless everything, but see this somehow loose here within 7 months. And we revised it because of non-union. We applied 2 plates on both the columns with BMP and bone graft. Then we achieve the union and that's sufficient. Now this is problem with this osteoporosis. If you apply plates and don't fix both, it's failed, it come out. So this is one of the problem with these plates because they even don't have purchased an osteoporotic bones as well. And where to restore anatomy? These kinds of patients have, somebody have put some plates and nothing left behind. The young guy, this all comes out. Now look at the movement of this patient. Video चला लेंगे? मेरे पास चलेगी. इधर तो चल रही है. Now see, with this all failure, this movement is somehow good enough. Even I have seen patients with a 60-year female, nothing left in the bone, but their range of motion is absolutely normal. Sometimes we think even people with the old age don't need any fixation on the distal humerus patient. So this is basically the message. So where you need is there is a decision of the surgeon, and what you need to do is basically your stable fixation. If you think your stable fixation is not there, it means your surgery will fail. So I must conclude, anatomical distal humerus plating is a good tool, but is a key for the surgeon to know where to apply and how to apply as well. But in our studies, we see there's elbow stiffness is a common problem everybody encountered around the world. Sorry, because this is the second presentation I made. There are too many pictures I missed in my presentation. So thank you very much. Any question?
Should have some buttons in here. Okay, excellent talk.
Not working yet.
Yeah, it's good. Excellent presentation, Prof. They were challenging cases, and elbow, of course, as you said, is difficult anatomy, limited bone stock, and the idea behind fixation is to stabilize, to mobilize. So it's not that you put them in back slab and cast and keep them for 2-4 weeks. They get super stiff. It is a challenging procedure. No matter how much of an experience you have on your back, at times you would be stuck in a situation that that you would be spending hours. I do use the triceps split. I also keeping a very high threshold to cut down the olecranon. So, but yeah, a few things. The pre-control plate, they are very anatomical that we have it there. Somehow the plates that you were putting it, to me, they were not looking like so super anatomical that you would expect, or that what they were there. Were they like the old plate, or you have better option in terms of plate now available?
If you see there's anatomical plates contoured, there's somehow problem, especially on the medial side. In posterior side, it doesn't make any difference. If you apply the plate on the posterior column and lateral column, posterior side, there's not much problem because you have good bone stock on the posterior side. When you apply plate on the medial side, if you have a variable anatomy, you have to bend some of plate. Either you put first cortical screw, make the plate sit all over this column, and then you apply other screws. Sometimes we read sometimes there's no need to bend the locking plate because they are such a beautifully contoured that they sit by itself. But we see there's a lot of problem in making sit all this plate on the medial column. And there's no problem on the lateral side because we have plates that are not exactly AO. They come from this other company, they apply this SAN in Pakistan.
Well, yeah, rightly said. Even I'm using Santhis or SANs.
I've seen
they are
Santhis
not
plates.
anatomical
Even
as well.
With Santhis as well. I have seen Santhis people.
You need to have custom-made plate to put it 100% anatomical. If you do an X-rays, they would be kind of, especially the medial side plate, it would be off at some places. But yes, I would still agree, I would still go for the anatomical plates, no matter if it is got a little bit off the bone on the medial side. There is no way that you would keep your elbow in some sort of, you need to mobilize the elbow. But anyway, that was challenging cases, and I really appreciate the good work, hard work done.
Thank you.
Any other questions from the audience?
Very excellent talk. My point is, you said that Y plate, it doesn't work very good. To my experience, Y plates work very good. And the question why it failed in your case was you left almost 4 or 5 screws. So there was a lot of forces acting on that because the lever arm increases much. The local made Y plates, they sit very easily. They have got the very, very easy contouring, and the rehabilitation is very easy. And you don't need to apply with a double plate. So in my experience, Y plate, it does, serve the purpose.
So maybe it will be good in your hands because we seen these patients operated somewhere else and we have complication and we see there's even see problem with LCPs as well. It's not that LCPs are everything. But key is you should apply in a mode that you have achieved this stable fixation. This is basically the method. Thank you very much.
Thank you so much. Now, second invited talk is distal radial fractures in adults, 4 versus 6 weeks of the cast immobilization after closed reduction, a randomized control trial by Dr. Muhammad Irfan Yusuf. He's physically not present. He sent his video from the island.
आपके पास है?
Hi, a very good day to the President, respected delegates, and the participants of this 36th Annual Pakistan Orthopedic Association meeting. My name is Muhammad Irfan Yusuf. I am a trauma and orthoplasty consultant working at Cork University Hospital in Ireland. And I'm delighted to present my original research that got published in the summer of 2023. This is in relation to the distal radius fractures, which are being treated conservatively in the cast. We noticed in our clinical practice that the patients who were treated for lesser than 6 weeks were doing as good as those treated in 6 weeks. So we realized that probably there is no need to treat these patients for 6 weeks in the cast. So we decided to devise a research whereby after getting an ethical approval, we recruited 216 patients who had distal radius fractures, which were treated conservatively. However, after applying inclusion and exclusion criteria, we ended up having only 80 patients between January 2021 to December 2022. And we divided them into two groups. One group was treated for 4 weeks in the cast, and the other group was treated for 6 weeks in the cast. And we measured their functional outcome scores at 6 weeks, 3 months, 6 months, and at a year follow-up. And we realized that there was no statistically significant difference in the functional outcome in the two groups. So we concluded that we can safely discontinue the cast for these patients at 4 weeks rather than at 6 weeks' time. I'm going to share my original paper there. Just give me a second there. Share screen. And here we go. So that is my original paper. So as you can see, this was published in the European Journal of Trauma and Orthopedics. We had a total of 216 patients recruited. However, after applying inclusion and exclusion criteria, we ended up having only 80 patients. And as you can see, they were divided into 40 each group. One was treated for 6 weeks, other was treated for 4 weeks. And if I show you the results there, you can see the Quick-9 score at 1 year was 10.4 for the 4 weeks group versus 16.8 for the 6 weeks group with a p-value of 0.55. From this data, you can see patients who were treated for 4 weeks were actually doing better than, a little better than those for 6 weeks. Also, you can see the patient treated for 6 weeks had a higher chance of getting a CRPS. One patient got a CRPS in our group. So we concluded that all these patients with distal radius fractures should be treated conservatively in the cast for 4 weeks rather than in 6 weeks' time. This is a very safe practice, and there has been other studies similar to our studies, which are multicentric randomized controlled trial, and they had a similar conclusion at ours. So I would recommend that you should all treat distal radius fracture for 4 weeks in the cast rather than in 6 weeks' time, and at 4 weeks' time, we should mobilize them. Thank you very much.
Now, for free papers, we have the frequency of unsatisfied patients treated conservatively for the mid-shaft fractures, clavicle fractures, by Dr. Fahim Gori. Yeah.
Assalamu alaikum. Bismillahirrahmanirrahim. My name is Dr. Fahim Sultan Ghori, and I'm here to present a paper entitled Frequency of Unsatisfied Patients Treated Conservatively for Midshaft Clavicle Fractures. Over the years, clavicle has been treated successfully with non-operative measures, and operative treatment was reserved for a few individuals with limited indications. But recently, papers are coming in support of open reduction and internal fixation, and indications for surgical fixation have expanded after Canadian orthopedic trauma study in 2007, which has made cultural shifts towards surgical fixation. The COT study states that operative fixation of a displaced fracture of clavicle fracture results in improved functional outcome and lower rate of malunion and non-union compared with non-operative treatment at 1 year follow-up. Hardware removal remains the most common reason for repeat intervention in the operative group. This study supports primary plate fixation of completely displaced midshaft clavicle fractures in active adult patients. After this study, people started going towards operative intervention, and similarly, in a systemic review by Yan et al. In 2022, he stated that surgical intervention was associated with better clinical outcomes compared with non-surgical approach for midshaft fractures in terms of improvement in functional scores like DASH, time to union, and fracture-related complications, although not to the minimal clinically significant difference. Benefits in long-term functional improvements were more pronounced. Sassy et al. In 2022 stated that the rate of surgical treatment of clavicle fractures increased from 0 in 2008 to 10.8 in 2019 per 100,000 population. There was a rise in the rate of surgery from 2.6% in 2014 and 16 to 16.1% in 2017 to 2019. So we decided to determine the number of unsatisfied patients treated with non-surgical correction of mid-shaft clavicle fractures. This was a prospective cross-sectional study carried out at the Orthopedic Surgery Department of Jinnah Postgraduate Medical Center. 87 patients were included in the study. The inclusion criteria included patients from age 15 to 65 years who received conservative treatment for a duration of 3 months, closed fractures, Alman Group 1 classified as Alman Group 1. Exclusion criteria included open fractures, polytraumatic with multiple bone fractures and injury to vital organs, old clavicle fractures, and patients lesser than 15 and older than 65 years. Patients were comprehensively explained and counseled regarding the purpose, risks, benefits, and potential complications associated with the non-operative treatment of clavicle fractures. Following fracture reduction, triangular brace or a figure-of-8 bandage was applied and the limb was supported by a triangular sling. This was given for a total of 6 weeks. Patients were informed that minimal deformity of the shoulder girdle might occur at the end of treatment, but overall shoulder function would remain normal. Shoulder movements such as pendulum exercises would commence afterwards. Contact sports and heavy lifting were prohibited for 12 weeks. Follow-up examinations were done at 6 and 12 weeks. At each follow-up, X-rays were taken. Tailored rehabilitation was done. Patients were advised to follow up for 12 weeks in total. DASH score was used to assess the outcome. DASH is a 30-item score that is scored from 1 to 5 with a total score of 100. And demographic data and acceptable outcomes were recorded in the preformed performer. SPSS 23.0 was utilized for data analysis. Standard deviation and mean age were calculated for age and DASH scores. Gender, diabetes, hypertension, and satisfactory outcome was expressed as percentages and frequencies. So results, among 87 patients, 16 patients were only there who were not satisfied with the treatment outcome, and while 71 patients expressed satisfactory outcome. Regarding the frequency of outcome, 17.24% patients achieved an excellent outcome. 55 patients had an outcome that was good. A fair outcome was reported in 12 patients, and only 5 patients had a poor outcome with non-surgical treatment of mid-shaft clavicle fractures. These are the statistics of age. The mean age was 38.20, standard deviation is 7.82. The minimum age was 20 years, and the maximum age included was 50 years. Patients from 20 to 35 years, only 5 patients were unsatisfied, while 26 patients were satisfied. And patients from 36 to 50 years, 45 patients were satisfied, and only 11 patients were not satisfied. Gender specific, 51 males were satisfied with the treatment, and 20 females were satisfied, and only 4 females were not satisfied. Historically, the standard approach for clavicle fractures has been non-surgical, as we discussed. However, recent studies have challenged this strategy, particularly in cases of mid-shaft fractures. So non-optimal treatment approach for clavicle fractures is found in the literature, and the decision to employ conservative or surgical decision remains a subject of debate. Factors such as the severity of injury, comminution, high impact trauma, involvement of dominant part, age, athletic demands, and patient preference all play a role in deciding the appropriate treatment. Our study shows a dissatisfaction rate of 18.39%, which aligns with Di Giorgi et al., who had a dissatisfaction rate of 28.2%, while Posticini et al. Found 20% dissatisfaction rate after conservative treatment. Subramaniam et al. Suggested that clavicular brace management should be the first-line approach in skeletally mature patients for displaced mid-shaft fractures, provided that the intent is to achieve a good or better outcome as per the constant score. So to conclude, conservative management of mid-shaft fractures has good outcomes and associated with a higher rate of patient satisfaction. In the present study, only 18.39% of patients were not satisfied by the results of conservative management of mid-shaft fractures. These are my relevant references. Thank you.
Any questions?
We did not fix them, sir.
My experience is that almost all patients are unsatisfied initially when they see overlapping in the X-ray. But later on, when they are united, their outcome of functional outcome of shoulder is very good, rather excellent. They are satisfied then.
Yes, sir.
I have experienced 7 non-unions of clavicle. They were invited for the internal fixation, but 6 of them refused that we have satisfactory functional outcome. We don't need any surgery. Only one patient I treated at Mayo Hospital, Lahore, by plating. Otherwise, all patients are satisfied later on, not initially.
Yes, sir. Totally agreed with you.
I think that we should have an open mind when you're dealing with these fractures. Patients who are sporty and doing sports activity, you should fix them, because with shortening of the length of the clavicle, power of the shoulder is reduced. So you should not have a fixed idea that we don't need to fix them. People who are active, who are playing and who are competing in national or international level, they should all be fixed. And there is no harm in fixing. It's a simple procedure. It's a very easy thing to do. And now with new plates, it's very easy to fix them. And the results are also very good. Yes, we don't need to operate on everybody, but people who are active, who are doing sports and are and want a very strong shoulder, they should all be fixed. Like cricket is so common in our country. People play them at local levels and national and international level. They should be fixed. Otherwise, they will have a weak shoulder, and like a bowler will not be able to perform very well without fixation, because of the length is lost and the power of the shoulder is reduced by about 20-25%. Thank you.
Thank you.
Thank you so much.
Whenever you go outside, everybody is fixing clavicle, and every clavicle is fixed. And we have some other problems. I have seen patients having LCPs. Their LCPs are exposed because only little skin is applied. If you don't apply appropriate approach, you will have trouble in this area, because such a difficult area to operate on. Below this is the main neurovascular bundle line. In Mayo Clinic in USA, they mentioned that they put some plate and somebody put the bit inside and they go into the lung, patient died. So it's not an area that you will straight away go and you will come and you will put the plate, there's nothing wrong. It's a place where you should be careful when you operate on. Exactly. So it's basically, that's basically the message. If you want to operate on the clavicle, you should have enough skill to operate on. It's not just easy to, you will go and apply plate. We have seen the patient applied both sides clavicle plates, and 1 year after they want to come for the implant, the removal. We remove the plate and percutaneous way, one side there was non-union after 1 year. And both plates removed, one side was moving. So this is something you can't expect. In a clavicle, after 1 year, you have plate and a non-union.
It can happen. You see, you know about non-unions. Any bone can go into non. When you're doing surgery, you strip the periosteum badly, then it is going to go into non-union. So it depends on the surgeon. If he's not experienced enough, he strips everything off, then it's going to go into non-union. So it's,
sir,
it's the technique, I think.
All are
it is the
sitting here,
technique which is important, but you've been there in Europe, everybody is fixing them. They're using a simple mobile nails to fix them. But that's what I was saying. Choose the right way. Don't have a 100% fixed idea that I'm not going to fix them. You should choose the right patient. People who need to be active, who want to do sports, who want to have a very strong shoulder, they should all be fixed, I think. They should be given a chance. Why do you want to not give them a chance?
We should do multi-center studies, because too many people sitting here, everybody is managing conservative.
I think both are right. Both are the groups. There are certain indication and expertise as well. And I have faced many, as per indication, a butterfly fragment, comminuted fragment, grossly displaced fractures. Fix it proper way, and you will not find any non-union exactly if you are not stripping the inferior periosteum and the posterior periosteum. The complication is with every surgery. There's no problem. So it is very right to have a multi-centric study in Pakistan, and you can get a good outcome of this paper. But bluntly say, I will not operate, is not so. Because of the lever arm effect, because of the short net, because of the cosmetic, because of the broad thick after the conservative Republican. So there is indications and expertise, both has to be tailored. Thank you.
Thank you so much, sir. Now the second is Nimra Rashid, functional outcome of the radial head fractures when treated with open reduction and internal fixation, our experience. Nimra Rashid. Functional outcome of open reduction and internal fixations of the radial head fractures by Dr. Ghazanfar Ali Shah. Yes, sir. GHR Junior. He is from Trauma Center, I think so. Mayer's procedure for the grade 1 and 2 AVN avascular necrosis in the delayed femoral neck fractures, retrospective study by Dr. Mohammad Mozammil. Clinical and radiographic outcomes of the phyllodes plate and proximal humeral fractures, our experience by Dr. Nida Hamid. To evaluate the outcome of AO external fixators for the management of grade 3A and B open tubal fractures by Dr. Allah Nawaz Abbasi. No? वो नवाब शाह का है सर, अब तो नवाब शाह नहीं जा सकता. Now I request Professor Akhtar Beg Saab to comment and conclude the sessions as a panelist.
लिमिटेड लोगों की प्रेजेंटेशन थी. मैं सबसे पहले तो मैं बदर की जो प्रेजेंटेशन की बात करूँगा. बदर इज़ ऑलवेज, जब भी कभी भी आते हैं प्रेजेंटेशन के लिए तो उनकी तैयारी बहुत कंप्लीट हुई. आज थोड़ी सी इनकम्प्लीट थी, लेकिन फिर प्रेजेंटेशन वाज गुड. ऑस्ट्रोटोमी की बात उन्होंने ज़रा कम की, लेकिन बहरहाल हम ऑस्ट्रोटोमी करते हैं जहाँ इंट्राआर्टिकुलर फ्रैक्चर होता है और वहाँ पर रिजल्ट थोड़े से कंप्रोमाइजिंग होते हैं, थोड़ी सी लिमिटेशन ऑफ मूवमेंट ज़रूर होती है. फिर ये क्लेविकल फ्रैक्चर की बात हो रही थी. जहाँ तक मेरा अपना पर्सनल एक्सपीरियंस, जब भी मैंने कभी भी किसी पेशेंट और किसी और के ऑपरेटेड क्लेविकल फ्रैक्चर देखे हैं, दे आर ऑलवेज इन नॉन यूनियन. हाँ, अनीस की बात सही है कि जी जहाँ इंडिकेशन हो वहाँ ऑपरेट करना चाहिए और सर्जन मस्ट बी वेल इक्विप्ड. इंस्ट्रूमेंट के हवाले से भी इक्विप्ड होना चाहिए और अपनी सर्जिकल स्किल के हवाले से इक्विप्ड होना चाहिए बिफोर ही डिसाइड फॉर सर्जरी. नॉट एवरी पेशेंट फॉर क्लेविकल फ्रैक्चर शुड बी फिक्स्ड. कंजर्वेटिव ट्रीटमेंट का आज भी जो है रोल है और आइंदा भी रोल रहेगा. लेकिन हाँ, जहाँ जहाँ पर इंडिकेशन बनती है, जहाँ हमारे ऐसे एथलीट हैं जिनको इंटरनेशनली कम्पीट करना है, उनकी सर्जरी होनी चाहिए. आई थिंक इट्स ए गुड सेशन. ओवरऑल इट्स ए गुड सेशन. थैंक यू वेरी मच.
Any comments from Professor Kashif Debani Sahab? He is also a panelist.
Thank you, Dr. Isha. Basically, basic principles अगर आप follow करेंगे तो आपकी सर्जरी बहुत आसान हो जाएगी. Orthopedics is a locomotion. आप अगर basic principle को follow कर रहे हैं कि anatomical reduction कर रहे हैं,
One present, Dr. Nida is here. She was initially in the spine session, so that's why she's a little bit late. Her presentation is on clinical and radiographic outcomes of the phyllodes plate and proximal humerus fractures. Dr. Nida Hamid.
Assalamu alaikum and good morning, everyone. So my topic of presentation is clinical and radiographic outcomes of Philosopher's plate in proximal humerus fracture, our experience. Proximal humerus fractures account for about 5% of fractures and are the third most common fracture due to osteoporosis. The treatment of these fractures is still much debated. Each case must be assessed individually because the sole classification of the fracture is not enough to establish a treatment. And the gold standard for 3 or 4-part proximal humerus fractures, according to NIRS classification, is the use of open reduction and internal fixation with plates and screws. So while non-surgical treatment may yield favorable results in majority of proximal humerus fractures, yet surgical intervention is frequently warranted in some of cases of the unstable proximal humerus fractures. And the aim should be to restore shoulder function and bone union with good alignment. Some other parameters which can influence or affect the proximal humerus fractures are age, pre-existing conditions, functional demands of the patients, quality of the bone, rotator cuff function, and also integrity of the vascular system to estimate risk of AVN. So Philosopher's plate is a fixed angle device which prevents subsidence in the metaphyseal areas. There are still issues with Philosopher's plate which are limitation of the range of movement and subacromial impingement, avascular necrosis, loosening of the screws, and articular penetration, also varus fixation or loose fixation afterwards, and non-union. We should know where is the problem, whether it is the poor surgical technique, it can be improper implant positioning, or failure of the accurate intraoperative assessment of reduction and screw length. Our objective in this study was to evaluate the effectiveness of Philosopher's plate fixation in the treatment of proximal humerus fractures within our local patient population, focusing on functional outcomes and patient satisfaction. So this study was a retrospective study which was done at the LUMS Jamshoro from January 2021 to December 2022. Patient with age of 40 to 80 years of either sex were included. Patient with displaced 3 and 4 part proximal humerus fractures with or without dislocation, and patient with at least clinical and radiological follow-up of 6 months were included in our study, while patient who had no radiological or clinical follow-ups, who had open, neglected, pathological or ipsilateral fractures were not included in our study. We utilized a deltopectoral approach in all patients. Polysling was applied, and post-operative radiographics with a 6-week intervals were taken to assess the maintenance of reduction, loss of fixation, and fracture union. Functional outcomes were assessed using a constant Mulde scoring system, and the data were collected and analyzed using SPSS system, and we used chi-square and t-test, and the p-value of less than 0.05 was significant. So results, coming to results, majority of our patients were female, which was around 62.5%, and their age was, majority patient age was from 60 to 80 years. The mechanism of trauma in majority of patients was fall, history of fall, which was 80%, and most of the fractures were 4-part fractures, followed by 3-part fractures. Infection rate in the patient were 7.5%, and where there was also a varus malunion, which was around 15%. Even of humeral head was there, which account for around 5%, and plate impingement was present in 15% of the patients. There was also shoulder stiffness, and which was 57.5%, and screw penetration was 10%. Implant loosening was there, which was around 25%, and to consider the functional outcomes, 12.5% patients fall in a very good functional outcomes category, followed by 27.5% of good, and 42.5% patient fall in the fair outcomes, functional outcomes category. So coming to result, there was statistically significant correlation between the infection and varus malunion. Let's come to the discussion. Operative treatment. of comminuted and displaced proximal humerus fractures, especially in osteoporotic bone, has been a complex and challenging problem. Different techniques have been described for fixation of comminuted and displaced proximal humerus fractures. Varying rate of complications such as cutout or breakout of the screws and plates, non-union avascular necrosis, and fractures distal to the plate. Okay. Application of locking plate technology for proximal humerus fractures has a steep learning curve, and appropriate surgical technique is very important to achieve good functional outcomes. Based on our observations, inadequate positioning of the implant resulted in reduced functional outcome. Hence, to improve functional results, we consider plate positioning to be of utmost importance while using flows plate fixation. Management of proximal humerus fracture is still a challenging and controversial task due to different personalities of fractures and variable bone quality, especially in elderly population. The use of flows plate in proximal humerus fractures appears to be promising a treatment option with good outcomes if applied correctly with correct indications. Thank you so much.
Any questions?
Any questions? No questions?
Thank you, Dr. Nida.
Thank you so much.
Now I request Professor Anis Bhatti Saab and Professor Akhtar Beg Saab, Professor Kashif Tebani for the distribution of certificate and seats among the participants and panelists. Now for certificate distributions, I am requested Professor Badruddin Sato Saab come forward and receive his certificate. Dr. Fahim Gori. Dr. Nida. I think so she left the hall. Now I request Professor Akhtar Beg Saab to receive his shield as a panelist from Anis Bhatti Saab. For shield, Dr. Nida Hamid. Certificate for Dr. Nida. For shields, Professor Akhtar Beg Saab, he is our panelist. Kathan. For Professor Ayub Lagari Saab, I request Dr. Anwar ul Haq to receive a shield of Professor Ayub Lagari Saab. Dr. Anwar ul Haq. Professor Kashif Tebani. Professor Kashif Tebani. Dr. Zahur Ilahi Sumro. And last, for me, Dr. Shad as a moderator. Thank you so much. Thank you so much.
Someone's किसकी है ये USB? Next session is I think at 11. क्या ख्याल है? 11 बजे है ना?
Check 1, 2, 3. Low mic check test. 1, 2, 2.
इनको ये टेबल
बिस्मिल्लाह करना, मैंने तो अपनी टॉक करनी है ना।
पहले तो मैंने इनको बुलाना है, प्रोफेसर जे चौमिया को।
मैं नहीं जानता हूँ।
Assalamu alaikum. We're going to start the session now, and I'm going to invite Professor J. Chomiak for his presentation on MSK screening protocols and its benefits. The session consists of panelists Professor Ghulam Mehboob, Professor Shahid Ilyas, Professor Abdul Rahman Sheikh, Mr. Guy Vansborough, Professor Nair Qayyum, and the moderators are Dr. Tahir and Dr. Shakir Saeed.
Good morning. So allow me to talk the last my talk, musculoskeletal screening protocol and its benefit. Again, I'm from Prague, Czech Republic, and I can divide it into 4 parts. First, it's the prenatal screening. We use not we, but gynecologists use the ultrasound screening in first trimester. Then between the 18 and 22nd weeks for the congenital anomalies, like for us it is important the length of the femur, and third is between 30 and 32nd weeks. Again, congenital and developmental disturbance, like for example the clubfoot. Clubfoot is possible to diagnose before the delivery, and explain after then explain to the parents what will be after the delivery. Then the pediatrician used the laboratory screening. It is the alpha fetoprotein between the 16 and 18 weeks of pregnancy, choreogonadotrophin and estriol, and if it is something suspicion, they make the amniocentesis. Then we have the postnatal screening. First, immediately after the delivery, they make the test for spinal muscular atrophy. It is very simple, simple test, and then we start with therapy of spinal muscular atrophy. And of course, they follow also the other metabolic diseases. For us, for the orthopedics, we have 2 more screenings. First is the DDH screening. Why? Because in our country, historically, it was the high epidemiology of DDH. Between 50s and 60s, it was till 15% of newborns had some degree of DDH. And so we were the country with endemic DDH in Europe, and for example, the Germans say it is the Bohemian hip, DDH hip. So, but after then, it was clear that the similar numbers are in Austria, Germany, Italy, Poland, former Yugoslavia, but in Anglo-American states, it was incidence under the 3%. So there, the former generation of orthopedic surgeon enforced the target screening for detection of DDH, namely in form of 3 consecutive controls. And this was after that was the law in Minister of Health in 1977. So screening was later modified according to the sonographic examination was published as follows. The first examination is in maternity hospital between 3rd and 5th day. We make the clinical examination, and if is it possible, if it has the good probe, so linear probe, we make also the ultrasonography. The second examination, every child is sent by pediatrician to the orthopedics clinic, or outpatient or hospital. Between 6 and 9 weeks, we make the clinical and ultrasound diagnosis. And third examination, between 12 and 16th week, we make the clinical ultrasound and eventually X-ray. X-ray only exceptionally if we have really pathological found. So another one. So we don't make the X-ray routinely. This has the effect with dramatical decrease of incidence of DDH also in our country. What is the advantages in this screening? Screening is completely covered by the health insurance. Every orthopedic department or outpatient clinic in our country provides ultrasound screening and clinical examination. And orthopedic surgeon provides this screening because they immediately start with the treatment without any delay. And because it is a law, the parents accept this screening program, and this is no problem to screen practically 99% of children, I will say. How we organize it? We organize the education of orthopedic surgeons. We regularly we regularly provide the teaching courses. There are 2 to 3 courses per year since 1999. My clinic make this courses for all country, but we are a small country and we have together about 800 orthopedic surgeons. And it is the 2 days interactive course with theoretical part, practical part, exam, and after then the certificate to provide ultrasound screening in pediatric hips. Why we should make this the screening early? So it is very important to start in newborns after delivery because we follow the risk factors. They are worldwide accepted: congenital anomalies, contractures, positive family history, and breech position and delivery. I mean, it is well known. Then clinical examination, I mean, it is also well known, the abduction test, limited or asymmetrical. Then the Barlow test, of course, I am sure that all know this test. Then the Ortolani reduction maneuver, again, very well known. And what we know that at age of 3 months, this test could be negative, but we see the limited abduction, asymmetry of gluteal and femoral folds, and knees in different level, the Bettman or Galeazzi sign, if it is the dislocated hip. Hip sonography is currently imaging method of choice for diagnosis and follow-up DDH. We use the static technique according to graph because it offers quantification of bony and cartilaginous roof in relation to the age of baby, because the hip maturates during the growth. We started with this ultrasound in 1985 because Professor Dungel, my former chief, was in this time in Austria. I met Professor Graf, it is on the picture, and took this technique to the Czech Republic, and we started with it, and we can see that really we reduced also the numbers of the treated children till 3%. We have, of course, we have the very low natality, 100,000 per year, so it is not dramatical like here in Pakistan. But dislocation is about 101 to 115% per year, really dislocation. Why sonography of the hip in detection in early age? Because clinical examination cannot obtain acetabular dysplasia and needs experience and skill. Neonatal hip composed primarily from cartilage, so it is difficult to image with the standard radiological techniques. development of the hip is very rapid till 3 months. I will show you later. And this screening significantly reduced the rate of conservative treatment, and we can see also the over-treatment. According to the Austria experience, it was the 12% in 12% of DDH treated in 1999, and then after 1 year of implementation of this technique, it was only 6%, and later also the 3%. And it significantly reduced the rate of operative treatment of DDH. The same in Austria, Germany, and also in our country. It means it brings also the cost benefit, this screening. Why we use this static technique according to graph? Because it enables the exact classification of every hip joint according to age, enables the proper treatment of each hip, and method is not static because we use also this dynamic stress test according to graph. We publish it later. And I know also from my experience from Posna, Ottawa 2005, Graf and Harkey in USA, they made a consensus of both methods. Both methods are possible to use. So we have this small tool to classify all hip according to graph, and it is very practical, and every medical doctor making the ultrasound use this small tool. Why so early? Because you can see the alpha angle. It is the angle between the baseline and bone roof. It matures very quickly till 3 months, and after then it slows down. So 3 months, 64 degrees, but in 1 year only 66 degrees. So till 3 months, it is really very important to make the sonography. So it means also it is important for early treatment. If we start the treatment as soon as possible, it will be better for the child because we will achieve the maturation of the hip very good. So after then we follow up every dysplastic hip to avoid the residual dysplasia. We recommend the controls, and 12 months it is possible to make the ultrasonography. With the last possibility, after then it is not good, not possible to really say how is the maturation of the hip. Then between 18 and 24 months, we make the X-ray because it is the decrease of acetabular growth. We know it also. Then we make the one control before the school age attendance to say the child is okay and needs nothing for the behavior. It can behave like the other children. And then last control is in adolescents between 15 and 16 years, because we know in this age they are also the accessory ossification center of the acetabulum, and they could be also not present or damaged with the treatment. So, and if we see the AC angle over 25 degrees in preschool age, we offer the parents the surgical treatment of acetabular dysplasia. First of all, the Solter osteotomy. In the residual dysplasia, we follow all known X-ray symptoms. It is the roof AC angle, lateralization, Shenton line, valgus and anteversion of the femoral neck, and we know that residual dysplasia or subluxation both are the pre-arthrosis. So I mean, it is not necessary to explain it. Also, we see the migration index, tennis angle, crossover sign according to Reynolds to see if is it not femoroacetabular impingement before eventual surgery. And if we have the residual dysplasia, we follow also MRI because there are often this rupture of the labrum or labral cyst, and it is also painful. Okay, so it was the DDH. Now the fourth one is cerebral palsy. It was yesterday spoke by Professor Inan. We know that incidence of instability and severity varies according to neurological impairment, ability to walk, and we know that hemiplegic and ambulatory patients, they have only the dysplasia or subluxation without progression to dislocation mainly, but diplegic, quadriplegic, and non-ambulatory patients, they have very high risk of hip dislocation up to 90%, like in this patient on the picture below. So it is the pathogenesis of the hip subluxation due to the muscle imbalance. You can see first the subluxation, then the dislocation of the hip with the changes on the femoral head, of course. So I hope you know it, the pain, sitting problems, hygiene, and limited range of movement. So what do you make in our country? We know that these patients have the higher risk for dislocation between 2 and 6 years. So we screen the hips according to rank. We use the rank classification on rank recommendation. Examine the spastic hips every 6 months to age of 8 years. And if we see the hip abduction under the 45 degrees, we say it is the hip at risk, and we make the X-ray examination. If it is no subluxation, no progression, we observe the hip in 6 months period, but we don't treat it. If we see the progression of subluxation, we go to the surgical treatment. Of course, we use different tests. So flexion, we see the flexion contracture, abduction, and internal rotation more than external rotation. This is a clinical exam. We use all clinical tests like Thomas test, Taheli, Eli test, black popliteal angle, and for the ankle, the silver scale test. I mean, these tests are well known. We use the plain radiographs. It was also discussed yesterday by Professor Inan. We divide the dysplastic hips, normal hip, dysplastic hip, subluxed hip. We follow, of course, this migration index according to Reimers, and I mean it is also well known. We should consider also other factors. GMFS grade and physiological classification, if is it a pure spasticity, dystonia, ataxia, or mixed form. What is with the spine? I mean, it is the question what we should correct first, if spine or hips. We discuss with our spine surgeon. We should corrigate the pelvic obliquity. We should know how is it if anterior pelvic tilt or sacrofemoral angle, location of acetabular dysplasia, because sometimes there are also the anterior dislocation like in this girl, and it is always necessary to know it before the surgery. So let me conclude. Screening of DDH. Hip sonography is responsible for diagnosis, but also for the therapy and prognosis. And Graf found that the early diagnosis of dysplastic or decentered hips leads to reduction of the surgical therapy, the 1024 to 1,000 babies, and it is the lowest rate which ever was reported. Late operations are reduced to 25%. Cost of treatment had been reduced, inclusively screening cost, to 1/3. It is also very important. So to use the hip sonography represents one of the most effective prevention program in the orthopedics, we can say. And in neurologic hip instability, it is also useful to use it in hip at risk because it is major probability to subluxation or dislocation with problems at reduced range of movement, sitting balance, problems with hygiene, pressure, skin ulceration, arthritis could be or not, could be painful or not, but pain is very often in dislocated hip. And we know that salvage procedures in adult age are limited and sometimes disappointing. It was the very intelligent patient with painful subluxation. We made total hip prosthesis 2009, and you see the migration of the acetabular part because of muscle imbalance. So it is now very difficult to treat it. So thank you very much for your kind attention and kind hospitality here in Karachi. Thank you.
So it was a nice talk. So are there any questions from the audience regarding the screening?
Thank you, Yuri. I just comment because according to the graph and hierarchy, if you have a stable hip, you don't need the follow-up.
Yes,
but the
true.
literature comes, there is a residual dysplasia if you have a more than 60 degrees of the graph angle or alpha angle is not safe. You have to follow and we have to control it again. The second thing is in the last paper said that 55 degrees of the alpha angle is the safe to control it. But according to the DAS paper, more than 10%, there is a residual dysplasia again. I think that's the question is, for the screening program, we had to change something according to our finding. And this is the group of the problem is the regional problems. If the population is too big or large number of the babies coming, national screening program is not possible, like a Turkey, we have not, because we just following the risky babies. Then for here, that's you suggest the 12 months, every kid has to be controlled, and I think that's your program.
Yes, it is. If we treat the hip, we follow the hip. If it is even, it will be 2B hip, for example, we follow it because we know it's about 30% can have the acetabular dysplasia later. We treat the children first very good. We have the concentric hip. We have the graph A after the 6 months, but we follow it till according to 12 months the ultrasound, and then before the school age to see how it is the development of the acetabulum. If good, it's good. But after then, we make the last control in adolescent to really say, okay, the adolescent girl or boy are perfect and can live normal life. Yep. There was one.
May I ask a question? Thank you for a lovely talk. Obviously, we in the UK only aspire to having a universal screening program, and it would be ideal, and your population allows that. What I'm interested in is, you said in the first assessment up to 72 hours, if a probe is available, they'll get an ultrasound. So that leads me to ask 2 questions. One, who would be doing that ultrasound? Will it be someone who is trained in the graph technique? And number 2, would the first potential ultrasound be performed by someone trained in the graph technique? And secondly, if there is no ultrasound done then the first ultrasound is going to, that the child will have is between 6 and 9 weeks. Is that correct?
Very good question, thank you. So mainly we have no linear probe, so we cannot make the ultrasound if we have no linear probe. But otherwise, experienced orthopedic surgeon come to the maternity hospital and make it. If not, then it is recommendation of the pediatrician to send the baby till. So I will say mostly after 3 weeks to the orthopedic department, and then we make the first control. Yeah, we postpone this first control, but because you can imagine the situation. Delivery is on Friday, and on Monday they go home. So we have no chance to see a lot of children. Yeah.
I understand. I was just worried about the potential delay for 6 to 9 weeks before the first scan, but you've allayed that. Thank you.
So, yeah, I mean the 3 weeks is, 2 or 3 weeks are also ideal to make it the first examination. Another question? Okay.
Sorry for that, but that's the concern is before the 1 month,
Yeah.
if you screen these babies, you have many false positive results because of the immature hip.
Yes, we know it.
But the first month, if you have, because we have the insufficient source for doing the ultrasound, there is no enough people doing that. If you do first month, if it is not dysplastic, that means it's not dysplastic, but it is normal. That's okay.
Yes, it is. But if you see the dislocation or unstable hip in first examination, you start immediately with a treatment with abduction. Yes, with some type of abduction.
The problem is when you call the babies back for the screening. For the Turkey, this is the first month, 4 weeks to 6 weeks, not more. That's the Turkish rules.
Yeah.
If you discharge the baby to home, they have to come back at the first month, at the 4th week, for the screening program.
Yeah,
That's
I agree.
But not before that.
I agree with you. So it's important to make this control.
Can I just add to this in regards to your question in England? You know, I can recall from 2010 training, we used to have a radiology consultant and an orthopedic surgeon combined during a clinic where they will assess these babies usually around 4 to 6 weeks time, not too obviously early given the scenarios in England, national screening type program. So that's something I don't know if recently is being practiced or.
It's highly variable. What universally does not happen is a universal screening program. What does happen is a day 1, what's called an NIPE examination, which should lead to, if there's any abnormality suspected or detected, to an orthopedic clinic. And at that clinic, it may be staffed by physiotherapists and an ultrasonographer, or a radiologist and an orthopedic surgeon. It's very variable. And if the patient is born with risk factors, but a negative examination at day 1, they go for a simple ultrasound scan without any other clinical assessment.
Professor? You have no? Okay.
Thank you very much.
Thank you.
Now I'm going to introduce the next speaker, Dr. Shakir Saeed. He is a radiology musculoskeletal consultant at Wrightington Hospital, and he's going to deliver a talk on radiographic evaluation following hip arthroplasty.
Good afternoon, everyone. My name is Shakir Saeed, and I work in Wrightington Hospital in United Kingdom, which is the birthplace for Charnley hip replacement, if somebody don't know. I have nothing to disclosure in regards to my presentation. It's more educational here. So the learning object of this topic is to see how the normal or acceptable appearances are following hip prosthesis, especially for the orthopedic trainees and consultant here. As we can see in Pakistan, there's lots of arthroplasty is being done, Unfortunately, I think so the follow-up here is totally different to what we practice in United Kingdom. It's quite variable. So I thought it would be a nice topic where some trainees and colleagues can go through some basics and see how to proceed from there. Abnormal appearances and complication, and then role of plain films in management. I'm not here to teach you about the components or implants because you are more knowledgeable for what the components are, but this is just a snapshot of, you can have hemiarthroplasties, total hip replacements, bearing surfaces of different types such as ceramic on poly, ceramic on ceramic, metal on metal, which again in England is quite a common theme, and quite a lot of patient population are being screened for them, especially in regards to their ALVAL or ATLR kind of complications. Component fixation, again cemented or uncemented depending on individuals and practice. Common language to speak, especially in musculoskeletal radiology. When we talk to our or report for our orthopedic surgeons, we usually try to stick to these common knowledge where we can talk and they know which areas we are talking about and what we are seeing, such as acetabular Deely-Chanley zones and Gruen zones, most of you would be aware of. Limb lengths, again, these days it's more common practice to have a CT scanograms where which all those are measurements done for us, especially we hardly do them on plain films any. Lateral cup opening angles, which again most of you know whether it is open or closed, depending on which may make it prone to dislocations, as you can see in this example. Again, normal appearances on lateral and AP images of the femoral stem where it should be aligned normally at the time of operation to look for. Again, you can see here a tilt on the distal stem where it's touching the lateral cortex. Component fixation, how well the prosthesis is fixed. Is there any spectrum of findings? Is it a solid fixation or there is a definite loosening? Solid fixation, as we can see in this image. Some of the acceptable fixations where there are fibrous linear lines you can see along the cement bone interface, which is usually the osseous integration happening between the bone and the tissues. Again, that's an acceptable finding. Usually we talk about more than 2 millimeter of radiolucency along the components. Possible loosening, is it a definite loosening? Is it osteolysis, periprosthetic loosening, or bead shedding, or cement fractures? Next, I don't know, it's not working here. Sorry for that. So again, cement fracture, so extensive, so definite loosening wise, you can see this scenario where you can see, you can't point it from here, so you can see at the bottom of the component, there's quite significant loosening on that plain films. Movement wise, you can see in such cases where you can see sinking of the component and distal movements. Again, loosening, you can see the difference between the one on the right and the left, how the component has moved because of the loosening. Bead sheddings, you can see those tiny metallic sort of debris at the distally where this is the same thing which will then give ALVAR or ATLR types of reaction to the soft tissues. Compared with previous, is very, very important in plain films. If we are looking into this, always we should be. Unfortunately here, I don't know how the systems are, but back home we have quite, going back to up to 2005, 2006, we can compare previous imaging and make up our diagnosis, which would help. So very, very important to look into previous one. Like in this example, you can see the one pre-operative image where you can see the cyst around the lateral acetabular margin. And if you see gradually towards the last end one, that is still present there. So again, prosthetic fracture, which you can see the component is totally failed. Predprosthetic fractures, again, quite obvious. Another example where you can see a perforation in the region on the lateral cortex here. On the CT, same findings. And there's the periprosthetic perforation which has been fixed. Again, another example of infection where again osteolysis. So if you see some osteolysis, whether is it infective or it is septic or aseptic, basically is what we are looking for. And if you can see gradually the shoulder of the component here is sinking down. Again, just a MR snapshot of an area of soft tissue edema along the component. Adverse local tissue reaction, very, very common practice. We see them quite often. We do screen them very regularly. We can pick them up on plain films depending on, again, previous, very, very important to look for. So here we can see on T1 weighted image, there is an osteolysis in the region. Similarly, finding on the acetabular side on the distal bottom one. And gradually you can see from this onto the plain films there, you can see the femoral neck, there is a significant osteolysis. So again, polyethylene wear, very challenging sometimes. And again, in UK, most of these films are either auto-reported because our orthopedic colleagues usually look into them and we don't comment on them. But if it is picked up usually by the radiographer who reports them for us, they do pick up these wear of the polyethylene. We can see Charnley-Deely zone 1 and 2 osteolysis in that region as well. Heterotrophic ossification, again, other than loosening, we have to look into the areas of heterotrophic ossification which can be cause of symptoms and pain and impingement especially. Non-cemented, again, features stress shielding, pedestal formation, and spot welding. So these are different areas of location of, for example, stress shielding, where usually what happens is the greater trochanter is more osteopenic and the marrow dysplasia is what is giving us that kind of features. Pedestal formation at the bottom is a sclerotic rim. Usually on spec component, when we do spec for certain challenging cases, we do see these quite lit up just because of the sclerosis in the region. Spot welding on the femoral and medial cortex. Take-home message from the key plain film is very important one, is always compare with the previous one. Type of prosthesis, yes, we can see what they are, alignment, position, and component fixation. Challenging is the bearing surfaces. Yes, we can find out, but you have to actively search for them and see them if there are some metallic debris. Complication-wise, again, loosening, dislocation, fractures, abnormal reactions, infection, heterotrophic, soft tissues, and impingement, least likely, but then you have to correlate with them other modalities to work out. And always compare with the previous plain films. Some few references, and Jazakallah, thank you very much. And any question, please?
So I would invite the audience and the panelists if there are any questions for Dr. Shakir.
Thank you very much for a lovely summary of the radiographic features after hip replacements. I wonder how often you're actually asked by your orthopedic surgeons at Wrightington to report on these films, or do most of your...
Very few. I think it's mainly the musculoskeletal advanced practitioners because they run the clinics, arthroplasty practitioner basically. So if they are in a struggle, then definitely I would say 1 or twice a week, they may ask me. So if we are a group of 5 colleagues, so maybe very few, but usually, as I said, they are mainly auto-reported, seen by the orthopedic surgeons themselves. But it's usually the advanced practitioner who come and ask us, do you mind if you have a look, if they're not happy with either if there's a impending fracture going to happen, which is the most likely, most common question they ask us.
I imagine also you run a multidisciplinary team meeting.
Yes.
And that's where your input is most valuable.
We do have, we have got, every week we have got about 6 MDT, so 2 for upper limb, 1 regional lower limb, 1 local lower limb, 1 infection, 1 knee, 1 soft tissue. So yeah, most of them goes there.
Thank you.
So moving on to the next talk. So I'm going to invite Professor Guy Vansbrough, who is a foot and ankle consultant at Devon and Torbay, and he does quite a lot of charity work in Kenya and Bangladesh, and he's going to present us his experience of his time in Kenya, the tip of the iceberg, treating trauma disability in Kenya.
Thank you. While we wait for the talk to come up, I'd like to say thank you very much for inviting me here to Pakistan. It's my very first time here. I've met some fascinating people. I've made some good friends, and I have seen the MMI hospital, at which some of you will work, I'm sure, which is impressive beyond belief, really, considering the other places that I've been and seen hospitals. So thank you to everyone who's looked after me. Sounds like I've put too many videos in it. This is a non-technical talk. I hope you will not feel that it's irrelevant, because I'm very conscious that some of the things I talk about here will be bread and butter to the surgeons here who see these sorts of things more often than I do in the UK. I've no conflicts of interest, and all the patients have given their permission for their videos and images. Kenya in East Africa faces particular challenges delivering orthopedic healthcare. For example, their population sparsity, and in the north there is one county named Marsabit that has the same surface area as England, but around 60 times fewer population. This leads to obvious challenges to reaching hospital, both for the distance and the transport costs for the patients. And Kenya is in this bracket. Economically, Kenya is challenged to the tune of around 22 times less money per capita as GDP, but interestingly, around the same as in Pakistan. Perhaps most significant is that in England, we enjoy around 130 to 40 times more orthopedic surgeons than Kenya does. In 2009, Lucia Blensky on the left, who's a global leader in expedition medicine, teamed up with Samuel Ndanya, who's an orthopedic surgeon in central Kenya, to form the Kenya Orthopedic Project, which delivered side-by-side charity healthcare camps for a number of years before developing into Future Health Africa, which is a larger and more ambitious charity involving, amongst other things, a trauma team. That is a team of around 15 to 20 orthopedic practitioners who travel to the country with equipment and implants and the desire to teach and to be taught about charity healthcare work. The need for this arises from the skill shortage in orthopedic practitioners in Kenya, the very poor financial environment, and the fact that there are very few other charities delivering similar services. To date, they've worked in 5 different hospitals on a regular basis, twice a year, around the country, and we're about to start at a 6th, which is St. Joseph's on the left-hand circle on this slide. Each camp is widely advertised before the team arrives, offering free orthopedic assessment and care. And that typically leads to around 1,000 to 2,000 patients attending an outpatient service being assessed and triaged, and ultimately 50 or 60 will receive surgery during the same 2 weeks. In 2012, the first 3 years' worth were published in the JBJS, or the Journal of Bone and Joint, I should say. That included 210 patients with a follow-up rate of 77. It seems a low number, but these are complex patients often, and they're used for teaching. Future Health Africa has focused in order to deliver efficient and safe orthopedic care on a charity basis on the following subjects: recognizing disability, promoting non-operative treatments and high volume management where such things are gold standard of care, supporting a sustainable service and local training between camps, observing and following local leads in decision making, and trying to supply a sustainable supply of implants. Disability takes many forms, many of them invisible, but clearly musculoskeletal disability is the one we concentrate most on, and somewhat on back pain. Disability in Kenya can have disastrous results, especially for children who are ostracized by their family and may be rejected by their families into orphanages such as this one. Here's an example of a patient at risk of such treatment. His name is Osman, he's 14, and about 6 years ago he sustained an injury to his leg. He may have a congenital pseudoarthrosis, but either way, he has an awful deformity which has led to his, not quite persecution, but his ostracization by society. It looks dreadful, but actually with quite simple management of bone grafting and internal fixation, he's achieved a cosmetically and functionally much better leg, and it's really transformed his life. In Kenya, clubfoot is the most prevalent congenital deformity and is around 3 times more prevalent than in India. Historically, these patients would have struggled to get to healthcare and would have either presented late or never to surgeons, who would then be forced to do an operation. Meanwhile, in the rest of the world, non-operative treatment has become the gold standard of care. And FHA promotes this belief and the facilities and training to deliver this in Kenya. Particularly important is the fact that it's cheap and does not require orthopedic surgeons. In fact, nursing care, or in this case, James, the orthotist at Nanyuki Hospital, can deliver a very good service. Many patients attend our camps with back pain and expect to have operations. But in fact, we know from the literature that simple physiotherapy and movement is all they need. And accordingly, one physiotherapist can lead a huge class of actually doing camps. The actual orthopedic interventions can look very scary. And in this patient, whose name is Zachary, has not been able to work or support his family. And he's been waiting for orthopedic care because it's been so difficult for local surgeons to deliver. But in fact, we were able to take an orthopedic registrar from Kenya through this operation relatively simply, shortening his humerus slightly and fixing it rigidly. And he's had a great result. Workshops for South Africa Charity has set up 2 locally led initiatives with support from Plymouth University, which are actually commercial courses run in Kenya for healthcare professionals throughout Kenya. One being Grasp It, which is global recognition of the acutely sick patient. And the other is Quality and Leadership. And of course, that feeds back into the confidence that the orthopedic community can lead itself in country. There is quite a lot of wasted resources in Kenya when the local surgeons are not quite sure what to do, and patients wait for a long time for the next camp to come along, and then they may be disappointed. For example, this girl who has a widespread tarsal coalition, which really is not suitable for surgical treatment, and all is required is an orthotic, and that reassurance that orthopedic management wouldn't help her any further. And that means she won't come back and won't need dangerous and expensive care. Conversely, this patient on the right who has sustained a Lis fracture dislocation and a triple joint fracture dislocation about a year before we saw him has a complicated decision-making process ahead of him. So we discuss this with local surgeons and make a plan. And in the UK, I would think that that gentleman may well end up with an amputation simply because his pain will be dreadful for a very long time. We discussed this, but according to the local surgeon, that was not appropriate. It was not socially acceptable, and there's no availability of prostheses, and he was much better off having surgery. So we did that. And in fact, at 3 months following surgery, that was probably the right decision. Occasionally we see patients who really do have high-risk problems, but then the disability is so severe, sometimes the risk of operating is justified. This 8-year-old is a herdsman and lives a nomadic lifestyle with his tribe, who have had to travel from place to place, either carrying him or slowing down because of his disability. We took, after discussing with local surgeons and the family, we took the decision to do an open reduction despite the risks of infection, redislocation, and avascular necrosis. And around 9 months later, he has really benefited from that operation, and so has the whole of his tribe. So what of the future? Well, 2023 has involved the development of St. Joseph's Hospital in Mizumu, the one on the original map. Future Health Africa has supported the hospital in designing its services, its equipment, and developing its processes to deliver orthopedic healthcare. And as a quid pro quo, we think hopefully this will become our base to work in Kenya, so we can run camps from there and future training courses. We've applied for a Global Health Workforce Programme grant of about £250,000. And hopefully that will allow us to invest in St. Joseph's Hospital to run local training programs involving such things as simulation and Ponseti training, to which we can invite healthcare professionals from across Kenya. So we think the future is very positive. Thank you very much.
Are there any questions from the audience?
Excellent work done in Kenya. The clubfoot, do they have got any inventory or any audit or any system where yesterday you saw a presentation here by Indus Hospital where they were having centers, different centers in the country trying to eradicate this. So is there any sort of a scheme there? I gather you have got very good support from the NGOs and it can be expanded. So I was just wondering, are you thinking anything on those lines?
There are a number of charities that work around the world. I think Walk for Life is one, and I'm embarrassed to say I'm not sure about the ones around that are available in Kenya, because most of the services I've seen have been locally administered by local surgeons. For example, in Nanyuki, the single surgeon oversees the orthotist's work. I detect that the training hasn't been very comprehensive, and it doesn't, certainly in that hospital there's been no input from an NGO. So I think there's a lot of potential to set up clubfoot and Ponseti workshops, both to train the practitioners and probably train the trainers as well. clearly there's no point in doing it immediately alongside an NGO. It's better to join forces and establish what role each party plays in delivering that training.
Well done, excellent job done. I'm from that part of the world as well, like from working in Ireland. I was just wondering, in terms of patient cohorts, you saw the difference between the outcome in terms of the less frank patient. Is there any significant difference in terms of the patient expectation and their outcome satisfaction between the two cohorts, like working in Europe and Kenya, Africa? I was just wondering, I'm taking this question, asking this question in terms of our own population here in Pakistan. I was listening to a few presentations earlier. People were saying that, the treatment offered in here is kind of a little bit different than what we are doing in that part of the world. Is that the case, and what's your experience?
Well, I feel that's a loaded question, and you know the answer, which is, of course, it's a massive difference. I think having had a national health care system in the UK for 75 years has led to an assumption that care is freely available in the UK, that people will always merit care in the UK, and therefore, by implication, that care is always the right, interventional care is always the right thing. And we've become too reliant, and there are a lot of other political overlying factors that make the European and particularly the UK patient more needy. And it's very clear that in Africa and probably in Pakistan, people are less needed. They expect less. They've never been used to having access to care. They put up with a huge amount more pain and disability than we ever could in the UK. And that does lead to a different expectation. Overlying that, there are cultural implications of wearing prostheses and appearing to be disabled in some way and to having amputations. So it's quite different. And I agree with you. I think it's probably much more similar to your poorer population in Pakistan than it is to the UK. And I think there are, for people like me, there's some people who really enjoy that contrast and try and recognize the different objectives. And there are other people in the UK who are scared by that and therefore would not be comfortable working in the developed world, the developing world.
Yeah, that's right. And probably the social factor is also involved. Here in Pakistan, we have the liberty of a lot of social care, joint family system. A person with a hip fracture is taken care of, at home without his or her hip fixed for ages. And over there in Europe, the social life, the social care, the family dynamics is not there. People living alone, and their needs are probably different. So yes, I agree. I think these are a few differences that we have to bear in mind. Well done. Thanks.
Thank you. Thank you very much.
Thank you very much, Professor Vansborough. Now moving on to our next talk. The next talk will be delivered again by Dr. Shakir Saeed, and it is on anatomical variant MRI findings in hip, knee, and shoulder joints.
Hi, again to those, good afternoon. I have not said hi earlier on. It's my another topic for quite interesting, especially again the orthopedic surgeons here. Unfortunately, in the city and the country as a whole, there are very lack of musculoskeletal trained radiologists who can give you good reports, which can make your life easy. And I think so most of you guys rely yourself on your skills and on your knowledge of interpretation of these scans. So I thought if I can come with some slides and some teaching slides on major joints such as shoulder, hips, and knees, where it may help you guys without whether do you need an intervention to read these scans, or is it just an art like a variant where you don't need to do anything. So we'll start with some introduction to the common pitfalls in shoulder and hips and knees. Shoulders, again, most of you would have known through your knowledge, is the acromion normal variant, the type, especially for shoulder upper limb colleagues, where different types of acromion in the report can have quite nice external impingement and it can help the surgeon to identify what to do. So we should be aware of, usually in our reports we do mention them. Here obviously depending on how it's reported, most common type 3 is the one which has, if it has got hook which can impinge and give external impingement and can be a cause of something which can be treated. Osteoacromially again is a very common finding for, especially in the reports, most of the time is not reported or documented. And if it is there, is it symptomatic? Is it causing the problem? Is it the cause of the problem? So these are two things which in the acromial region we should be looking for. If you are reading the scan yourself, which is mostly the case in Pakistan, I have seen. Coming to the humerus again, unfortunately, what my experience is, I do practice sometime in Islamabad. I come and help my colleague in Islamabad, and there's hardly any center which can do MR arthrogram studies over here. But for those who can see or read MR arthrograms, there are few certain areas, especially for labral pathologies, which are anatomical variants, and they are not pathologies, and they should be left as they are. One of the example is like when we talk about Hill-Sachs lesion, which should be at the coracoid level, usually sometimes we can see that there's a posterior humeral groove, which is not a Hill-Sachs lesion. It's something which can be left, and it's not a pathology. Glenoid, again, cartilage defect. We have seen them quite often when we report MR, either if it is on a 3 Tesla MR scan or if it is done as an arthrogram study. That's a normal variant. So if a central glenoid cartilage defect, it's usually a central area which is absent, and it's a normal variant. Similarly, a tiny tubercle can sometimes be seen, which can be mistaken for like a subchondral osteophyte, or unless if you don't see any cartilage changes or if you don't see any chondrosis in this region, then it's an overcall and it's just a tubercle which can be ignored. Pear shape, which is the shape of the glenoid, normal variant, presence of a glenoid notch. Long head of bicep, again, it can have lots of variations, which I will address later with the labrum, but usually the most common one is the magic angle, which happens just because of the way around 45 to 50 degree when the angle of the scanning when we take and the tissues shows abnormality, then you correlate those on T2 or other sequences to see if it is a true pathology or is it something which can be as a normal variant ignorant. This is an example of a T1 and T2 weighted images where we can see on the T1 weighted images there's a vague intermediate grade abnormal signal change, whereas when on T2 we are not seeing those abnormalities. So it's not a true abnormal bicep anchor. Again, pitfall we can see at the footprint of the humeral head next to the supraspinatus footprint. There's a small indentation. It should not be mistaken for any underlying articular-sided tear. It's a normal anatomical variant, which is the bare area between the supraspinatus footprint and the humeral head. Ligaments-wise, again, quite variation in the ligaments as well, which we have to address them individually depending on the pathology, the mechanism the injury is caused, and what's the clinical question to be answered by the operating colleague. The common ones are this, which is the conjoint MGHL and Bouffard complex, which is most common. In Bouffard complex, we see that the MGHL is thickened and there's absent anterior labrum, and that's why you see the Bouffard complex. And it's an anatomical variant, which is a thick one, which you can see. And we do see them. If I report in a month, if we report 40 to 50 shoulder arthrogram study, I do see them 5 to 6 will have it. It is there. Again, superior glenohumeral ligament, which may be absent in 3% and may be thick with the MGHL. Similarly, capsule variant, again, we talk about if the capsule is capacious. The key to remember is if it is too much capacious and if there's any anterior Bankart lesion or anterior osseous Bankart lesion, what we may sometimes misrepresent as a periostal stripping. So you have to be careful to see how the capsule is, what are the other associated injuries with the capsule anteriorly. Labrum, again, common ones are common, which is the sublabral foramen, which is usually at 1 to 3 o'clock position of the labrum, which communicate with the fluid. If we see such communication or if we see fluid on a normal MR study or on an arthrogram contrast, we do mention that there's a common site for anatomical variant, so team should be aware of whether is it a true pathology or not. Similarly is with the sublabral sulcus, which you can see a tiny at the top next to the bicep anchor. So these are the most two common ones which you have to cross-reference on different other sequences before even labeling them as a pathology. Coming to the hips, again, in hips there are few variants, but the common one is the labrum when we see if there's no symptomatic labral pathology and there's a subtle increase in the T1 weighted sign, that's a normal finding, and it's an asymptomatic individual, it's a normal, we can leave them alone. Sublabral sulcus is a debated topic. Again, some colleagues may take it as being an abnormality, whereas mostly seen in the posterior side of the labrum, which again, if there's nothing wrong with the labrum in itself, if the labrum has a low signal, triangular sort of morphology, then we should just ignore. So it's not just the finding on an isolated image, we have to treat it as a whole picture. Transverse ligament, again, anteriorly, especially when we see them inferiorly at the joint, and there's a small area of, you can see a subtle contrast which is going between the transverse ligament and the joint. That's abnormal, that's not a tear, it's just a transverse ligament with a cleft there. Os acetabuli, again, it can be symptomatic, but in this case we can see that it is present there, it's not something which is abnormal, we can see them, and until unless if it is giving symptom of impingement or chondrosis around the area, it's left alone. Paralabral recess, again, at the anteriorly we can see some areas where the contrast is going between the labrum and the soft tissue or the capsule around it. These are left alone. Again, superiorly, just like when we talked about the glenoid cartilage in the center, similarly in the hip, we have got central weight-bearing hip acetabulum top part. We can see some notching there. Again, if the chondral surface is intact and not degenerative, or if there are no occult like cartilage bubble or cartilage dark sign, then we leave them alone. Accessory iliacus tendon, again, anteriorly more common than this would be, which we may see in the hips, is the iliopsoas impingement or iliopsoas impingement, which is causing labral tear. But in those cases, accessory iliacus tendon can be seen. I have not seen one, but it's what documented as a common variant. Pectinofoveal fold, again, we see them and we ignore them. Most of the time, you won't even see us reporting these. Knee is very interesting and most common because this is obviously the good thing with this setup is that we don't need arthrogram for these. It's a normal MR study which we can talk through and is more interesting. So there are quite a few areas which needs to be looked into, which even by the radiologist are mainly missed as well, especially the posterior periphery of the menisci, which is the difficult area to approach, especially when you are reading the scans. People can miss like the ramp lesions in the medial meniscus. So here we are seeing some few examples where you can see abnormal high signal changes along the periphery of the meniscocapsular junction of the meniscus, which again, if you follow them on slices, there's a coronal correlation of these sagittal slices. You can see the fluid cleft is going, extending between the Risberg and the posterior horn, and it's a true tear then. This is another example which is not a tear. So if you see any intermediate to high signal change between the Risberg ligament and the posterior horn of lateral meniscus, and on subsequent slide on sagittal sequence, you are not seeing it just disappear and it's on isolated. So if I'm reporting such scan, I do mention it, and I say there's a highly likely that this is an anatomical variant pseudo-Risberg ligament tear, and then depending on the surgeon, if there's associated ACL tear or pivot shift mechanism injury, then obviously chances towards the complex tear is more than compared to the pseudo variant. Another example of the anteriorly, if you see when the transverse menisco-meniscal ligament is extending, we can see on this image on the front where you can see a fluid cleft, but that's just the edge of the menisco-meniscal ligament and the anterior horn, and it's not a true tear. So again, another example, which is a pseudo tear, we call it. It's not a true tear, where you can see quite a good amount of fluid along the popliteus. And if you see here, the popliteus tendon is extending and going behind the posterior horn of the lateral meniscus. On coronal images, you can see there's a slight subtle high signal change, which is again not a true tear. You have to cross-check them on different coronal, sagittal, and axial imaging. Another example of now coming to the posterior horn or the periphery of the posterior horn, where on image 1 we can see quite nice, well-defined longitudinal abnormal high signal change. You can see a secondary findings, which is of the bony edema where the star is. That's a common theme where you are seeing a longitudinal periphery tear. So that's a true meniscocapsular junction injury. Whereas in the recess, you can see a well-defined tissue, no abnormality along the meniscal. You can see a nice triangular shape. You can see nice chondral surface of on the cartilage as well on both sides. You are not seeing any bony edema or any traumatic contusion into that region. So these will be then, this one will be labeled as meniscocapsular tear or injuries to that region. Another example of similar sort of separation where you can see high signal change posteriorly with a rim of small meniscal tissue attached there. And again, another positive sign is the bony edema or contusion to the bone. Now, these are a few examples of the difficult one, the root tears, which are usually in degenerative tears where the root is gone wear and tear and it whirls from the root. Another example is you can see at the coronal image. On this image, you are seeing degenerative arthrosis in the middle image where loss of chondral surface, subchondral marrow edema, marginal osteophytes, and a degenerative meniscal tear. Again, continuation of the same. On this image, you can see a root tear where the root is, if you compare it to the lateral meniscus on this side, you can see a nice definition of the root there. But if you go to the medial side, there's loss of meniscal tissues and it's a root tear of the medial meniscus. Similar example where you can again see there's a chunk of tissue missing from the menisci if you compare it to the other side. Again, tear of the posterior horn of lateral meniscus, usually with ACL tears, we do see in pivot shift mechanism. So ACL is gone, and in this case, you can see a complex tear of the posterior horn of the lateral meniscus with abnormal osseous contusion to the central sulcus and the proximal posterior tibia. And these are true tears. This is an example of a variant where you may see if the other tissue, so the key important thing in experience is if there's an isolated tear, you have to look into the rest of the tissues to see if there's an osseous abnormality, ACL is gone, MCL is gone, what is the status of the other tissues. In this example, you can see there's a linear low signal tissue, which on further cross-references turn out to be just a menisco-meniscal ligament rather than a true abnormality. Another example of similar sort of tiny areas of meniscal flounce, for example, is we do see them if I report again as a 40 to 50 scan a month of knees. I will see 2 to 3, and we do report them, and it helps the orthopedic surgeons to know this is not abnormal, I don't have to go in. Another same example of flip meniscal fragments, common, which is I'll show you on the next slide, is the bucket handle type tears where you can see meniscal tissues which are torn. So again, if you see any torn tissues which has flipped, so I usually report them either locally flipped, or if it is a bucket handle type, then we tell them that it's a bucket handle type tear. This is a nice example of a bucket handle type tear. You can see along the femoral intercondylar notch, there's a meniscal displaced tissue which is sitting there. On this axial example, you can cross-reference it as well, that it's sitting in an abnormal place. Another example of a post-operative menisci. Again, post-operative is challenging sometimes, but the good thing is back home is we do have cross-reference of the pre-operative scans. Here the challenge is most of the time your scans are not even on the PACS. You guys are more expert in reading the films, and it's very difficult to cross-reference, but it's always good to have a pre-operative imaging, because sometimes we don't know, the orthopedic colleagues might have gone in and they might have repaired the tissue, whereas it may just be an intermediate grade signal change for a repaired tissue rather than a true tear. Another example of here where what we have used technique is that although we are seeing on this sequence, So on this sequence, the fat is not being suppressed. So if you see the marrow is still bright, this sequence fat is suppressed, so marrow is not bright. So the fluid should be bright on this sequence. Here we are seeing intermediate grade signal change, but when we truly suppress the fat, there are no abnormal high signal change. So it was not a true tear. So what it was just from the previous sort of subtle. Sometimes colleagues will report these as undersurface degenerative fraying or tear, but we are not seeing any fluid cleft extending into the meniscus. Another example now coming to the cruciate ligaments. Again, this is the way the ACL should be looking. Complete discontinuity in some cases. Here we are still seeing some fibers, and there's a lax morphology, but although fibers are intact, here we are seeing a bit of femoral attachment in the notch where the proximal of femoral origin of ACL is coming up. PCL, we do see them. They do come along, not that rare. Again, abnormal kinked morphology with loss of normal definition and heterogeneous thicken, which is the posterior cruciate ligament tear. Again, coming to the collaterals, these are sometimes subtle, especially in elderly population. We do see that early subchondral insufficiency fractures, which are very common theme, the morphology. We do report them. So again, here we are seeing example of MCL, which we are trying to work out. If there's a marrow contusion, work out the tissues over there. Similarly here. Another example of posterolateral corner injury where we can see loss of normal definition of the lateral collateral ligament with a conjoint. If you see, that's the biceps femoris tendon coming up, that's the LCL coming up. Another variants are extensive mechanism variants such as bipartite patella. Again, it can be symptomatic, asymptomatic. And the next one is the dorsal defect of the patella. This is another example of patellar dislocation. Again, we do see them very regularly. They're very common theme for us, where you can see abnormal contusion on the medial side of the patella. Usually, if the scan could have been scrolled, you will see abnormal lateral aspect of the lateral femoral condyle, which is the typical morphology of the marrow contusion. You are seeing loss of definition of almost the entire MPFL femoral attachment. There's quite a lot of soft tissue edema and contusion to the medial retinaculum and MPFL patellar attachment. Another thing to remember, and look, this is the case of a bipartite patella where it is symptomatic. So if you see soft tissue edema and patient is symptomatic with anterior knee pain, these are the areas to look for, and these anatomical variant can be symptomatic then. Another example where we are seeing a nice good going edema, which is the main cause for symptom for this patient. Dorsal defect of patella, again, if you see edema, if it is benign, if there's nothing around it, like that's a CT image showing the definition of the defect. Here, if you have contusion and edema with an intact chondral surface, then it's most likely the cause for symptoms. Fat pad, again, common. We do see them, HOFAs most commonly, but just be careful when we are reading the soft tissue. If you don't see anything, then ask yourself, is it a HOFAS fat pad, or is it a quadricep fat pad edema, or sometime ITB friction syndrome? So these could be three subtle changes, which if there's nothing showing up, if I don't see any major meniscal or ligamentous injuries, my review areas are, okay, sit back, think about HOFAS, think about quadriceps fat pad, think about ITB friction syndromes, and those can be subtle findings which can be easily missed. So again, here we are seeing abnormal edema of the quadricep or suprapatellar fat pad. Another example of HOFAS fat pad, which is most commonly in patellar maltracking or usually patellofemoral trochlear dysplasia cases. We do see them associated features. Bone marrow, the last, obviously then we have to look into the marrow, see if there's any abnormal marrow changes. It's not just the soft tissue. On MR, we do see the marrow, we do talk about. If we see any such changes which we are not sure, we ask to review clinically and look for any previous, if there's any metabolic or hematological condition which needs to be reviewed, should be addressed. A few cases where we can sometimes see hydroxypeptide deposition disease. In the same area, we can see sometimes avulsion fractures where they, known as a Pilak-Steed disease, where MCL is avulsed from the proximal femoral attachment. Exostosis very least likely in this region, but yes, we can see them, but you have to then think about and make your diagnosis. Plica, yes, if it is thick, if I see it, I say, sometime in my report I would say it's visible plica. Most of we do see them, but if it is thickened, then definitely colleagues can go in and work it out. Another incidental finding of a vascular thrombus, which was incidentally picked up on the MR of one of the patients. So we have to just think out of the box kind of thing sometimes. Jazakallah, thank you very much. And
excellent presentation. About this medial meniscus, we keep on seeing reports from MSK, radiologists. We say the 3rd degree meniscal tear in the medial meniscus.
Yep.
It's littered.
So
every 3rd patient which we send there with a knee pain comes back with a 3rd degree meniscal tear. And I've done arthroscopies on them as well sometime, but now I don't. And we never find a 3rd degree meniscal tear. So what is the...
So what I do, so what I can say my practice, I don't know about the regional practice here, but if I'm reporting a meniscal tear, if it extends to the articular surface, if any of the high signal abnormal change goes to any of the articular surface, that's a tear. If it is contained, so I will say, if I don't see any communication between the high signal abnormal MR menisci to the joint surface, I will report that it's contained signal change. I won't say, I don't grade them. In my report, never grade them. And I work with 10 knee surgeons, it's like. So we never grade them because if they have to go, it's a tear or it's not a tear. And if I'm not sure, I then describe it and leave it to the colleague and say, happy to discuss. So they do come back to us saying, listen, Shakir, you have mentioned this. I'm not sure. I think so it's a tear. Should I sit tight on it or should I just proceed with it? But I don't grade them. And if it is communicating with the joint, I do say there is abnormal high signal change which is extending to the joint, and that's a tear.
Thank you once again for a nice talk. So I'm going to invite now Mr. Shahzad Sadiq for his presentation on management options in periprosthetic fractures in hip surgery.
Thank you, Shakir, for nice 2 talks. One of the things we have seen is, I think my talk might be on the timer, so I probably have to come back and answer that. So I work in Worcester Hospital, which is a sort of big district general hospital, and we are a group of 20 orthopedic surgeons with specialist interest. So we have all specialties other than spinal specialty, and rest of the, most of the orthopedic cases we deal with ourselves. So the question in fractures around the implant is when to replace and when to fix. That is the main 2 questions we have. And considering being in orthopedic as a consultant for 20 years, we no doubt are putting more implants, and in UK, Europe, the population is increasing. Hence, there are more fractures around the implant, and definitely it is unusual that we don't see at least 2 or 3 periprosthetic fractures around implant on your on-call in a week's time. So some of our patients have done a journey where they have been with us. So I started as a consultant in 2007. I dealt with this patient initially for a fracture around the hemiarthroplasty, and some years down the line with a fracture of the distal femur. Then we operated and did a long stem, then a dislocation, and then it was converted to a constrained liner. So you know your patients because you have probably performed about 3-4 operations over a period of 10 years. So no doubt, increasing age, and with increasing age, osteoporosis, dementia, but the challenge is to keep the patient mobile, and we talked about the care. Care in UK, European, Western countries is more expensive, hence the patients would prefer that they remain mobile and they are not dependent. That's the only way they can go home and not in a nursing home, which nobody wants to go if they have some brain cells with them. Coming back to the classifications, we have 2 radiology talks. I'm going to keep things simple, and I do believe classifications are good. Having said that, you need to know the basics, and in practical terms, we will be dealing with fractures around the hip implant, making the implant unstable or loose, which means we have to go for replacement options. Similarly, some fractures, no doubt, are difficult to identify and difficult to classify, and they are not part of any classification. More often, we do CT scans for all periprosthetic fractures because there is availability and also because there is always more information available. Having said that, most of the time, we are able to manage the management plan, but it is reasonable to have CT scans in majority of these cases to avoid unexpected situations. Intraoperative fractures can happen, and all surgeons who do surgery will come across, and anyone who's done hemiarthroplasties over the years have possibly gone through and seen to these complications. Fractures can be proximal, perforations, and distal to the stems. The key thing to learn from this is how to avoid these intraoperative fractures. So going back to intraoperative fractures in revision surgery, it is important. Over the years, I learned that to put a prophylactic wire once I have an uncemented stem to remove, because it is quite challenging to get the stem out without fracturing the femur, which is an uncemented stem. Luckily, a lot of our surgeons still use cemented stems, hence that is not the case. This is just an example of an intraoperative fracture in my practice. This slide is about 4 years old. I had one intraoperative fracture which wasn't picked up in post-op radiographs, but I think it was intraoperative as the patient came back at 3 weeks with a displaced fracture, but the post-op X-rays were normal. You could still manage those fractures and keep the patient mobile with various options, cemented or uncemented stems. Main reason for the fracture is fall, and as long as people are falling, going out, it is impossible to avoid fractures. The current inventory has changed. In the 20 years, we have seen development of plates, and the more modern plate, we have all good options, very long plates, which are a combination of locking options and non-locking options, cables, and various companies are able to provide you these implants. Similarly, we have long stem cemented options, which are more traditional and stem from work from Exeter, Wrightington, where cemented hips are still being done in vast majority because they were the inventors of cemented hip surgery all across the world. But more often, we have the options now for uncemented long stems, which have taken over as compared to cemented long stems, in clinical practice, including in UK and definitely outside UK. So workhorse, long distal fixation stems. Again, in my hospital, we have striker implants, so we use restoration system. And I also have kept a cannulated long stem, which also is reasonable option to have in cases poor bone quality and fractures of the femur in the middle third, where it is difficult to fix a distally fixed stems. And bone grafts, allograft bone is available in most hospitals, but especially the hospitals which are doing probably more than 50 periprosthetic fractures. We keep good stock of allograft bone, NHS bone, but fresh frozen bone is not available. It usually has to order. In my book, the management options will depend about the status of the patient, the medical comorbidities, fit and active, and then is the next question about the stability of the implant. And in some situation, we have seen the surgeons have struggled. We have already put a lot of implant. This is an old slide. When I started as a consultant in 2006, we have this patient dislocated, very challenging. Maybe this time around, 20 years on, we could replace it with the whole femoral prosthesis. Having said that, at that time, she was walking on it, and it was left alone other than fixing the fractures. Similarly, this patient has a loose socket, but developed a fracture, and the fracture was dealt because she is 97. To do a major revision surgery of a 4-hour operation will definitely cause mortality. So well-fixed implant, where it will be more challenging to take the implant out, it is reasonable to fix them. And we went through the swing phase when we said, okay, 10 years ago, we tried to replace more implants. However, we have come back to realize that intraoperative complication on taking out the well-fixed implants are much more. Hence, unless you are 100% confident the implant is loose, they can still be fixed. Especially, it goes with the Exeter stem, and I'll come to it at a later stage. This is just an example that the plate fixation, in this case, did not work for type C fracture. However, redo plating with allograft in well-fixed plant did work. Again, this is an example of a more distal fixation failure, and these are not uncommon X-rays that if the fracture will not heal, the implant will fail, but I dealt with addition of allograft bone. This is our most common practice dealing with the fractures which have made the implant unstable, to go for a distally fixed uncemented stem with the use of cables, and that remains the main course of treatment for patients with a loose implant. And this is another example where the fracture is running around the Exeter stem, and it has been fixed with long stem distally fixed prosthesis. In this case, we have an option to correct the problem because it was a sort of posteriorly pointing prosthesis. It lasted still about 15 years until it had a fracture, and it has been dealt with, again, revision of the socket and revision of the stem with a distally fixed prosthesis. In the last 5 years, we also noticed that when we fixed some of the loose Exeter stems, they did work. And that was the experience of the surgeons from Exeter and other centers where still 70% of the femoral stems are cemented. And even my impression was that there is no point making the operation more difficult if the cement is well fixed and you are dealing with a loose stem. In revision surgery, revision of a stem has worked very well in cemented stem. Hence, it is not uncommon nowadays. We have an Exeter stem, which is loose stem, but has a good cement mantle. We will be fixing it if the cement mantle is intact. And that is only advantage of if you are doing cemented stems. So over the years, we have also learned that the longest possible plate is the best. That will allow you early weight bearing. So fixing it from trochanter to the distal condyle is probably the best. It does not need that every hole has to be filled with the screw. Probably lesser the screws, but more of a tension band principle. But key is the anatomical reduction, like in this case, we can't see the fracture once it has been reduced, and we know the Exeter stem then generally behaves very well in the well-fixed cement mantle, definitely for another 10 years. A lot of our plates now have options for adding the other mini plate and addition of screws from the side, which are of smaller sizes. So this was the paper which came out not from Exeter, but from Edinburgh, outside Exeter group, that you could fix these Exeter loose stems with fixation rather than replacing it, because replacement obviously has its own risk, longer operation. Probably cost-wise also plating is more cost-effective. So in summary, it is important to understand what patient we are dealing with, his comorbidities. As I say, in Western society, it is very important the patient is mobile, active, independent, living alone. That's less costly than having a carer, because care is very costly. That's why a lot of money is spent to keep them mobile, active, weight-bearing, so they don't spend time in hospital either. And that's the whole sort of stimulus for the operative treatment of these fractures. Again, the fractures are increasing. The population is aging, and more people are healthier as well. As I say, the area I live, the average age is 87, which is pretty much probably slightly higher than the rest of the UK population. Thank you.
Moving on to the second talk of...
I have a question, please. My name is Dr. Ijaz. What is your preferred approach for revision surgery? And if you encounter a situation in which you have a loose implant cemented but not infected, do you remove all the cement for revision surgery? And if you have an infected cemented implant, then what is your approach to remove all the cement?
Okay, so your first question, well, you have three questions, I think. First, you asked me about the approach. So most of us in our surgical training in UK, majority of the surgeons do Harding approach for their hemiarthroplasty. So you can't say that you're not familiar with that approach. So everyone is familiar with anterolateral approach. Over the years, the primary hips and majority of the revision hips I do through the posterior approach. Having said that, the posterior approach advantage to me is only access to acetabulum. So if I'm just dealing with the femur and I feel that I'm not going to touch the acetabulum, for me, I think the assistant point of view, you get reasonably good exposure of the femur with the Harding approach. So I do interchange according to the situation. But in general, if I'm not doing a major reconstruction of the acetabulum at the same time, I will be doing in periprosthetic fracture. Quite often we are leaving the socket. We're dealing with the fracture itself. And so I will do Harding approach, anterolateral approach. which means your femur is down and your resistance is down. I can look at the femur. So in my practice, I do rely still on Oscar availability, which I don't know in Pakistan it is available. And the main reason is that I feel intraoperative fractures are more common. In osteopenic bone, just removing a well-fixed cement, you will crack the bone and you will make more holes. So if you have ability to remove it without damaging more bone, it's better to have that sort of kit. Otherwise, you will be there for a long time. So that was your question. In terms of your question, whether do we have to remove all the cement, we answered that your cement mantle is the key. If you are dealing with a loose cement mantle, then you might as well remove it, isn't it? I mean, but in general, the fractures we are fixing, even in a loose stem, if their cement mantle is good and you think the lines are only 1 or 2, even on CT scan, it doesn't look bad, you could probably fix them as well, because accident. What I wanted to tell Shakir Sayed was a lot of reports these days on the hips come degenerative impingement in a 50-year-old. The physiotherapist requests the MRI scan, then they are sent 50-year-old patients with a bad arthritic hip with degenerative and the diagnosis of impingement. The physiotherapist is interested in impingement. They don't do hip replacements. Their referral letter is about what surgery this patient will have for impingement. They forget about the rest of it, that you have also written there is a degenerative disease in the hip. Similarly, 50-year-old plus degenerative meniscus in NHS, we are not going to. And in this country, we also have to learn that don't waste money for the patients. If it is a degenerative meniscus in the knee, degenerative disc, you have to correlate the symptoms and the patient and the pain. Not every degenerative meniscus needs to come out. Not any degenerative tears have to come out in the labrum. That's why clinical judgment is important. And you have to be convinced the surgeries. So your answer, I think we should know our limit. We should know our limit.
So moving on to the next talk by Dr. Shazad, Acetabular Bone Defects and its Management.
So I'm going to talk about bone defects. And on the first day, it was that patient's peace population where you could say that God was not kind to the children and didn't make their bone. And we had some very good talks. And we talked how to manage a child and how to provide coverage. And we learned about some very bad cases of deficiencies. Here we could say we did create this problem, but we did a treatment for arthritis, and then that led to the phenomenon of osteolysis. And as I say, I briefly mentioned that I work in a busy district general hospital where I routinely do about 150 primary hips, around 80 knee replacements, and about. We do have established clinics on infection, and I do a complex clinic which consists of dealing with non-union periprosthetic fractures and ruins. So, Shakir, I was in Wrightington in 2004 for a year when you were much younger, and some of the world, the Americans think that whole of the problem of cement disease and osteolysis and all the classifications were originated from Wrightington. And is that true? Anyway, so this is the man, John Charnley, the inventor of cemented hip. But I'm going to show this slide. This is the paper I wrote in 2004 about long stems, which we published. But you do see the osteolysis in the proximal femur, which led to the fractures. We're dealing with a lot of reporting of that osteolysis because we dealt with a lot of surgeons, and I worked with Professor Oblowski and Bodo Burbert. That was Oblowski's last year in Wrightington. And I know Bodo Burbert well because he's my age fellow. And since the company took the, he retired. So that was his dedication to the cemented hip surgery. He said, I'm not going to perform any hip. He did not do any uncemented hip. And he retired because Dupuy took out his C-stem out of the inventory. That happened last year in the UK. And I met him in the British Hip Society meeting. So bone defect causes, we discussed yesterday, day before, joint arthroplasty and also in revian surgery. And this is what we are talking about, osteolysis. The two most popular stems 20 years ago. And then we also have the Exeter stem. But this is an interesting picture. So obviously everything you could blame to the cement here. There is no cement here, but there is significant osteolysis. So you won't escape osteolysis even in the absence of cement. So don't assume that you have eradicated it. So where is it coming from, osteolysis? It is coming from this excessive wear of the Foley. And again, at some point the screws were being blamed at earlier days. These are the x-rays of 12-year x-rays of some of my cases, because I've done hips now for the 15 years. And I feel quite satisfied that even at 12 years, there is no cemental disease, and the interface between the cement bone looks very encouraging, which gives us a hope of that question that even if you fix some of these stems, they still behave very, very different to the fixed stems, which were the Charnley type stems. So the polished taper stem behavior is very different in cement as compared to the other stems. So in simple terms, there are many classification systems, and there is another classification in British Hip Society, which at that time Tim Board was registrar with me, but now he is the head of, I think, orthopedic department there. And he has invented a complex classification from Wrightington. But in simple terms, you have segmental defect, the cavity is getting bigger, you have combined defect, and you have defects in which the bone basically has disjointed. And Peprosky's name can't be forgotten. He is a surgeon who is a very practical surgeon. Everything he does has a basis behind it, and he puts his classification based on what he does. And to keep it simple, you can totally have a mechanical mind that you just look at your inventory and decide what you have to do. And that is also very important in one way, because if you are in Africa or if you are going to Kenya, first go to your room, what you have in stocks. There's no point discussing things, what is being done in Europe. You could bring in the principles, but you have to look what you are dealing with. So when you go back to your hospital, you have to look what implant you have got. You have got this shell, you have got this shell, you got this option, you got this option. And then you have to look at your plates, you have to look at your stems. So you have to know what you have got. And then you can just simply deal with it. Okay, I've got this. This will deal with the segmental defect, and this will deal with the more difficult, complex, combined defect. So we got two options. So you are dealing with defects or big holes. So we have to either find a way to filling that hole and then fixing something inside, or you have to find the host bone to fix it. So if you are going on uncemented cups, you have only one option, because if you have stopped doing cemented cups, which is the case, you have to find the host bone. It means you are going what we'll call go big route. So smaller cup wants a bigger cup, but more bone loss. You are not thinking that you will give the bone back to the patient. But probably there is a case of both of them, and there are situations where you have to deal with both situations. So this is the inventory I have in Worcester Hospital. I do have augments because I deal with mostly the striker implants. So Zimmer implants, which is a better system, TMAR system, I only order for more difficult cases. And I have this option, which helps me deal with the pelvic discontinuity. So if you have this option, along with all the two stems, cemented hip, cemented cup, and your uncemented hip option, and an uncemented long stem, which I already shown you the pictures in the previous slides, you probably can deal with a lot of these cases yourself rather than sending to any other tertiary centers. But you also need this. What is the bone graft? So this is the Wrightington technique of producing bone graft. And anyone like me who has worked 14 months there, so which is a reasonable time to be spent in a unit during your training. So I have kept the skills of bone grafting and in my practice, and I still find it is very useful and has taken me out of trouble in many difficult situations. But we do have now NHS bone. We don't have to have a fresh frozen bone. We do have NHS bone bank, and we have a lot of bone available. So we don't have to go through all this unless I'm doing a elective procedure where I can order femoral heads. So segmental defects, they can be in the wall, floor, base, and the key thing is to remember that your columns are intact. Even in a primary hip situation, if you purely use impaction, one of the issues is if you hit hard, this can crack. And that's why in the last 5 years, if I am dealing with a big defect, a big difficult pertusio, I do add a shell. Because in my experience, I did find that if your sort of graft is more than 1.5 centimeter thicker, it is likely to migrate and disappear after 7-8 years. This is what we have seen. I don't know, you probably could write a paper, Shakir, on this. How much should be thickness of the impaction grafting to survive more than 10 years? There's no established study on it. And one of the reasons there's not much study on it, because we are going bigger. We are doing much more uncemented hips and uncemented sockets. So again, this is a fracture situation. You do CT scan to see columns are intact. You could bone graft, pack it. And again, in order to prevent the disappearance of the two femoral heads into a soft tissue, you have created a bit of support, but there is a further support with a cage, and then you can put your cemented cup to deal with this problem. And this is more of an example. This is very typical sort of hip after 10, 15 years. I would say this is one of the reasons I don't do many cemented sockets, but this is the most common revision. I deal with a socket getting loose, radiolucent lines. So my classification for loosening is pretty much similar to Roblowski's concept. It's not based on radiological. We sometimes worry about radiolucent lines, but if the patient is walking with that radiolucent line, has no pain, for me it is irrelevant. For patient who is having problem, I will take things more seriously. And it is interesting that those radiolucent lines persist for years before it comes to revising it. So you have to correlate symptoms. But I'm getting a lot of referrals because a physiotherapist has requested the X-ray, radiologist has reported radiolucent line in zone 1, which are not, when you go back to look at the X-rays, they were there, some of them even 5 years ago, and they were non-progressive. So this is an example of an uncemented metal shell with the augment. And this is more traditional approach, which was published in Exeter, but I wrote a review article or similar to that, that you can use bone graft or augment and put cemented cup underneath to deal with the more simpler options. And in this patient, my senior colleague who is Exeter trained has performed about 2 operations. He struggled, this failed at about 4 years. He has used constrained liner here. My issue was not that the issue is dislocation. My issue is that he had 2 operations in 10 years. So the issue of failure, it wasn't a dislocation. So I wasn't bothered about dislocation. I was bothered about how to provide a fixation for another 10 years. That's why I have not actually used in that setting a tripolar system. I have just used a normal, but increasing the offset and bringing him to the length. I have taken the metal work out. In this case, I have used the Zimmer system because I wasn't sure that the Stryker trabecular metal is good enough for very large defects. So again, in big defects, cavity and superior migration and breach of the Kohler's line. And if I think the migration is more than 2 centimeter, it is a significant defect to fill up and just use the cemented cup. I tend to put the shell, and I try to fix the shell with the ischium, and that also giving bone graft reincorporates the bone stock. But you can have that approach that you can deal with the big defects and you will use the big cup. Big cup means anything above 70. But again, in my experience, you put a big cup and you eat up all the anterior and posterior walls. So you have created a very difficult situation for the surgeon who is going to follow you in 10 years down the line. And he will struggle until we develop maybe artificial hemipelvis, which is being developed, but we are not able to use it yet. So coming back to impaction grafting technique, it has worked very well from the centers and from Wrightington work, and it has helped us. So these are the simple, again, very typical X-rays, bone defect, migration, This is more clear-cut indication of Rivian. Patient has got a loose socket, can't walk. But other radiolucent lines with a stable cup over a period of 6 months can still be observed because all Rivian surgery is a complex operation for that particular patient. So cemented cup and with a bit of bone graft can be done. These are some early x-rays that hemiarthroplasty has worked very well for hip fractures. There's no reason to jump in to do total hips unless you are dealing with patients whose life expectancy is more than 20 years. He is very fit. He is ASA grade 1 and 2. This patient has this done. His one side was done in Truro, and the other side was done in our hospital. And one hemi lasted about 10 years, and the other hemi eventually did penetrated into the socket. So this is one of the complications. If you live long enough, yes, it can happen. And that was some 10 years ago when I dealt with him. And this patient was dealt with the reconstruction, again with the rings. So similarly, again, you have loosening around the cemented cup, and you can pack that bone. The bone is nicely built, and I do x-ray them over a period of a year and 2 years just to see and learn, do I still have to keep doing this, or I just go to an uncemented option. But it's a learning that you come across. Again, this patient is dealt with the bit of bone graft and cemented cap. So coming back to my practice is to deal with the situation. I must say, if the bone is osteoporotic, which is a lot of female bones, bone defect, they usually have dysplastic hips. I still try to restore the bone for them. It's my option. Fixation in them is quite difficult for uncemented cups. I find there is a higher failure rates in them as well because bone quality is poor. So I mix and match my cases, pick up the cases. If good bone quality, I will do uncemented with a bit of bone graft. Otherwise, I will do cemented with bone grafting and restoration of bone stock, taking into mind the future. We have a lot of facilities. We have got CT-guided implants being made. We do CT scans, and technology is advanced because rather than doing 3 operations for very big cases where there's a cavity defect, column discontinuity, once you fix it, you put an hour is spent in each process. Why don't we have implants? But they are costly implants. You order those implants, you have a CT template, and then you get that implant. So the future, it is being practiced in centers like Wrightington, Oswestry, and Birmingham. But in district hospital, it's difficult to get and practice. And if you have majority of the implants, which we have, we can deal with 95% of the cases in our population. Thank you very much.
This robotic surgery which you are talking about, and there are a lot of robots coming up there. What do you see in the future going through? Will the surgeons will be all dependent upon these robots, or do you think that the customary, the traditional way which we are doing?
I don't know about my journey in 20 years. I think to learn a technique, you need good amount of numbers. And the reason we are super specialists and we don't do other things is because we need numbers. So in United Kingdom now, if you don't do a procedure less than 10, it is unlikely you will be doing that procedure in the next 5 years. So the number will is around 10 for Rivian hips and knees at the moment. So surgery and the surgical technique is important. It takes time to learn it. The question will be, the robots doesn't need training. And if robot come, what the other people will do? We will go to Kenya and come here maybe. I mean, there will always be, you know, I worked with Professor Cobb, who in 2004 was developing robot in his uni. He's got prolific surgeon himself as well. But technology, if you're driving your cars with the help of Google and everything, technology is going to push you. And we have to use all the technology what is available and be liberal what comes our way. As long as we have brain cells and we can do something, we will survive.
I think we're going to have to keep the robots under control, even if they become good. And in the sort of work that you're describing in your talk now, I can't see robots being able to synthesize all the different factors or indeed to perform the surgery for decades to come.
Let's see. Any more questions?
Thank you very much, Mr. Shehzad Sadiq. Now, moving on to the last talk by Dr. Zahid Malik, Problems and Solutions of Orthopedic Surgeons in Pakistan. Dr.
If Zahid Malik is, I think he's not here, there are two announcements for the related with the, one is on regarding the research awards, another is the award for the poster presentation. So the award for the poster presentation is sponsored by the Health Research Advisory Board. So I request Professor Shahid Noor, please come sir and announce the awards as well as few words about the Health Hub. This is from the Gates Pharma. I also request to Mr. Rizwan, if he is here, please come on the stage.
Thank you very much, Professor Asadullah Makhdoom Saab. Research is an area which is not very prominent in this part of the world. And in this regard, a foundation was set by the name of Health Research Advisory Board. This is chaired by Professor Ghaffar Billo Saab, who is teacher of a teacher. He is 85 years old, still very active, still promoting a lot of activities. I am one of the founder member of Health Research Advisory Board. I am Finance Secretary and I am the chairman of Registry Committee of Health Research Advisory Board. This Health Research Advisory Board is totally sponsored by Getz Pharma Company, and we are very grateful for the entire unconditional grant which is given by Getz Pharma. There are many activities that we are doing through the platform of Health Research Advisory Board. The vision of this Health RAB is to promote health research ecosystem in Pakistan. And we've been conducting different activities, including promoting research workshop around different centers across Pakistan. We've been conducting workshop on grant writing, and we've established centers of research across different institutions in Pakistan. One of the important flagship activity of Health Research Advisory Board is National Disease Registry. And we are very proud to say that these registries have been there now, national registries, for more than a decade now. The first registry is Pakistan National Joint Registry. In February 24, it will complete 10 years of successful induction. There are, through the platform of Health Research Advisory Board, there are 4 orthopedic registries that we are running, including Pakistan National Joint Registry, Pediatric Orthopedic Registry of Pakistan, Spine Registry of Pakistan, and more recently, Hip Fracture Registry of Pakistan, which is led by Professor Amin Chinoy. This is in collaboration with Asia Pacific Fragility Fracture Society. In addition to that, we've established registries on Cardiology Registry of Pakistan, Diabetic Registry of Pakistan, Stroke Registry of Pakistan, Psychiatry Registry of Pakistan, and Gynecology Registry of Pakistan. Another activity of Health RAB is Research Award, and this is being granted to research presentation in different specialties, including cardiology, orthopedic, psychiatry, and other things. And In this conference during Pakistan Orthopedic Association Annual Congress, papers were submitted, and I'm here to announce the first award, cash award, second award, and third award.
So we are announcing the awards. The third winner on the poster presentation is the Dr. Muhammad Manan Ali Khan. He is from Dow University of Health Sciences. So Dr. Manan Ali Khan, he is not here. So I request Dr. Taimur, he will receive on behalf of Dr. Manan Ali Khan. And congratulations, the award is the 50,000 cash. So he has less money, he can go outside without any security purposes. So the second position is going to Dr. Nimra Rashid. She is from Shaheed Mohatma Benazir Bhutto Institute, Trauma, Karachi. Is she here? Is any from the trauma center from the Karachi? No. So, okay. That is the 75,000. So we will send her from the Mr. Rizwan. Yeah, this one. And the first position in the poster presentation is the Dr. Muhammad Waqas Khan. He is from Dow University of Health Sciences, Karachi. And the amount is 1 lakh rupees or 100,000. So we received the various posters and we make one jury and they decided that who is the winner. Thank you to all. Thank you, Professor Shah Noor. Thank you, Mr. Rizwan and Gates Pharma. And we have also another research award from the Farm Evo. They first time started in the Pakistan Research Startup Challenge. And the aim is to promote health research in the various institutes of the Pakistan. Again, they announced this and through our scientific committee. And again, there are few winners in that, but they will provide or release the funds over there, and that is 250 lakhs per researcher. So I request to the person from the Farm Evo, sir, please come. Saman Saab. I request Saman Saab is from the Farm Evo, so please come. Now I request the judges of this research startup, Sir Professor Ghulam Mahbub, sir please come, and Sir Professor Khalikaman Siddiqui, Professor Ayaz Khan, if Ayaz Khan is here, and they will announce about the names of that. Sir, aap aa jaye.
Bismillahirrahmanirrahim. This activity was for the first time, and it is sorry to say that none of the person came to criteria which was set before we started the looking at their research proposal. But still, as this is first time, they want to encourage the people to take part in it. So it was decided that this time, instead of 4, we are going to give it to 2 people, to encourage the people so that they can come. And first goes to Dr. Sobia Aziz, Dhaka National Hospital.
Well, I think we must appreciate this activity of the Farm Evo, because the research, as said by Professor Shahid Noor as well, is very much required and essential in our country. And as Dr. Professor Mahbub Saab said, none of them really qualified to the marks that was a limited marks, minimum marks decided. But even then, we must be grateful to the FAR-MEVO for their generosity to encourage and attract the people to come forward for the research. And therefore, they decided to award the two researchers. And their plan is not to hand over all the money in one go, but obviously it's going to be the piecemeal. As they will enhance or advance the study, they will be releasing more money so that the money given at time is not taken in the pocket and not used for the research. However, the second one selected for this research is Dr. Tawsif Raza from cohort. Dr. Tawsif Raza. Thank you very much.
Now you distribute. Thanks to FAR-MEVO. And now, Dr. Shakat, please distribute the shields amongst the speakers.
So this brings the session to an end. Before we end the session properly, I would like to invite all the panelists, Professor Ghulam Mehboob, Professor Shahid Ilyas, Professor Abdul Rahman Sheikh, Mr. Guy Vansborough, and Professor Nayyar Qayyum to come on the stage for their shields. And for the respected speakers, Dr. Shakir Saeed to come on the stage to collect his shield. So the first shield is being given to Professor Ghulam Mehboob by Mr. Guy Vansborough. Professor Mehboob was one of the panelists in this session. Now the second shield will be presented by Professor Mehboob to Professor Guy Vansborough. It was a nice talk by Professor Vansborough for his time in Kenya. Now I'm going to call Dr. Shakir Saeed to collect his shield from Professor Mehboob. Now I'm going to invite Mr. Shahzad Sadiq to come on stage and collect his shield from Professor Mehboob. Professor
Jiri Chomyak, Professor Jiri Chomyak, I think already.
Now there is an announcement for the moderator, and this award goes to Mr. Dr. Tahir Mehboob, and he received from award from Professor Ghulam Mehboob. Thank you very much.
So now it's a lunch time. We will again come at 2:30 for the sessions. Thank you.
अच्छा लो
Thank you.
वेलकम
Hello.
Assalamu alaikum. Welcome for the second part of foot and ankle session. Inshallah, we'll start in 2-3 minutes.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. My name is Sohail Yusuf. I'm one of the moderators for this session. This is a foot and ankle session too. We did a foot and ankle session yesterday. We're going to cover common sports-related injuries in the beginning of the session with some common fractures. We'll then move on to Achilles tendon injuries. And lastly, we will invite our young doctors to come and present their work and share their experience and reflect on what they're doing and learn from this meeting. My colleague panelist for this session will be Professor Irfan Mahmood, who has a special interest in foot and ankle surgery based in Lahore. I work in London and have a special interest in ankle arthritis as well as sports injuries. Rizwan is a moderator who's slightly delayed and should be joining us. My first speaker for this talk is Sayyid Mohsin Ali, who's been part of the Foot and Ankle Forum for more than 10 years. He works in Johns Hopkins in Dammam, previously was working in England as well. He has done fellowship in foot and ankle surgery and has a trauma as well in foot and ankle practice in Dammam. Welcome, Syed. Over to you.
Thank you. Slide it. Assalamu alaikum everybody, especially POA and Dr. Sohail for introducing me in such a nice way. What I'm talking about today is the osteochondral lesions of the talus, which is the most common injury we've seen as an OCD lesion. I have nothing to declare. So if you're looking at the incidence of the OCD lesion in talus, mostly associated with some sort of injury. 50% of the sprains are associated, as well as 70% of the trauma, ankle fractures are also associated. And they are 10% bilaterally, and some are maybe without any trauma, maybe as a childhood or something you can see them as well. Why is it so common in talus only? Why not on the tibia? If you attended a lecture from our colleague, Dr. Khalil, on the talus fracture, he described that talus have a different anatomy from any other bones. It has no muscle attachment, 60% is a cartilage, and has a different blood supply, and its nutrition is through the synovial fluid. So any trauma, anything which leads to effect can lead to a problem in the talus bone. And if you look at the cartilage surface, a lot of work is done. Why is not common ankle arthritis as compared to the knee or hips? Although there's a thinner layer of the cartilage thickness as compared to the knees. So God has given this bone a spatial status. So mainly locations as a talus, we divide into 9 zones, medial and lateral and central. Most common is in the medial side when there is no history of trauma. If there is a history of trauma, those most common side on the lateral side, and they are more painful. Middle are more larger and deeper, while the lateral side is a little bit smaller. So what is the mechanism of injury when you get the middle side, when you get the lateral side? Lateral dome injuries are mainly with the ankle inversion, okay, with the dorsiflexion, the inversion and dorsiflexion, while as the medial dome is an inversion with the external rotation. So you get, like, if you remember the Log-Hansen classification, sort of those things. If there's a repeated micro trauma, there's a ligamentous injury before and repeated, so that will affect the blood supply and affect the nature of the cartilage, and these lesions can. You need to always look for any other deformities. These lesions can be associated with like a cavus deformity. This patient has more prone for OCD lesion. So most common symptoms are pain, swelling, exacerbation on the weight bearing, locking and catching. A lot of patients with the OCD always them of clicking in the joint. So that has to be a differential diagnosis, occult fracture, there's a whole list. You do a physical examination as every patient. You do some spatial tests to look at the talar tilt and any subluxation which can be associated with it. The important message is do a fully thorough examination. As a basic investigation, we do the radiograph. Normally, sometimes radiograph looks like normal, but you can see a subtle lucency or a bony fragment if it's a large fragment. Bone scan, MRI scan, and CT scan be used as well. Especially I use MRI and bone both because there's a ligamentic injury, and for the MRI and CT scan if I'm doing surgical planning, which gives you more anatomical description of the pathology. There are a series of classification from the radiology, CT, MRI, or arthroscopic. Arthroscopic is an easy one. You can read smooth from the rough surface, fibrillation, flap, loose, non-displaced, and displaced fragments. There are some cases you can do them in a non-operative, which shows 45% of the good to excellent outcomes. But you have to wait 3 to 6 months before you plan for doing any surgical. And overall effectiveness of the non-operative is 50%. Surgical strategies for the OCD lesions can be cartilage repair, microfracture, retrograde drilling, cartilage regeneration like AC-MACI technique, and cartilage replacement. If the fragment is large enough, so you can do an arthroscopic fixation of the fragment in an acute injury, especially in the children. And there also in literature described the implants have been used before. So overall algorithm of the OCD lesion treatment is depending on the size. So if you start on the middle to left and right, so with a lesion of less than 1 to 1.5 centimeters, you can go for bone marrow stimulation. And if the cartilage is intact, you can go for a retrograde drilling. But this is a problem, this middle group. When the lesion is more than 1.5, then it's different choices of treatment. I can stop the talk here to give a message now, but it's a 15 minutes, so I can continue. I briefly give you my cases, what can we do. For the cartilage repair, if the lesion is less than 1.5 centimeter, there's a bone marrow stimulation, like this case. You go do arthroscopy, you do a chondroplasty, and then you do a microfracture. You have a special tools for ankle as well now. Is a specific diameter, different angles, which you can for different lesions in the ankle. I do normally with the anterior scope, but sometimes if the lesion is posteriorly, you can do a posterior scope as well. So this is one of the cases. You see this MRI scan, and another case basically, and you do the microfracture. So what BMS doing? BMS doing a fibrocartilage, which is not a collagen type 1, is a collagen type 2. It doesn't have that structural property like collagen 1, but it's give up to the 60 to 90% in the literature. The paper mentioned that patient can go work without pain and symptoms are reduced. So this should be the gold standard first treatment for my practice and most of our surgeons. We can discuss this later as a panel. Arthroscopic marrow stimulation can give 85% improvement to 60, 90% fibroid cartilage, as I said that. The only problem that it can cause a demyelination of the cartilage. So you have to be careful how much deep you're doing, how big is the lesion. Retrograde drilling, again, up to 1.5 centimeter with intact cartilage. Okay, there may be a subchondral cyst bone. When you drill it, you can do some bones substitute, or you can do a bone marrow aspiration and inject it there. So you can confirm with this. The only complication that while you're doing a retrograde, if you're not careful, you can breach the cartilage. So this is one of the case of 59-year-old with this lesion with intact cartilage. So if you look at an arthroscopically, that it's okay. I do a debridement a little bit because of synovitis. Then you do under X-ray guidance. You have to plan this on CT, where your guide wire should be. You guide it, and you can use that 4.5 cannulated drill. There's another case with a similar thing. Again, arthroscopically satisfactory. You do retrograde drilling. Cartilage regeneration, like AC-MACI techniques, is more than 1.5, that area is above that. It is contraindicated in diffuse ankle arthritis, bipolar kissing lesion, and advanced osteonecrosis of the. This is an expensive, this is the one way of doing it. I haven't done it. The problem is that it's a two-stage procedure. It's expensive, and it's open osteotomy, and bone graft may be replaced, underlining cysts and things. But when they compare the AC-MACI, there are much similar outcomes with up to the 89% good results. Allograft chondrocyte. So this is allograft chondrocyte. You do the microfracture technique, but rather than coming out, you do this, inject the chondrocyte paste, and you do a fibrin glue on the top. I've done one case, 18-year-old boy has a trauma injury. This is an MRI scan. So this is an arthroscopic picture. The last one, this is a chondro, glue. We put that and put the glue on the top. It did very well. If you see the repeat CT, the cartilage is reforming. But there's a problem in this patient happen, which I just want to share it. If you look at this MRI scan, you will still start complaining of stiffness in the ankle. So if you see this is in a hypertrophic cartilage. And when we want to put in the scope, we were not able to find the joint. But we did it under X-ray and debride the little bit of cartilage, and alhamdulillah, it's doing well. The other option is the allograft, which needs osteotomy. You can use a fresh frozen, and more than defect is more than 1.5. So this is one of the common techniques, which is called the mosaicoplasty. You need to do graft from mostly common from the knee, and you need this instruments which is available with Aquamed or Arthrex, and then you do a like a mosaic loss. You can do more than one graft depending on plan. Topic, this is a new paper recently published in British Bone and Joint Journal. Topic, which is in a, they use in a grafting of the iliac crust over the lining and overlining periosteum layer as an autograft. So this is a paper, and the conclusion that they have 100% consolidation of the graft. The problem with the allografts, you find a cyst and things, but they have a good results. So this is the one case. I take the picture from the article itself. I never did myself. I think Dr. Sohail has done one case. This was a graft, and they take a graft and do an osteotomy and fix it, and this is 1 year later. Allograft, I have some experience of allograft. This is a young 24-year-old gentleman with a large defect. So I get allografts, which is very expensive from States. So we cut the allograft into the preoperative planning is important, and you do a fixation like this without anything. And this is osteotomy after. 5 months later. There's another case, similar case, has a bigger lesion than the previous one. So this was all defect. So I cut the graft as planned before and did an osteotomy and fixed it. Sometimes if it's a shoulder lesion or something, you can use some cannulated headless screw or bioabsorbable screw or pins as well. They have some related complications with this. Most common complication is the cyst formation under the graft. You need to absorb it under observation for 6 months. If you think that maybe a collapse, you can do arthroscopically and do some like retrograde. The advances is PJ CAT is you take a, unfortunately you have to take this cartilage from the dead children, unfortunately it's young children, you take them and you can replace with cartilage. And disadvantage is a limited supply, high risk and so as I said, implants are being used. I have no experience of using it, but what are the literature saying is a bad outcome so far. And most of the orthopedic surgeons are, foot and ankle surgeons are not supporting it. So back to the same algorithm, two easily treated, and the middle one you have options, whatever you are comfortable at, you have a training, you can go ahead. Where we are in the management of OTL as a foot and ankle surgeon, we don't have a level 1 papers to support our randomized trial. So that we're lacking of. All the papers are level 4 or retrospective study or a case series. In summary, it is common. Conservative treatment should be the first choice. If it's not fail or it's something large defect, you can start from the beginning of thinking towards surgery. Size matter here. Operative treatment depending on the surgical skill, where you're working, age of the patient, and stable of lesion. Thank you. You want to do questions now? Or?
Thank you, Syed. Excellent talk. Does anybody have any questions? Any show of hands? Anybody doing arthroscopic ankle OCD management? Anybody do ankle arthroscopy? So question from me, if they are not doing arthroscopic OCD management, can they do retrograde drilling without arthroscopy and do it under X-ray control?
See, this all depends on the training. We've been luckily trained, we have an arthroscopic train, so always we do arthroscopy, but it can be done. It has to be very careful. If you have a CT scan which is showing it. The only thing, the problem is that if you bugger up the cartilage, you damage the cartilage, then what you're going to do? So yes, it can be done.
And what drill do you use for retrograde drilling?
I use a guide wire and a cannulated 4.5 drill. And depending on what comes out, the issue is that you need to curate that area. You just not go in one point. You have to take that whole cyst. And that if there is a space is big on the X-rays, you may have to put something like a bone paste or something. And sometimes people aspirate from the iliac bone and graft that bone marrow.
Thank you.
And sometimes you can use a plug as well, bone plugs. Similar what we use as a mosaicoplasty. If you can take up a bone plug from there, retrogrill, you need to drill with a 6.6 or 6.5. There's a, and you can plug as a plug. So inshallah.
Have you ever tried ACL jig to aim where you are going to drill?
No, I am. Yeah, you can use it. Yeah, but
Yeah, it will give you an idea where
but
you're.
then you need an arthroscopic port for
Yeah,
that. No?
yeah, absolutely. Thank you. My next guest speaker is Dr. Harun Majid, or I call him Mr. Harun Majid. He's going to talk about a very hot topic in fixation of the posterior aspect of the ankle fractures. Over to you, Harun. Thank you.
Thank you very much, Sohail Bhai, and thank you to all the organizers for their kind invitation to have me here and share my little experience with you. So in this talk, I'm going to talk about a slightly different approach to managing the ankle fractures, which is a posterolateral approach. So ankle fractures, as we know, are one of the commonest injuries that we treat in our practice. And the place where I work, similar to other major trauma centers in the UK, this is one of the main injuries that I treat in my day-to-day practice. My rough estimate is about 80% of the ankle fractures are complex trimalleolar, just because of a tertiary referral center and the complexities of the mechanisms of injuries and various new sporting activities that the general population is nowadays doing that has changed the dynamics of the ankle fractures. So this talk is not about the isolated, undisplaced posterior malleolus fracture. We're not talking about those which are rare. But trimalleolar fractures, which happen to have a variation in their injury pattern, they have a posterior malleolus fragment and syndesmotic injury, and that's what we are talking about here. So in general, ankle fractures are a huge burden on our NHS expenditures. Overall, they are associated with longer periods of recovery, longer time off the work, and loss of earning for the patient, and burden on the NHS in a way that they require longer follow-ups, physiotherapy support, and despite a good management, they are still not where they were before the injury. So these are potentially life-changing injuries which have consequences in the short, medium, and long terms that they can change the profession of the person, their sporting career can finish, and so on. So about 10 to 15 years ago, this fracture would have been treated with the fixation shown in the picture on the right. This was a standard way of fixing these with a lateral fibular plate, 1 or 2 anteroposterior screws, which we used to think we have done a really nice job in fixing a posterior malleolus fracture, but the reality was that we could even not see the posterior malleolus fragment anymore because it was hidden by the fibular plate by the time we had done the x-rays. And this was based on something which came out in 1940, a paper published by Nelson on just 8 cases. So let me ask you one thing, that is there anything in our lives, let alone medicine or orthopedics, that we do now which is based on something which came out 80 years ago? I think the obvious answer will be no. Things have moved on, we have learned new skills, we have learned new concepts, and everything seems to have changed. Even the medicine that I learned 20 years ago and did my only medicine job, the entire medicine has changed since then. So why are we relying so much on such a historical evidence and fixated here that this is the only way of fixing? It works well. In fact, it doesn't. I think we have to accept the reality, which is now published in many papers, that the 2 screws, front to back, are not enough to give sufficient fixation, stability to the ankle, and the outcomes are really poor in those cases. And this was based on 25% or 33%, whatever it was, and we are so much still fixated on this. And believe me, even in the UK, our non-foot and ankle colleagues are still finding it difficult to accept that we have moved on from that concept. Similarly, other papers which have shown no correlation between the functional outcomes or the development of arthritis based on the fragment size fixation of the posterior malleolus. So if it is not the size that matters here, what exactly it is, what is this fuss about, and why has the concept changed in the last 10 to 15 years? That's really important to understand. So at the end of this talk, I'm not expecting that you will all transform your practice and start fixing them here, but at least it will give you some food for thought, some time to think about this, that this is actually a good option, and it will help your patient management for these. So just take a step back and go to the basic anatomy. Where is the posterior malleolus? What is attached to it? And what does it actually do to make the ankle stable? So posterior malleolus is this posterior and inferior prominence of the distal tibial plafond where the important syndesmotic ligament is connected. And PITFL, or posterior inferior tibiofibular ligament, is actually the most important of the three ligaments that syndesmosis has, and it provides 42% stability to the syndesmosis. And as we know, syndesmosis directly affects the ankle stability in all planes and its ultimate function. And if there is disruption of the syndesmosis or inadequate fixation, then the ankle joint will be affected directly. And the rest of the ligaments have their own importance, but are less in their strength compared to PITFL. And PITFL is the one which is most commonly injured in posterior malleolus fractures. And that's the bit we are talking about here. So it's not about the size of the fragment, it's about what is attached to that fragment, which is the most important structure here. And studies have also shown that a step off in the posterior malleolus fragment of more than 1 millimeter poses a significant risk for development of arthritis and hence poor function in the long term, even in the short term. And therefore, no rocket science, basic AO principle that anatomical reduction, compression, and early mobilization is the key here, and that's the absolute stability concept that we already know, and we manage intra-articular fractures based on that line. Another important study here that showed about 73% patients fixed with anteroposterior screw had a step off compared to only 17% in a direct posterior fixation. And that's not a new study, it's about 30 years old. And that's the bit I was talking about that we cannot see in the intraoperative radiographs after apparent good fixation of a posterior malleolus fracture. So this is actually one of my recent patients who about 10 years ago I would have fixed it as I've talked about. There was a decent sized fragment, and this is how I did it. And the intraoperative picture gives us a really good view of the posterior malleolus fragment because that is done first before the fibular plate goes on. And that's absolute anatomical fixation, rigid fixation, and I can rely on this for early mobilization. And that's how it should be done. And it's just not me saying it. There's enough evidence here. This is a universal consensus in the UK and across the Europe. And in fact, an AP screw fixation of a posterior malleolus fracture is considered negligent in the current practice. Do you agree, Sohail bhai? I hope you do. Right, so the basic clinical assessment is the same as per any other ankle fracture. Mechanism of injury, any other associated injury, any soft tissue problems, and the usual comorbidities which can lead to poor outcomes among general population. Plain X-rays before and after reduction are the key. A CT scan is a must for every trimalleolar fracture because you cannot understand the anatomy based on two-dimensional AP and lateral X-rays. And the more you know about it, the more you think, and it can potentially, or more often it does, change your approach to fixation, change your surgical landmarks and your type of fixation as well. So a CT scan is actually a routine, and in our department, patient can get CT scan before the X-rays in some cases. So this is again one of my other patients, a young lady in her mid-30s, fit and well, isolated and closed injury, and X-rays give us some information that there are 3 fractures here, but on the CT scan of the same patient, it gave us a lot more information. And this is just one example, and I can quote lots of these here. So here we can see a posterolateral fragment, a posteromedial separate fragment, a separate medial malleolus fragment, and obviously a fibula fracture, but on top of that, this fragment here is from the anterolateral distal tibial plafond. It's not from the fibula. And intraoperatively, this was actually found trapped in the fibular fracture. So we got a lot of information on the CT scan compared to these X-rays. So following the same basic principles, anatomical reduction, and again there is a trapped fragment within the fracture site which required pushing out for an adequate reduction. Sagittal view of the same patient, and the intraoperative picture here, you can see a little dent here, but that actually is not a step off. There is this piece of small fragment which came off while reducing the fracture. So that is reduced, but with a slight loss of articular surface, which we can't do anything about. So this is the final picture of the same patient, and I was very satisfied with this anatomical reduction. And an important part here is that there is a small metal pin which is holding on to that little separate piece of fragment. It's only a 1.5 millimeter twist-off type pin, which was only for that fragment. So we've achieved excellent and sufficient stability by addressing all the fracture fragments and restoring the joint surface as much as possible. Ankle mortise looks normal, and you can't see the fractures at all on this view. Another few examples, typical posterior malleolus fracture. Again, we're not looking at the size of the fragment, we are looking at the overall stability of the soft tissues which are attached to this. But the purpose of showing you these is that CT scan is a must for these. You cannot manage these patients without appropriate information. We can keep going on these. Again, anatomical reduction. This was one of my colleagues who did it. So, posterior malleolus versus syndesmotic fixation. There is enough evidence in the literature now that if you directly fix the posterior malleolus, restore the articular surface, and the fibula sits well and better in its notch compared to trying to fix it separately with a syndesmotic screw. And if you restore the stability of PITFL, by default, you have stabilized the syndesmosis and you do not require separate syndesmotic fixation. However, having said that, there are still some cases where syndesmosis still looks unstable intraoperatively, and it's a must to check your syndesmosis at the end of your fixation. The evidence suggests that if you do added screws to syndesmosis on top of your posterior fixation, they get more stiffness, and the functions are inferior compared to the ones without syndesmosis screws in these patients. And if the screw breaks, it relaxes the syndesmosis, and then it improves the function. But the key is to stabilize everything as much as possible. You can remove the screws if you want later on. And overall, direct comparison shows that posterior fixation gives you less stiffness compared to syndesmotic fixation with the older technique. So I hope this makes sense, what we have discussed so far. Like everything else in orthopedics and trauma, there is a classification and there is evolution of classification. Haraguchi, about 30 odd years ago, described, which was used for a long time, and that was an isolated posterolateral fragment. Type 2 was medial extension type, and 3 was small shell type. Then a few years ago, the guys from Liverpool, who are very well known for their work on posterior malleolus, Lyndon Mason and Andy Molloy, they have published their classification, which is nowadays widely used, and it's considered better because of its prognostic and predictive value. Type 1 is a small fragment, essentially a soft tissue injury to the back with a very small fragment. Type 2 is a proper posterolateral fragment. Type 2A, and type 2B is extension to the medial side as well with a separate fragment, and 3 is a vertical peel-on type, more complex and more unstable injury. So based on that, what their recommendation is, which has now become a journal consensus as well among the wider community, is that type 1, you don't need to fix directly, because as long as you stabilize syndesmosis in these cases, that is considered sufficient, and there is no additional benefit. Because posterolateral approach, which I'll briefly mention about its steps, is not a benign approach either. It has its own morbidities and complexities, so you have to be careful and learn it properly, do it properly, and then practice it for these genuinely valid cases. And type 2A and 3, you require a direct posterolateral fixation. And type 2B, in addition, you also may require a posteromedial fixation for that fragment as well. because sometimes you cannot reduce the posterolateral without reducing the posteromedial because of a trapped fragment. So the purpose of telling you all of this is one size doesn't fit all. All ankle fractures are different. There are times when I have 4 ankle fractures on my list, and all 4 are different. They require separate fixation in each of them, and every case requires its own planning. Gone are the days with a flimsy third tubular plate with 2 medial screws or 2 AP screws or 2 syndesmosis screws. That doesn't work for every ankle fracture. So posterolateral and posteromedial are the 2 options for addressing the back of the tibia. Posterolateral allows us to have a really good view of the posterior fibula, posterior tibia, and the incisura. Posteromedial surprisingly gives us an excellent view of the entire back of the tibia. And there is a trend now to switch to posteromedial because of some potential problems due to peroneal artery in the posterolateral fixation as well. So it's important to learn both of these, utilize to your benefit as needed. When I started doing them, I used to do them in prone position, which works well in terms of the surgery itself, but the overall fuss about the anesthetic sides, it takes a lot longer and everything gets delayed. So then I switched to doing them in a true lateral position as we do for total hip replacements, front and back supports, and the leg is rested on pillows or a foam block if you have that available. The incision is halfway between the posterior edge of the fibula and the lateral edge of the Achilles tendon, and the only important structure you have to be careful in that is sural nerve, which is right underneath there, and that has to be protected after its identification. Then you go through the fascia and separate out the FHL, and deeper down you are straight onto the posterior malleolus, and this probe is on the posterior malleolus fragment itself, which gives you an excellent view to achieve reduction and fixation. And then peroneal tendons can be reflected onto the other side, and you are straight down to the back of the fibula for your direct fixation. Posteromedial approach, again, it is frowned upon and a bit scared, but we do work around the nerves and vessels in the rest of the body, so don't know what is this fuss about. We don't cut them, we just look after them and dissect them out and protect them. So I don't think that's a matter of concern as long as you're careful. It is usually done in a supine position with a slight external rotation and a figure of 4, and that gives an excellent view if you go just about a centimeter behind the posterior malleolus and through the sheath of the posterior tibialis posterior tendon, and you can see all the way to the back of the tibia. Another one of mine recently, isolated closed injury, and the usual routine of initial reduction, soft tissue management, CT scan, and then planning for fixation. And this plate, which looks really on the posterolateral fragment, I did it through the posteromedial approach, and it worked really well. And again, nothing to show off, but it's absolute anatomical reduction, and you cannot see that fracture fragment at all. So now, I wouldn't take much time on this, but the story of this guy is so painful that I want to share with you to let some burden off my mind. He came to me recently for a second opinion. He's currently 34 years old, and his ankle injury occurred 19 years ago when he was only a 15 years old young boy playing with his friend, playing football, and a tackle went badly, isolated and closed injury. He was managed in one of the local hospitals somewhere around Manchester. So in those days, CT scan wasn't really a routine for these, but there is a decent sized chunk of the posterior malleolus which was probably not even looked at. And clearly there is a syndesmotic injury as well. Surprisingly, this is how it was fixed in the mainland UK. You can clearly see that there are lots of flaws in this fixation. And I'm not pointing out anybody's mistakes because we all make such mistakes in theater, or some not deliberate mistakes, but things are difficult sometimes. But these are the cases where we should reflect on and improve our own practice to minimize the risk to these patients. And clearly there is something happening there. 8 months later, he came back, or when he was being followed up, there are obvious changes of arthritis. 5 years later, the story progresses on, disabling symptoms of arthritis with no doubts that what is going on there. He went to another surgeon in another hospital who did an ankle fusion on him when he was in his early 20s. The story continues, and his ankle never reverted to normal again, continued to be very painful. He lost he couldn't even start working, and let alone playing any sports. So another surgeon in the earlier part of this year did a triple fusion on him because his adjacent joint arthritis had occurred as the ankle was fused in such an early age. And he did a triple fusion which healed this is a 2 months post-op x-ray, healed well because his biology is perfectly fine. He's a non-smoker. And he didn't complain of any major issues after his ankle fusion other than the routine ongoing pain. But when he had triple fusion done, then the problem in the ankle got highlighted because the ankle was slightly plantar flexed when it was fused, and he started to hyperextend his knee because there was no compensatory mechanism left in his hind foot. So then, this is his leg with multiple scars and basically looks like a defunctioned neurological type deformity. So then, his pain got worse after his triple fusion. His triple fusion surgeon then offered him excision of TMT joints, which, again, not sure what exactly his thoughts process was. So he started exploring second opinions, and that's why he ended up in my clinic. And my honest answer to him was, if it was my leg, I wouldn't have any more surgery, especially the one which was described. And my idea that he needs to see a limb recon surgeon to possibly correct the deformity at his ankle, maybe that reduces the hyperextension at his knee joint. So the purpose of showing you this is that ankle fractures are not benign injuries. They are complex, they are difficult to manage, they have a huge impact in the short and long term, and they are really potentially limb-threatening as well. So coming back to the point, my usual routine is 2 weeks in a back slab, mainly for wound care and limit the weight bearing. Then the patient goes into a boot on which they can start to weight bear because I rely on my stable fixation and I'm happy for them to weight bear consistently. Unless there is a concern, then I can change. So they start mobilizing, especially dorsiflexion is really important at 2 weeks' time because they get stiff in dorsiflexion. And weight bearing with the boot on till 6 weeks, and then wean off the boot beyond 6 weeks, and then increase their physiotherapy input. 12 weeks, I'm happy for them to do non-impact activities, and 6 months, more or less, if they're recovered well, they can go back to playing sports. However, we have to be careful in their wound management because this is one of mine, posteromedial, which slowly settle down, but these wounds, they let us down, and we have to really, really carefully manage them intraoperatively and postoperatively. A few general tips that you need to know your positioning, your setup, and all the planning is actually done before you start the case. In theater, it's only the implementation of your plan, right? So have all the gadgets and all the available tools that can help you to make a smooth journey in theater. CT scan, like I said, is a must because it helps you to understand the anatomy, and that usually changes your initial management plan, and then plan your surgical approach and implement it carefully. So you need to understand the variation in the fracture patterns, and like I said, one size doesn't fit all. Assess the syndesmosis, and outcomes are really worse compared to bimalleolar fractures. And there are lots of studies available in the literature with larger number of series which show that the complexity of the fracture is directly proportional to worse outcome. And even with best surgical fixation, the outcomes are not brilliant. So you have to counsel the patient that your life and your ankle will not be the same as it was before you broke it. Multiple other studies which I can keep going, and there is enough evidence to support what I have told you. And this fracture, luckily this is not one of mine, this is not the way to fix it anymore. This has to change, and this has already changed across the rest of the world, and this is how it should be fixed. So in summary, posterior malleolus fractures require direct fixation with robust metalwork after a proper, careful CT planning and careful soft tissue handling. Fragment size does not matter anymore, and aim is to restore the anatomy and stability, not only of the posterior fragment, but that's directly attached to the syndesmosis, which directly affects the function and stability of the ankle. Thank you very much.
Anybody has any questions?
Professor. Nice talk. And it's most common topic we are facing here. It's daily practice, everybody is doing posterior malleus fixation. But somehow you change it. What do you think, why people have followed such a huge time for only fixation for the entry screw? Why not they switch earlier, 50 years back, think about the fixation and posterior? So what do you think? I think the only reason was everybody was not opening the posterior side and feel this posterior approach is somehow difficult to go and put some plate inside. So what do you think? What was the reason?
I don't know, difficult to say, but I think probably it's easier because it's quicker, only one percutaneous incision, and just fool yourself that you have done a good fixation with a partially threaded cancellous screw. We all have done it. Probably, I think the acceptance of change, don't know why, difficult to say on a personal note, but I think it's the ease of convenience. Supine position, sandbag, direct medial, direct lateral, 2 screws, job is done in 10 minutes, but that's not, I think, the reason to do it. So luckily there has been a change. We don't know what will be the long-term outcome even after these. We may find more problems with posterior plates, which are not easy to take out if you have to take out. So again, like I said, it's not a benign approach. But there is enough merit to fix them, but you have to do them properly rather than just fixing things without any concept.
The plates you are applying, so they're contoured?
No, this is a straight plate, titanium, Striker Very X set. And the reason for doing a straight plate is that actually the plate does the main job. So I don't disrupt the posterior soft tissues as much as possible unless I have to release that trapped fragment. Just use a small McDonald to poke that out. Otherwise, it's important to keep all the soft tissue attachments to the fragment. And then the plate, I normally use 5-hole or a 4-hole titanium straight plate without molding, contouring, and it does a very nice buttressing for you. And then the last screw or the second last you can use as a compression screw. And sorry.
Yeah, sometimes the posterior piece is highly comminuted. So even your single side plate, it doesn't hold all the fragments. So sometimes you need plate like floss or so, you need a T-plate. So they are built bulkier as well to put on the posterior side because tendoachilles is there, vessels are there. So if you put bulkier plate on the posterior side, they will create another problems as well. So
yes,
we have seen people have tried these plates on the posterior side, the T-plates, and it's a bit bulkier as well.
Yeah.
So what do you experience other plates, because this is single plate, yeah? There are no other.
Single plate.
No.
But if I'm doing a type 2B fracture, then I have to open up the posteromedial side as well and use a separate small 2.7 plate as well, which is a lot low profile. The reason for not doing a T-plate is that in our department, we have Synthes T-plate, which are pre-contoured. So they don't give that satisfaction of the buttressing unless the fracture is anatomically reduced. But this plate does a great work for you.
Thank you.
Just a comment on that, your question, why we do more. We have understand more biomechanics, the importance of that fragment, the chopard fragment. That's the one reason, and we have a very nice plates available. And the approach is very simple. As soon as you find out FHL, you are safe. The key thing is to find the FHL. That's my comment.
One more thing.
Which approach is more easier for the youngsters?
Sorry, say again.
Which approach, posterior medial or posterior lateral approach, more easier?
Posterolateral is a little bit more straightforward, but if you do posteromedial, learn it well, it is fairly straightforward as well. We go deeper down into the hip joint. This is a lot more closer to the skin than the hip joint, so it's technically a lot easier. But any approach that you can learn, practice, becomes easy with time.
And what about your 3 incisions? If you sometimes put 3 plates, I have seen people have put 4 plates as well. So later on, if you put 4 plates, very small skin are around the ankle. Once they get infected, the soul get destroyed. So this is one of the major problems. You put 3 plates, 4 plates, too much implant around. Want to catch everything with the plates. So there's a big problem with the ankle joint.
Yes, exactly.
So this is one of the things we should care about.
Yes. So only enough metal that is required for fixation, nothing unnecessary to show off.
Can I say something? मैंने पाकिस्तान में training की थी. Unlike Harun and Syed, I'm a hybrid trainee. 1/3 tubular plate does everything. Okay, we need fancy plates if the bone is protic. That's fine. 1/3 tubular plate, reduce the fracture. Put a screw at the apex of the fracture. Use the 1/3 tubular plate to reduce and compress the fracture. If you have a bicortical screw, it will get a great compression. You don't need a T-plate or 4 plates. You reduce the fracture, in my opinion, well. That is the key. That is the key for all orthopedic practice. You understand what is the configuration of the fracture. In posterior malleolus fracture especially, there is usually a fragment which is impacted in the joint. You need to reduce or remove that fragment. And once it is removed, you can put a 1/3 tubular plate that do a fantastic job. They are great plates. They are very good design, low profile plate. But I haven't found a better match than a 1/3 tubular plate in my hand for any fracture.
So that is a really good concept, and it's like driving a car. It's not the car, it's the driver. So if you do it well, follow the principles, I totally agree. It's just the availability that makes us use those fancy plates and gives us a bit more OCD satisfaction. But there was a biomechanical study from Cardiff which showed that for tibial plateau fractures, third tubular, buttress and compression has excellent biomechanical stability. So nothing wrong with third tubular plate. Totally agree.
Just a comment. Is irrespective of the size of the posterior fragment, it has to be fixed to achieve the stability of the ankle joint and to achieve the ligamentous stability also. For all posterior malleolar fractures, irrespective, again I'll say irrespective of the size, I fix them with percutaneous screws. It's a very easy approach. You put the patient in prone, under image intensifier you reduce, you pass a K-wire after reduction, and then you pass just two cannulated cancellous screws. And I have done a number of cases. I presented this paper last time also. So I have never used a plate, but I am happy with my results. Thank you.
Like many other things, whichever works in our hands is perfectly fine. There are more than many ways of doing things. If it works for you, for your patients, absolutely fine. And the trouble with majority of our patients in general is that we can tell them whatever we want to tell them for weight bearing, but they all do whatever they want to do. So in central Manchester, we certainly cannot rely on our cohort. So we have to make a robust fixation, give them a boot, let them walk on it, and sometimes things still fall apart.
So the patient whom you just showed with multiple complications, the one with footballer injury with sequence fixations and multiple complications, is there any advancement in total ankle arthroplasty that we could have used in that patient at some point before he had that triple fusion, when he just had a simple ankle arthritis? Is there any advancement in the total ankle arthroplasty that we could have used?
Yes, not in my personal experience yet, but there is a guy called Victor Valderbano who is well known in Foot and Ankle Society. He does exact vintage ankle replacements. And I went to attend a course with him earlier in the year. He actually does his ankle in younger patients, let them play sports on it, which is a little bit courageous and crazy, I think. But his thought is that the quality of life is impaired now. So what's the point in waiting till the age of 55 while those 30 years will be gone? If it fails, he says, I'll revise it in 10 years. But that's a different approach. Joints are meant to be mobilized. They're not meant to be fused. That's another theory as well. Do we fuse any hips, knees, or shoulders now, other than very rare indications? So why do we fuse the ankles now? It's meant to be moved.
Thank you, Dr. Harun. I think
Thank you very much for your attention.
Very detailed discussion, and we generated a lot of interest. So please feel free to contact Dr. Harun later on after the session. We need to move on with the subsequent talk. My name is Tashfeen Ahmed. Apologies for joining late. So the next talk is by Dr. Sohail Yusuf. Dr. Sohail Yusuf works in the UK in NHS hospitals. And he is a specialist foot and ankle surgeon. He's going to talk to us about lateral ankle instability, which is collateral instability of the ankle. Thank you.
Thank you very much. Assalamu alaikum everybody. सिर्फ एक छोटी सी बात, कल आप वहीं मसरूफ़ थे इसलिए आपने सेशन अटेंड नहीं किया. हमने ankle arthroplasty cover की थी, right? So आपने, but anyway, we're going to talk about ankle arthroscopy, ligament repair, when, why, and how I do it. I'm not the best person to do it, but in my practice, I have a lot of sports injuries because I live in a part of the world where there are lots of schools, lots of commuters going to London, and they have young children. And that's where I work. That's why my team. I'm showing my team's picture because these complex injuries can be done by people who work with you regularly. If they are not your part of the team or a member of your team, it becomes very hard to find the correct instruments at the right time. When we covered it yesterday as well, ankle arthroscopy is done for lots of reasons. There is enough evidence that ankle arthroscopy is the suitable management option for these problems. Open approaches to the ankles are associated with risk of scar formation, damage to the neurovascular bundle, and arthropibrosis. Why I do an ankle arthroscopy for a lateral ligament injury? That is my talk. There should be a history of injury and subsequent instability. And when I say instability, that should be a functional instability. They walk, they feel their ankle is moving underneath the weight of their body. They come and down the stairs, they feel they are going to fall. They are usually young people. Old people people of my age have arthritis. They usually do not have instability. If they are complaining of instability, that is probably from some other reasons. They may have tendon tears. Their peroneal longus or brevis tendon is subluxing. They usually do not have ligament injury leading to instability. Instability is a young problem. That's my take. Be careful about the Baton score. Baton score is a score for hyperlaxity of the joints. It has 9 points. People complaining of instability with high score, you need to be very careful. These are 2 x-rays. On the left side, this patient has a very subtle tilt of the tibio-talar joint. On the right side, this is the right side of me, has quite significant opening of the joint. Which one, in your opinion, is a ligament injury and which one is a Baton score? Hands up, someone think on the left side, right side of your screen is a ligament injury. Okay, and what do you think? Anybody think the picture on the right could be a hyperlax joint without any ligament injury? High Baton score? These are the x-ray of the same patient. Right, so this is, if you look at the lateral side, there's a small freckle bone. This is the same patient. He has a very high Baton score. This hyperlaxity is due to neuromuscular reason, Ehlers-Danlos syndrome. It does not have an ankle injury. Okay, just a word of caution. Why? Again, why? If there is an impingement, an OCD on MRI scan, which is causing problems associated with an ATFL injury. Sometimes ATFL injury itself is not causing the problem, but associated damage to the cartilage or subsequent changes around the cartilage can cause problems, and you have to do something about this ligament. You have to stabilize the ligament because there will be progression of arthritis otherwise in a younger patient. I'm not just talking about arthroscopic fusion, arthroscopic ligament repair. I'm just talking about arthroscopic and open. Coming down to arthroscopic, which is the workhorse for my practice, I use an ankle distractor. I put the patient on this distractor to open the joint. I have a better access and have less chances of damaging the ligament or the cartilage in a young person with my instruments. I can cause more damage with my instruments than the injury has caused to this patient. This is my setup. My fellow is doing this operation. We took these pictures just 3 days before I came here. Patient is supine. The leg holder is distracting. It is about midway in the table. About my finger breadth hand, the heel is away from the edge of the table when I start without flexing the knee. Once we flex the knee, then the rest is like an ankle arthroscopy setup. The knee arthroscopy setup. Your stack is there, your nurse is behind you, there is water everywhere. First of all, you need to find a joint. In case of knee arthroscopy, you can close your eyes, find the soft spot, and get into the joint. I cannot do an ankle arthroscopy if I have not done at least 100 knee scopes. You cannot perform an ankle arthroscopy directly. If you want to do an ankle arthroscopy, if someone interested, you should do more and more knee scopes first, get used to the triangulation, and it's not that hard. If you do not have ankle distractor, I put the patient supine, slightly raise the foot end, and tie the ankle with a ankle holder, tie something around my waist, and pull the ankle with my weight. I am very slim. I'm only 38 or 40 kilos. Sayyid is about 100 kilos, so he can pull it very well. But if you are not very strong, it is very difficult to distract the ankle for a long time. You get tired. Your back really hurt. But this is one way of doing it. Then you find the joint. My fellow in the middle picture has put a needle to inflate the joint. And then he put a 10 ml syringe. Then you see whether the water is coming back with a jet. That means you are in the joint. You have inflated the joint. Water is coming out. You have found the joint. You dorsiflex the foot. You enter from the medial side first. And then you make a lateral portal under arthroscopic control. You find a needle just like a knee arthroscopy. You go parallel to the joint. You should not be below. You shouldn't be too high. It should be parallel to the joint. And then you make a small incision, spread the skin to avoid the damage to the superficial peroneal nerve. The next step is surgical technique. Luckily, ankle does not have an ACL. There is no neurovascular bundle on the back, which you can damage very easily. The neurovascular bundle is on the front. So you get into the ankle. Can we play the video? No. Can you click on the video on the left side? So with a lateral ankle instability, the lateral side is opening up. You go in slowly. You look at the tibia. If there's any problem, you probably will ignore the tibial problems. Very difficult to manage the OCDs on the tibia. But on the talus, which is on the undersurface of this picture, you look for any damage. And then you go into the lateral corner. This is the syndesmosis, tibiofibular overlap. On the top right picture, you can see some redness and synovitis. If there is an associated syndesmosis injury, usually there is some synovitis. That's an indication that the patient may have an associated syndesmosis injury. On the bottom right, you can have some fraying of the cartilage. This is not full thickness deep. Don't worry too much about it if you see that. That's what I look for with an associated lateral ligament injury. Then if there is any impingement, any synovitis, debridement is often helpful. It creates more space for the ankle joint, reduce the impingement, and there is enough evidence that arthroscopic debridement of the ankle on its own is very useful. Sometimes you see osteophytes. Even if you're not doing arthroscopic debridements, be careful. These osteophytes sometimes limit the movement in an arthritic joint. And if you remove those osteophytes and increase the range of motion of that ankle, it may well be very painful for that patient. You make him worse or her worse. Debridement of any osteophyte is done under direct vision. I use the thickness of the shaver to find the depth of the bone which I'm going to remove. And that's how I use it. Clear some space. You'll see the difference between the two pictures. And your ankle will move slightly more freely. Just a lateral ligament reconstruction on its own is not going to work well. The next step is if there's a microfracture, which a Sayyid has covered, you debride it. That's my anatomical repair, which can be done with or without arthroscopic preparation of the ankle joint. Your landmarks are distal fibula. You can make a transverse incision. I prefer a longitudinal incision. It is along the anterior border of the fibula, moving towards the fourth ray. It is extensile. I can extend the incision. You can do a curvilinear incision, which was initially described by Brostrom. However, its extension is difficult. In the front, you can damage the superficial peroneal nerve. On the back, you can damage the sural nerve. There is also difficulty in assessing anterolateral part of the ligament. You then remove the remaining part of the ligament from the fibula, take a ronger and curette a little bit of a bone which is extra-articular. That will cause some bleeding bone and will help to hold the anchors which you can put in to the fibula. On the right side of the picture, which is my right, you can see that I have passed sutures through the remnants of the ligament, and sometimes the retinaculum is visible more than the ligament. Then you can pull them and then tie them together. This is called anatomical repair, and that is my preferred way of treating young people with a primary injury which is not very old. Anatomical repair, Bostrom Gould, been around for many years. You do not need to do any fancy operations. When you repair and do a final knot, you evert the ankle, so you take the tension off from the ankle, keep it dorsiflex, and then you tie it. This is one of my cases, 19 years old female, semi-professional footballer. She had an injury in January 2022 that she has been managed before coming to me for some tendon problem, and her Baton score was 5. Can we play the video? Show of hands, please, who thinks the tendon is subluxing? Okay, play the video again, please. Okay. If the tendon is subluxing, what's happening to the fibula? It's not working. Point. Right, thank you. Sorry about that. So, if the peroneal, play the video again, please. If the peroneal tendon is subluxing, can one more time, please, the video. And you can see the fibula is moving backward as well. So this is a semi-professional footballer, high energy trauma. She has ripped everything around her ankle along with syndesmosis. So in my opinion, it's not just peroneal subluxation. Her whole ankle is subluxing posterolaterally. It's a rotational instability of the ankle. Can you play the video again? This is a standing CT, which I have the privilege of getting it done in my hospital. Not many hospitals have that facility. It helped me to compare both sides. If you do not have a standing CT, you can get a normal CT. And again, you can see the fibula is subluxing on the back. Play the video again, please. Intraoperatively, then the other video, here we go. The same patient, the ligament is completely lax. If you pull the ankle forward, it is subluxing forward. And the bottom video is showing intraoperatively how we have reduced and held the ankle together. Okay. In this case, with such evident posterolateral instability, I used an internal brace. My repair is here, and the two other sutures are for the internal brace. This is an augmentation. I do not use internal brace, as I mentioned earlier, for simple, straightforward ligamental injuries because I think they can be problematic. There's a lot of buzz about internal brace. I'm very cautious about internal brace. I use them routinely, but very selectively. This is the principles of internal brace. You find, you make a hole in the fibula, and the distal end. Then you make another portal for at a 45 degrees for the talus, and if the CFL is affected, you go into the calcaneus as well. This is something which can be done arthroscopically. I haven't tried this, and I don't want to do this because in a very small incision, I can do quite good work, and I'm quite happy with my results so far. What is my rehab protocol after these injuries? 2 weeks of non-weight bearing. I would like them to slow down, let the wound heal. Ankle is quite swollen with the arthroscopy, and it allows the ankle to settle down as well. I keep the ankle in a neutral dorsiflexion. Next 4 weeks, weight bearing is allowed in a boot or a brace. They can sleep without the brace or the boot. They can do gentle range of motion exercises, but no inversion. And further, this rehab progressively continue for 10 to 12 weeks, and they are allowed to go back to high-level sports at 12 to 16 weeks' time. What can go wrong? Neurovascular injury, superficial peroneal nerve, and it is quite possible to damage the superficial peroneal nerve. You can damage the sural nerve if you are repairing the CFL because you have to retract the peroneal tendon. Sometimes you can damage it. You can damage the peroneal tendon as well, by the way. Infection is very rare. If there is one, sinus tract formation is possible. I haven't seen it in my life. Painful incisional scars, yes, I have seen them. Too tight. Especially with an internal brace, if your repair is too tight, it's not a bad thing. They feel it is too tight because their ligament or ankle has been very lax for a period of time. So they actually prefer too tight, and it feels good. Fractures or intra-articular tunnels can be caused by the wrong placement of internal brace portals and can cause impingement. That's me done. Thank you.
Thank you, Dr. Sohail. So we'll take questions after the next talk. So the next talk is by Professor Irfan Mehboob. Dr. Irfan Mehboob has been the head of the Postgraduate Medical Institute, Lahore, and he's going to talk to us about calcaneal fractures, operative and non-operative management.
Bismillah ar-Rahman ar-Rahim. So the calcaneal fractures. So this is the biggest or the largest bone of the foot, and it forms the foundation of the foot where the entire body is putting on its weight. So in my talk, I'll be discussing about a bit of anatomy, the signs and symptoms of these fractures, and the classification, how to manage, and what are the different options to manage. So you can see this is the largest bone, and it articulates with the talus superiorly and the cuboid anteriorly. It's, as far as the consistency is concerned, it's dense cancellous bone, which is covered with a very thin cortical bone. You can see it over here, the relations of calcaneus with the other bones of the foot. The articular surface, it has an articular surface, which is in the anterior half of, and there is a tuberosity on the posterior half. It forms the heel, and it acts as a lever between the gastrocnemius and the foot. And it's the foundation of the body weight. In sports, and it supports and maintains the lateral column of the foot. So these are the functions of this bone. You can see over here how it is forming the foundation of the hind foot. And if there is any disturbance in it, it may lead to either the flat foot deformity or the cavus deformity. Now this is the bone which is commonly fractured, and the incidence of these fractures is about 11.5 per 100,000 trauma patients or the population. The male to female ratio is about 2.4, and the peak incidence is at the age of 20 to 30 years. And these are, most of the patients are those who are involved in work. And the usual cause of this fracture is fall from the height, and in some patients it may be as a result of trauma. So in about 71% of the cases, it is fall from the height. Whereas in 18.8% of the cases, it is because of the other like trauma and the motor vehicle accidents. It may occur as an isolated injury, or it may be associated with the injuries to the other parts of the body, like the injury to the tibia, or maybe the knee joint and the proximal or the distal femur also. But anyhow, in most of the cases, it is just an isolated injury. Then, most of the times when there is fall from the height, it may be bilateral calcaneal fractures. These fractures could be displaced or undisplaced. In displaced intra-articular fractures, they are about 60 to 70%. And these are intra-articular because the mechanism of injury is such that talus that impinges on the surface of the calcaneus and results into the displacement. This is not working. I'm sorry, this is not working. Okay, before going into detail of the fracture, you can see a bit of anatomy over here. If you see this, there is a fibula and the posterior aspect, the tibia, the medial malleolus, the lateral malleolus, and then you see the articular surfaces. The articular surface of the calcaneus, it has a posterior facet, and there is anterior and the middle facet, and there is medial, on the medial side there is a tuberosity. Then if you see from the lateral view, we have the sustentaculum thalli and the peroneal tubercle. And the anteriorly joins with it forms a joint with the cuboid. Now, and from the different views, you can further see a detailed anatomy, and you see the gastrocnemius, which is attached to the tuberosity over here. The blood supply and the different vessels which wind around calcaneus, and you can see it over here. That's how the calcaneus is supplied. The ligaments which are attached with the calcaneus and the other bones. And the tendons which pass through, and they have different type of relations with the calcaneus. And the further ligaments over here. Now, this is important that when we think of these fractures and we opt for the operative treatment, then one has to keep it in mind, the neurovascular bundle and the sustentaculum thalli. And there's a small ligament which is the medial talocalcaneal ligament, which attaches the calcaneus with the talus. And since our approach is on the same side, so there are chances that we might not damage these important structures. So it also provides attachment to the different muscles like gastrocnemius, soleus, plantaris, abductor hallucis, and the flexor digitorum brevis. Now this is important that histologically, because the calcaneus is a very cancellous bone, and it has a very thin cortical shell over it. Now there are certain trabeculae, if you see in detail, that these are the trabeculae which are supporting the thick part of the calcaneus, which are just below the articular surfaces or the articular process of the calcaneus. And these are the compressive and the tensile trabeculae. You can see it over here. And in between the trabeculae, there is a small zone where this bone is very thin or the bone is deficient, and that is called the neutral angle. Neutral triangle. Now, the Professor Harrison, he says that fixing it is just like nailing the custard pie to the wall. So once you go and try to plan the fractures, you must keep it in mind that it's very difficult to fix the fractures of calcaneus. It's not all that easy. As far as the symptoms are concerned, there are usual symptoms like pain, swelling, and the swelling is marked, and it is always out of proportion as compared to the trauma. And the one sign is that there is, most of the times the patients, they come with this sign, and that is because of the blood which has been clotted, that is under the skin. And there is bruising, and sometimes the patient comes with the blisters also, and the marked swelling. So you can see the bruising over here, and the swelling could be in the entire foot or only in the heel. And if there's a late presentation, you might see that there is a disruption of the skin or breach in the skin also, which makes your treatment difficult. And even in these cases, you can have blisters like this. And the symptoms, they are proportionate to the severity of the fracture. If the fracture is as severe, the symptoms will also be more. Now, before we make the diagnosis, we must understand a bit of the anatomy. And for that, we have to have the lateral view, AP view, Broaden's view, Harris view, and X-ray of the uninjured contralateral extremity in certain cases. If we have the lateral view, we can make the diagnosis of tongue-type fracture because it's the decrease in the Bowler's angle, the fractures of the posterior articular surface, and the anterior process of the calcaneus. And in AP view, we can see the extension of these fractures into the calcaneocuboid joint. The Broaden view, which is an oblique view of the posterior articular surface, and that tells about the italo-calcaneal joint, and it tells about the fractures which are extending into the calcaneocuboid joint. And it helps in making the preoperative and intraoperative plans. In the axial view, which is the primary displacements and angulation of the tuberosity can be seen, and that also tells about the width of the heel. So sometimes in children, when there is a doubt of fracture, especially in the posterior aspect, you might have to have the X-ray of the contralateral heel also to make the diagnosis. The tongue-type fractures I'll discuss over here. Okay. Now, this is the lateral view of the normal heel. You can see over here the tubercle, the sinus tarsi, the talocalcaneal joint, cuboid, sustentaculum tali, and the calcaneum itself. Obviously, the talus is on the top of these. Now, these are the primary compressive and the secondary compressive, primary tensile, the secondary tensile trabeculae, which support the calcaneus. And in between, you can see over here, there is this area which is a neutral triangle. And these trabeculae, they help in making the contour of the articular processes of the calcaneus. Now, on the lateral view, you have two angles to see. One is the Bowler's angles, and the second is the Ghisenius angle. Now, when there is fracture, both the angles are disturbed, and this is very important to restore. Now, this area which is shown as yellow, that's a neutral triangle. This neutral triangle is prone to impaction in the typical compression fracture. The cortical bone is especially thin, and the lateral wall of the calcaneus, which leads to its bulging and the calcaneal fractures. You can see the talus, which sits right over the neutral triangle, and the talus acts as an axe, and it splits the calcaneus into different parts. No, there are fat pairs also, I think this is a bit too much detail. Now, on AP view, the calcaneus appears like this, and you can just see the extension of fractures if they are going into the cuboid joint, calcaneocuboid joint, or the talonavicular joint. Now, this is the lateral view. Most of the time, we use the lateral view to see the fractures, because in the AP view, it's very difficult to make the outline of the fractures. Now the broadens view, which is an oblique view of the posterior articular surface, it tells only the extension of the fractures into the different joints. Now this is the broadens view. That is how we take the broaden view. So this view helps in making the fractures of very clear subtentaculum tali fractures. Now there is another view which is called the Harris axial view, which tells you about the primary displacement and angulation of the tuberosity, and any increase in the heel width. Now see the fracture of the heel over here, and increase in the width will be shown by the Harris axial view. Now you see, if you see the lateral view, you will not be able to see this fracture, but if you see the Harris axial view, you will be able to see the fracture very clearly. So that's the importance of this view. So for intra-articular fracture, and when they are displaced, we have to measure the Bowler's angle, the critical angle of Ghisane, calcaneal height and length, calcaneal pitch angle, and calcaneal tangential view. So this was the person who described the Bowler's angle somewhere in 1931. And this is how we mark the Bowler's angle. These are the two lines which pass through the highest points of the calcaneus posteriorly and anteriorly. And the normal variation of the angle is about 40 degrees. When it is reduced, that tells that something is wrong and maybe a fracture. So that is the normal Bowler's angle, and in the fracture case, you see the angle has been reduced. Now the critical angle of Ghisane by William Ghisane, somewhere in 1998. So this chap, he gave the treatment as well as the classification of the fractures also. So this is the Ghisane's angle, which passes through the articular surface, articular processes of the calcaneus anteriorly and through the point of the calcaneus posteriorly. And the normal angle is between 95 to 105 degrees. Now if you see over here, the angle is disturbed. Calcaneal length, height, and width. So in different X-rays, we can measure the height of the calcaneus and the length of the calcaneus also, and the width. And once we have restored the normal anatomy, then we recalculate the angles, whether the anatomy has been restored properly or not. Calcaneal pitch angle. These are the two lines which are passing on the undersurface of the calcaneus to tell us about the calcaneal pitch line. Now, this is the usual mechanism of injury, that is the high fall from the height. And in other cases, there may be a twisting injury or the motor vehicle accidents like this. So in classification, broadly speaking, there are intra-articular and extra-articular fractures. The extra-articular fractures are about 25% and 75% are intra-articular. The extra-articulars are anterior process, beak of the tuberosity, and sustentaculum tali. Okay, I'll finish it in 2 minutes. So you can see over here. So tuberosity fractures, they are not involving the intra-articular surface, and in this case, the angles are already restored, so nothing to do about that. The associated injuries, one has to keep it in mind. Now for these fractures, we have different options available. That is, either we go for the closed reduction, that is the conservative treatment, or we can even go for the percutaneous K-wire or the screw fixation, or the open reduction and fixation with the plates and all that. So if the fracture is very simple like this, I think even if you apply the plaster cast, that is good enough, because in this case, the angles are restored, the width of the calcaneus is maintained, the height is maintained, and they can be very well managed on the plaster cast also for a couple of weeks. But if there is a displacement of the fracture, then one has to reduce it and fix it. Now, fixation can be with percutaneous screws, or you open it up and fix it. This is tentaculum tali. Now, different types of plates are available, and they are available over here also. It depends upon your choice, training, and learning curve, whether you can apply it or not. But usually it becomes very difficult to restore the proper anatomy of the calcaneus if the fracture is of this type. And for all different types of fracture, there are different types of plates available. So you have to plan it very carefully, pre-operative, that what is the nature of the fracture and how you are going to fix it. So this is usual mechanism of injury, the axe of the talus that impinges or it digs down into the calcaneus, and the calcaneus is fractured. So see it over here. This may not be seen on the X-ray. For that, you got to have some help of the CT scan also. So in this type of fracture, the angle is already restored, so you need not to go for the meticulous fixation. You can do it in percutaneous ways also. I'm sorry for the short time, but too much material which I have collected over here. Now, these type of fractures. Now, this tongue type fracture, they can be treated by percutaneous shank screw pass, which we pass from the posterior aspect of the tuberosity, and with the joystick, we pull the tuberosity down. That means, and towards the plantar surface, the fracture is reduced, and once the fracture is reduced, then you can pass the percutaneous screws or the wires, and you can achieve the anatomical reduction. You see it over here. The fracture has been reduced, and the same shank screw can go anteriorly, and then it is fixed with the percutaneous screws, or you can manage with the plate also. I'll not go into the details of the two classifications. One is Essex low opacity, which is based on the X-rays, and the Sanders classification, which is based on the CT scan. I hope every one of us knows it. So before 1850, usually they were treated by bandages and elevation, close reduction and cast. Percutaneous K-wire fixation started in 1952, and in 1993, then there was extensile lateral approach and the platings. So indications for the open reduction are the displaced intra-articular fractures, anterior process of the calcaneus fracture with more than 25% involvement of the calcaneo-cuboid articulation, displaced fractures of the calcaneal tuberosity, fracture dislocation of the calcaneus, and in certain open fractures of the calcaneus. Now, in doing so, we must keep in mind the associated problems of the soft tissues. The exposure is difficult. It's a complex 3D anatomy of the bone. And there are changing devices which are available in the market for fixation. And when there are open fractures, it becomes even difficult because the closure is difficult. Bones are usually osteoporotic, and there are comorbidities with it. So this is just 1 minute. This is the usual in CN we give. We can do it either with the shank screws or the other approaches. Post-op is very important. We must go for the elevation splint, and we should look after the sutures, and we can apply the fracture boot, give to the early motion, and take care of the neurovascular bundle. So, thank you very much. Sorry I took a longer time.
Okay, so we can take some questions for these two talks by Dr. Irfan Mehboob talk on cantilever fractures and the one preceding that by Dr. Sohail Yusuf on lateral collateral ligament instability.
Without any traction. And so far it's working for me. Secondly, technical question is, do you scope every patient for lateral ligament repair?
Everyone. As I mentioned earlier in the talk, I just want to make sure that I'm not missing any other pathology. MRI scan is very sensitive, but clinical examination, and I'm concerned about syndesmosis pain, I do stress them arthroscopically with a probe, check their syndesmosis. If there is any associated osteochondral damage or impingement, or especially scar tissue is a long-standing injury, I do scope everyone.
Thank you.
And how frequently do you encounter OCDs?
More than 30%.
More than 30%. Okay. Yeah.
The talus has to move in the mortise to damage the ligaments. There has to be subsequent force transfer from the ligaments to the bone. And it's such a tight compartment. And if there is a tilt in a young patient where the cartilage is actually very soft, they will have some avulsion injury to the talar dome. So I think in my practice, more than 30% patients will have an associated osteochondral damage.
But will something need to be done for all of those?
If there is a loose fragment, I remove them.
Right.
If there is a cartilage which is attached, but there's a flap, I don't believe in classifications. It doesn't work. I don't remember them. I'm getting old and senile. So I just use my own clinical assessment. If the crater is not too big, I debride them and clean them. I use a soft tissue shaver to shave the edges around it. In young people who are very active, and I have met them before, I'm concerned about them. I do microfracture at the same time to allow them to have their cartilage regrown. Again, depending on the complaints of the patient, if their complaint is primarily instability, if the chronic, it doesn't matter, 6, 9, a year, 2 years, I will still go in and stabilize the ankle joint. But I do a scope at the same time to see if there's any problem. And in the chronic, I would prefer doing, I mentioned in the talk as well, I prefer doing an internal brace if it's a gross instability. If even in a chronic repair, the instability is subtle and is painful and is more marked on the clinical examination, I still try to do an anatomical repair. Yeah. You still have the retinaculum visible and most of the time preserved, even in the chronic injuries sometimes. No qualms about internal brace, but I just feel going up straight in with a not very unstable ankle, in my hands, the Bostrom repairs does give very good results. I use internal brace if there's a gross instability, especially if the CFL is also compromised and there is an evidence of hyperlaxity, then I do use internal brace.
Okay, any other questions? All right, we move on to the next talk. Dr. Amanullah could not make it because of flight issues, and Dr. Tayyib Asim also had an emergency, so he is unable to come. So the next talk is by Dr. Sohail Yusuf on Achilles rupture. And I requested him to cover the surgical aspect as well as non-surgical aspect both of the Achilles tendon.
Can we get the talk up, please? Okay. My original talk was when to operate, and Tayyib Bhai was supposed to cover the other part. I'm sorry he's not here. I'll see if we can touch base on other aspects. It is about 11% of all tendon and ligament injuries cause a lasting muscular deficit. You cannot push off if your Achilles tendon is not functional. It has profound effect on quality of life. Non-operative treatment is common and effective. And we'll talk in a minute. I think it is the gold standard. The non-operative treatment is the gold standard. It can do very well. There are some instances when non-operative treatment does not work, and we'll talk about it. Most important thing is a timely diagnosis and initiation of appropriate treatment for these patients. How many people treat Achilles tendon injuries in a plaster? How many people routinely see Achilles tendon injury once every month? Yeah. So, people in Pakistan are not raising hands a lot. They are uncommon in Pakistan, and that's probably where you work. Tashfin works in Karachi, people work in Lahore, they do see these injuries, more so in Islamabad. I have spoken to people, but not very common injury on day-to-day basis. I think because we do not diagnose it. The diagnosis is clinical, and for that you need a high index of suspicion of these injuries. I don't think the ultrasound scan is the answer to diagnosis, but if you listen to the patient and then pick up the subtle signs, you will be able to diagnose, and that's one of the reasons we don't see too many. The challenges in Achilles tendon injuries management with non-operative is higher re-rupture rates, and I think that is because of delay in diagnosis and not a standardized treatment. It's a very trivial injury, someone's coming down the steps, or typically in our part of the world, Father's Day, doing some sports which they have not done, or in a school event, and they will have Achilles injuries. Such a trivial injury, which usually not very painful, but takes a very long to recover. Operation or no operation, it does take months to recover. In my hospital, when I started as a consultant, we teamed up with 4 other hospitals, and we found a pathway. If there is a suspected injury, we see them, we put them in equinus forward front slab, which keep the foot into plantar flexion to minimize the gap between the tendon ends. And then we give them DVT prophylaxis and arrange an ultrasound scan to confirm the diagnosis. Every time that the suspected patient is seen by an orthopedic clinician to confirm the diagnosis. Or even if it's suspected, we still get an ultrasound scan. Once it is diagnosed, then we see them in the clinic to see whether we're going to offer them surgery or non-operative treatment. 90% of the patients will have non-operative treatment, only 10% patients will have surgery. The non-operative treatment is an equinus cast in non-weight bearing for 2 weeks. Seen by the physio, they will remove the cast in 2 weeks' time and put them in a removable boot, which they have to keep it on all day. There will be 4 wedges in these boots. They will remove the wedges at 2 weeks interval. Some wedges are less thinner or some more thicker. So about 9 centimeter height of the wedges, in an average size, male or female. Depending on the size of the patient, sometimes they change the depth of the wedges and sequentially remove the wedges and get them into the shoes. The whole process takes about 8 to 10 weeks before the foot or ankle is plantigrade. So from my own unit's results, which is now been presented in C-Court and waiting publication, in last 1 year, after the COVID, we have a quite significant increase in the number of Achilles tendon injuries which we are seeing in our clinic. So we set up a pathway where we see them quickly, assess them with ultrasound scan, and offer them physiotherapy as soon as possible once we have made the diagnosis. Patients were suitable for a non-operative treatment were managed with accelerated functional rehab, which is a protocol devised by the Swansea group, which is in Wales in England, and has proven track record, been very effective, and we follow that with some mild alterations, which I mentioned. So we have seen 139 referrals. Of those, 128 had a diagnostic ultrasound scan. The 4 patients which did not have the scans were 4 of them prisoners, 2 of them are prisoners and 2 went privately. 88% has a confirmed rupture, is a partial or a full rupture. In my book, you cannot be a little bit pregnant. Either your tendon is ruptured and functional, or partially ruptured or non-functional. It doesn't matter. It has to be a non-functional Achilles tendon. Can Simmons squeeze test positive, palpable gap, failure to push off. Of those 113, only 19 patients had surgery, and 89 patients were conservatively managed. None of these patients to date has a re-rupture. They are all followed up by our local specialist physio. And why I think the protocol is working, because the patients have information about their injuries very earlier on, usually within 5 working days of their attendance to A&E. It takes less than a week to do an ultrasound scan for almost all of these patients, except the 4 patients we lost in the follow-up. On the ultrasound scan, we found the location of the tear. If it is a full thickness or partial thickness tear of the body of the tendon, their rehab is as standard. If it's a musculotendinous junction in age of 40 or above, then their rehab is slightly quicker. First clinic appointment with me or another foot and ankle surgeon was within 10 days. Complications so far, non-operative treatment. 7% patients had DVT. Almost all had DVT prophylaxis. So this is something to concern. Although these patients were given DVT prophylaxis, they still develop DVT because your calf is immobilized. It's in a non-functional position, and I think different from an ankle fracture, the foot is kept in equinus. It may have some impact on the circulation or venous return and increase the risk of DVT formation. The same results were seen by a FATE trial, which is a multi-center study in England with looking at the DVT rates after foot and ankle surgery. And they have also noticed the patients with Achilles tendon injuries have higher risk of DVT formation. My surgical candidates were fit, active, young patients. When I say young, they were less than 40 years of age, high functional demands, do regular sports including rugby, football, or any involving pushing and pulling. If the tendon gap was more than 1 centimeter in dorsiflexion on ultrasound scan, I offer them surgery because of the risk of tendon lengthening. I think there is a higher re-rupture rates with higher gap, and that the reduced push-up strength. Sometimes the lab gap was less than 1 centimeter, but there was patient's expectations or choice to have surgery. They think their tendon will be more stronger with surgery, or their rehab will be quicker, which are only 2 weeks quicker. I did surgery for about 6 patients whose tendon gap was less than 1 centimeter, but they have very high functional demands, or they expected to have surgery. What is the evidence? There is plenty of evidence available of all these protocols I have suggested. I'm sorry, the slide is not working well. In conclusion, if you have a set pathway for Achilles tendon injuries and you can quickly diagnose and offer treatment, right, by treatment is immobilization in the earlier phase, that will help to reduce your complication risk. Risk stratification helps for shared decision making. Every patient will be treated differently. No set pathways can be suitable for every single patient you treat. You have to look at individual patients' expectations, need, and potential for rehab. This has streamlined process, has reduced the burden on our fracture clinics. More and more patients going to the physiotherapists. We do not see these patients. We have feedback from our patients which is very positive, and this model has been applied in 4 hospitals now and maybe stretch further. If you have any question, I'm very happy to answer. Thank you.
Thank you, Dr. Sohail. because at 4:30 we have to wind up our session and we have some free papers still remaining, so we can take questions in the end if time remains. Otherwise, feel free to contact Dr. Sohail after the session. So the first free paper that we have is by Dr. Faiz Ali Shah on outcome of early weight bearing cast for the treatment of Jones fracture. Dr. Faiz. Dr. Faiz is our ex-chief editor of the Journal of POA.
Bismillah ar-Rahman ar-Rahim. My talk is on outcome of early weight bearing cast for the treatment of Jones fracture. In fact, it's a study. I would like to share my results with you. So this is a disclaimer. Outline of my presentation would be just the learning objective of this presentation, the outcome, and the background, brief background, study rationale, objective, methodology, result, and brief discussion and relevant literature review, limitation and conclusion. By the end of this presentation, the audience should be able to identify relevant anatomy or significance of fifth metatarsal base fractures, know the classification of fracture of fifth metatarsal base, and realize the importance of Jones fracture, why they are important. Know the results of Jones fracture treated in walking cast. By the end of these presentations, I expect that the audience should be able to teach Jones fracture in walking cast and conduct similar or better study and report their results. So that's a anatomy of the base of fifth metatarsal bones. As you can see, peroneus tertius, peroneus brevis, and lateral cord of plantar. So these are the soft tissue attachment. And later on, I'll be showing that peroneus brevis is basically an important muscle, tendon. In fact, that is responsible for the instability of fractures treated in this area. Now, as you can see, the zone 1, it has been divided the intermetatarsal articulation, that is the zone 2. Proximal to it is the zone 1. And then 1.5 centimeter distal is to the, this zone 2 is classified as zone 3. And these are the attachment of the two tendons. Now, as I've told you that peroneus brevis is responsible for the instability of Jones fracture, whether operatively treated and non-operatively treated. So this historical milestones, as you can see, a very long history, first classified by Jones in 902, then is the Stewart classification, Kevan classification, and the recent one is the Lawrence and Botti classification that is widely used. Now, why these fractures are important? So fracture of the base of fifth metatarsal of foot, they are 0.5 centimeter from the base of fifth metatarsal and called the Jones fracture because they have been first reported by Jones in 902 in 4 of his fractures, 4 of his patients, and they constitute about 26.3%. As you can see in this diagram, this is the whole percentage and this is the zone 1 and zone 2. The percentage of zone 2 fractures, they comprise about 24%. Lawrence demonstrated that Jones fractures are as distinct in zone 2 fracture, a metaphyseal-diphyseal junction, and the fifth metatarsal extended into the fourth and fifth metatarsal. As you can see, this is the zone 1. Zone 2 is actually extend into the intermetatarsal articulation, and beyond that distal 1.5 is zone 3. So this is a distinct zone 2. And this is again the radiographic representation in the chronicity. Zone 2 actually are acute fractures. Zone 1 and zone 2 acute, and zone 3 are chronic fracture and stress fracture as well, called stress fractures. Again, this is a graphic representation of zone 2. That's a tuberosity and Jones fracture. Actually, it's a comparison of two classification. One is the Stewart and that is the Lawrence and Booty classification. So he has classified this Jones into zone 3 and zone 2, while Lawrence and Booty classified it into distinct zone 2 fractures. Why Jones fractures are important? Because they have a less healing potential and greater risk of delayed union and non-union because presence of vascular watershed area between the metaphyseal blood supply proximally and diaphyseal blood supply or the Newton artery distally. This was a landmark article.
2 minutes left.
As you can see, this is the area, the avascular area, where there is no blood supply and they're prone to the healing problems. The same representation, zone 2. Yes. The rationale of our study is they minimally displaced fracture. They are traditionally treated in non-weight bearing cast. And prolonged weight bearing, non-weight bearing casts have their own risks. So we conducted, and this was in fact the first study in Pakistan. Objective was to determine the radiological and functional outcome of Jones fracture. This was a descriptive study, right? And we treated, in fact, it was a 5-year study. Ethical approval was taken. That's the inclusion criteria, acute fracture, zone 2 fracture. And exclusion were the previously treated and surgically treated patients. What we did, we apply the walking cast to the patient and allow them immediately weight bearing and follow them radiologically and functionally with AOFS score. This is the AOFS score, and our result, 328 patients. Our union rates were 98% of our patients as union rates. As you can see, majority of our patients had minimally displaced Jones fracture, while displaced fractures were 43%. So this is a little bit of literature review. Our results were comparable. This is a systematic review. The operative treatment has been advocated in athletes, but it had complications. Complications, as you can see, many complications. These are some of the operative implants and the systems. That's the comparison of operative and non-operative treatment. This is the literature review. We compared our results with national studies, so it's almost comparable. The limitations of our study is a descriptive cross-sectional study, and we have a short follow-up period. The conclusion is early weight-bearing cause is an effective modality of conservative treatment Jones fracture, as shown by higher union rates and excellent functional outcome. This technique has higher patient satisfaction and compliance with minimal complication. We therefore recommend this early weight-bearing cause as a treatment of choice for undisplaced or minimally displaced Jones fracture zone 2. These are some of the references which we use in our presentation. Thank you.
Thank you, Dr. Faiz, for sharing with us your excellent results. And yes, internationally also, non-operative treatment is generally the standard of treatment. In cases of non-union, you would definitely need to do something. But initial treatment mostly is non-operative. Yes, so we can have the next and probably the last talk. Do we have the next speaker here? Dr. Sabir Khatak. Sabir Khatak nahi hai? Okay, then the last one is Dr. Mohsin Javed. Mohsin Javed? Okay, please come. Thank you.
Thank you, sir. I am Dr. Mohammad Mohsin Javed, resident orthopedic surgery from Rawalpindi Medical University. Today we will talk about the calcaneal fractures managed through percutaneous technique, that is minimally invasive technique, and I'll share why we have done in our setting and what is the perspective. Although there are many other treatments planned which are being followed for calcaneal fixation, now intramedullary nails are even there for calcaneal fracture. This is the published study with principal author, Professor Zubair, who is the head of department. So calcaneal fractures are the most commonest fracture among the tarsal bones, 11 in the 100 to 100,000 population. This study was done over the period of 4 years, and patient selection were those patients who presented to our emergency with calcaneal fractures depicted over the radiograph. Primarily, X-rays were the choice, and if required, CT scan with 3D reconstruction was done. The patient selection was the main criteria. As we know that in our society with tertiary care, government hospitals are being targeted by those who are below the low socioeconomic population, and sometimes they cannot even afford the implant. So for our department, they choose K-wires as a method of treatment for these patients, and those K-wires were arranged from within the department itself. So this surgery was free of cost for those patients. So given that it's not basically a trial, this was previously practiced, so we thought of publishing this study as well. Under CM guided, 2 K-wires were passed in order to stabilize the articular segment, and if required, a Schwann screw was introduced from lateral aspect of posteromedial aspect from the lateral malleolus in order to stabilize further the articular fragments as well as the joint, subtalar joint. So we assessed the patient on a visual analog score, which was done in the post-operative period and on the follow-up till the 3 months post-op follow-up. These are certain data which were recorded. And I'll share the result. 50 patients were selected over the period of 4 years. Among them, 40 were males, and mean age was 41 years with range of plus minus 10. And average BMI, as we can debate on that BMI also is dependent upon the choice of implant. The BMI was 23, and among them, right foot was the commonest one. So average time for surgery, as we have limited number of theaters per week, that was 5 days, and among them, Sanders classification was type 2, that was among the 44% of the fractures. And yes, we can talk about the complications of calcaneal fractures, septalar arthritis as depicted upon the pane, assessed upon the pane was the commonest among the complications. And what we can say that our study was successful. Why? Because the 3rd month post-op pain was significantly reduced, and patient was mobilized, and with weight bearing, the pain was reduced significantly. These are some of the per-operative pictures. And yes, I'll conclude with that calcaneal fractures, although there are many treatment of modalities and they are being practiced with percutaneous screw fixation as well as the intramedullary nails, but K-wire, although it might be an obsolete among you guys and in the West, but given the limited budgetary and for low socioeconomic, K-wire is still an option for the treatment of choice. Thank you.
Thank you very much, and thank you for finishing well in time. And that helps us to conclude our session in time, well enough to hand over to the next group. While we have the shift over, if there are any questions about the last 2 talks, calcaneal fractures, Jones fracture. Ji.
You said the average waiting for is 1 day to 5 days. And that's depend on your OR. Yes. But if the patient this is because of the OR or soft tissue?
Sir, in percutaneous fixation, we can respect the soft tissue. We are not giving the extensive incisions to do the surgeries. So in case where we have a devastated kind of skin conditions, in those conditions, we were still able to do...
You're still manipulating the fracture?
Yeah, somehow, but we would... That is where we were balancing the time for surgery depending upon the skin condition and the availability of the OR.
Thank you.
Percutaneous wires.
Yes.
One has to wait for the wrinkles test, wrinkle
Yes, sir.
sign.
Yes, sir.
If it is, when it is positive, only then we manipulate it.
Yes, sir.
Irrespective whether we are putting a percutaneous wires, screws, or we are opening it up.
Yes, sir.
In Rockwood, it's written there, one of the Japanese, they put this, there's a Omori technique, you should do in emergency whatever the condition. Because if you leave this bone in the comminution area, that will provide this compression over the skinner. So if you, it's just to squeeze it and it's just to compress the fragments that somehow meet the fragments. So that will somehow decrease the pressure over the skin as well. So we think we should at least somehow you should reduce the fracture. The same basic principle that what you are applying around the ankle joint. No, yeah, exactly. So that basically decrease the pressure. Exactly. So this is what we commend.
Mohsen, a very good presentation. You were very confident. Well done. A good start. How long does it take to develop arthritis in a human body after an injury? Your study is 3 months. Subtalar joint arthritis in 3 months? So how can you say at 3 months subtalar joint arthritis developed?
Sir, we were assessing it on the basis of pain.
So that is pain from the fracture,
Yes,
which is
sir.
not healed?
Sorry, sir?
That could be the pain from the fracture, which is not healed?
Yes, sir, but like I said, with limited.
So there is no need to fix those fractures if you cannot fit them properly. That's my point. You are not obliged to do a substandard fixation if you do not have the tools. You are doing more damage to the patient by putting wires. Fracture is not reduced, it's not healed. If you leave that fracture alone, you have less chance of developing infection, and you actually will do better.
Right.
They all heal. The human. We start orthopedics in the last century. We have been here on this planet for longer than that. The fractures were healing before that. People were falling from trees, caves, whatever.
So I think the point is that when we don't have the latest locking plates, calcaneal plates, anatomical plates in situations where you have availability of screws and K-wires, and we need to do surgery, then have the end vision in mind, which is anatomical reduction. If you can achieve by that, then regardless of the way of fixation, we expect the patient to have good outcome. So indirect methods, percutaneous methods, K-wires, as long as you're able to reduce the key anatomical features of the calcaneum, which means the subtalar joint and the calcaneal pitch, the Boller's angle, the Gisane angle, the mediolateral expansion, all of which would prevent subfibular impingement later on and tarsal tunnel on the other side. So as long as we've catered to that, then we should expect good outcome. Sir.
Sometimes it gets about 2 weeks to heal. Then there's a cellulitis develops. And sometimes they got the ulcer and the gangrene changes and they becomes open. How we treat them and after 2 weeks or 3 weeks time, is this necessary to treat them conservatively, or we go for the surgery for such patients? Because there's dalmia for that.
As far as the soft tissues are concerned, we must respect the soft tissues, especially in calcaneus. Otherwise also. But then you can plan your surgery or otherwise only when the wrinkle sign is positive. Then it depends upon your expertise and the facilities available. And if you open it up, then you must ensure that you properly restore the articular surface and realign all the possible fragments to achieve the Boller's angle, the angle of Gisane, the height of the calcaneus, and the width of the calcaneus. And if you are unable to do it, and if your planning is poor, then your results will be same as of that non-operative, even without applying a slab, without applying a plaster cast, because fracture is going to unite. The fractures, they always unite. They don't unite in the hands of orthopedic surgeons.
We have to hand over now. Please, I welcome you for the shields. We need to hand over because we promised to be on time. So I would request the first speaker, Dr. Syed Mohsin Ali. And for handing over the shield, I request Dr. Harun Majid, please.
For information, I think this was the only session we started in time and we are finishing in time.
Dr. Irfan Mehboob. And Dr. Sohail Yusuf. अच्छा ये भी पिलाना है
इसका कुछ डिब्बा नहीं पिलाने का
Thank you very much. Thank you. Okay, thank you very much for your interest. Please feel free to contact me, Tashfeen Ahmed, I work at Aga Khan University Hospital. If you have any foot and ankle cases that you would like to discuss, I'm the secretary for the Foot and Ankle Forum. Until the next forum comes into place, which we expect to come in any few months, please feel free to get in touch. Thank you.
Assalamu alaikum. My name is Dr. Sunil Kumar, and the next session is on bone infections and tumors. First of all, I would like to introduce the panelists. Respected Professor Raja Irfan Kadir. Sir, please come forward. Professor Badruddin Seto, Professor Hamidullah Khan Kakar, Dr. Shakil Abbasi. Sir. So, first we have invited talks. It's Professor Badruddin Seto on frozen bone autograft for reconstruction of bone and soft tissue sarcoma, our experience.
Yes, sir. Yes, sir, you have started.
Assalamu alaikum. Bismillahirrahmanirrahim. I'm going to present my talk on frozen bone autograft for reconstruction of bone and soft tissue sarcoma. So far we have treated around 22 patients with frozen bone techniques, and this is the list of the patients which we have operated. And if you see, we have operated from chondrosarcoma to Ewing's to osteosarcoma and some sort of every. sarcomas we have in bone tumors. So this is the shin. So we have 4 patients with perioperative fractures when we put the bone into the liquid nitrogen. 1 patient developed non-union later. 3 have superficial infection, 3 have deep, and 2 patients have soft tissue recurrence afterwards. So I will not discuss what it is, just to show you the patients and hope you will enjoy it. This is first case. The patient was known as the 10-year girl with osteosarcoma proximal tibia, and she already received 3 cycles of neoadjuvant chemotherapy. So we dissected out whole the tibia, right from articular surface to the distal tibia, and saved the epiphyses of this proximal tibia as well. So after that, we put this into liquid nitrogen for 20 minutes and then re-implanted same bone back into this leg. And above this, we put gracilis, gastrocnemius, medial head of gastrocnemius flap to cover it, defect, and close the wound. And if you see this whole bone, after recycling, this epiphysis get united within 4 months. And look at this child after adjuvant chemotherapy. She was absolutely normal. Even she visited the OPD, she has nothing wrong, neither no meds, and look at the functional outcome of the child. See absolute normal range of motion at the knee joint, and she is still, alhamdulillah, disease free. So I'm going to show you second patient. She was a 6-year-old girl, diagnosed with embryonal rhabdomyosarcoma. She already have a chemotherapy and radiotherapy. And this was the soft tissue mass here. And we removed the soft tissue mass first. She sent back to the oncologist and she received other chemotherapy agents. After that, look at this, after the first surgery, she was absolutely normal for 2.5 years. But later they noticed there is some problem with the bone and sent back the child to us. And if you see, there is some problem with the bone and the diaphysis as well post chemotherapy, adjuvant chemotherapy. So we thought, we redid the MRI, we saw there was something wrong with the soft tissue as well and the bone as well. So we thought there was some problem with the bone. So we again removed the soft tissue, did the pedicle freezing, where distal end is intact, did the subtrochanteric osteotomy, dissected out the whole femur, and what we did, we make an incision. We make an incision in the bone with the periosteum and remove the soft tissue all around in an envelope and send for the frozen section. Once we get the frozen section was negative, we put the same bone back and put the plate. And in this case, we augmented this child with the fibular graft. Because in children, bones are softer enough. If you put into the liquid nitrogen for some time, with 20 minutes, that becomes more brittle. So additional stability we achieve with this fibular graft and put the plate. But later, she again had a fall, and she got the fracture at the plate end here. So we replated again the child. There is another patient with 11-year-old adventinoma tibia here. And so look at the wound here. And we did the pedicle freezing, where we make an osteotomy here, flip up the whole tibia, and some osteotomy this here. Look at the osteotomy of the fibula as well. To flip this whole tibia back into the liquid nitrogen and put it in the back. Now this is 21-year osteosarcoma distal femur, where again we did the pedicle freezing. This is post-chemo X-ray. And look at this incision. We dissected the whole femur, flip out this whole femur, and look at this. Knee is still intact. Only the one osteotomy was made. Remove all the tumor from the bone, put some hole inside this bone as well to decompress the cavity, because liquid nitrogen increases the pressure if you leave the tumor inside the bone, so that there will be no fracture. And then put in the liquid nitrogen for 20 minutes, put double plates and close this. Now look at this. This is initial. Now within 4 months, there are signs of union. Even that fracture get united within 4 months. And this child, absolutely normal function. So there is another patient with 18 years of chondrosarcoma left humerus, but same child was treated 5 years back with a history of Hodgkin's lymphoma, and he got radiation. And look at the lesion here. And there was too much controversy about this one. We did the re-biopsy in this area, and that turned out to be chondrosarcoma. So see the extensive soft tissue involvement here, but neurovascular bundle is still spared on major side. So what we did is dissected on the whole humerus, just making one single osteotomy at the metaphysis region. Whole humerus gets dissected out till the elbow. Everything around this neurovascular structure was spared. Look at this, all neurovascular structure is spared. Remove this tumor from the bone. After removal, then put into the liquid nitrogen for 20 minutes and put the flash plate. Now this is after wound and after healing. See, this fracture gets united within 4 months. So, and look at the functional results of this child. So another patient with 18 years of male with Ewing sarcoma humerus, and see, this is post-chemo X-ray. Right from here, see this proximal humerus is still spared. So we tried to save this humeral head and did the osteotomy that we did the V-shaped osteotomy in the proximal humerus, saved the vascularity by identifying anterior posterior circumhumeral arteries, and dissected out whole humerus again till the elbow, save all the neurovascular structure in the arm, put into the liquid nitrogen for 20 minutes, and put the plate. Now see this is after union. And look at the function of this patient. Somehow abduction is still restricted, but absolutely normal function on the upper. Yes, look at that. So another patient with 70 male with Ewing sarcoma proximal femur, and when we did surgery and did this same for tumor necrosis, we find out there's only 0% tumor necrosis. It means chemo was not that effective even. So we did the same technique. See the extensive tumor, but dissected the whole femur and dislocated the hip joint and flip it at 180 degree. And then putting the liquid and put it back. Later on, we informed the oncologist that there was no tumor necrosis, so he started radiotherapy, and post radiotherapy had a fracture. And we put this proximal femur nail, and that later on, within 6 months, this get penetrated into the hip joint. So we changed this and put it into this implant. So hope it will work. He is also having good function now, but this video is not working. So there is another patient with 18-year male high-grade periosteal osteosarcoma, and this was the first time we started methotrexate in this patient. So huge one, right from this trochanter up to the mid femur. Same technique we used, dislocated the hip joint, cleaned the tumor from the bone, put it in the liquid nitrogen, and reattach this, put this bipolar with Wagner process because of some cracks in the femur because of some tumor left behind. So we put this circulage and implant. And we reattach this greater trochanter with abductors back into the same area. But see, this gets united within 3 months or so. So this was the patient. He was moving with this stick, and then later on with this stick. And the other problem happened with this patient as well later. He got some sort of recurrence at the distal part in soft tissue. There was no recurrence in the bone, but the recurrence was in the distal area. So we disarticulated this patient's leg. And the patient was 60-year-old male, left-sided pelvic moderately differentiated chondrosarcoma, involving level 1, 2, 3, all of this pelvis. And we did all hemipelectomy. But when we curated out tumor, look at this, there was nothing left side in the middle of this acetabulum as well. So what we did is we took the same bone graft, what we have femoral head, put into the liquid nitrogen for 20 minutes, and this bone graft from the femoral head put into the medial area. Then we put this cage and recycle back all the pelvis back into the same area, and then put the total hip replacement. So what will happen in the next morning after 13-hour surgery? Everybody happy that we did something extraordinary, and in the morning hip was dislocated. So we did nothing, left the patient stable, and once patient was stable for a few days, we did nothing and we did the kilo reduction. We did only the kilo reduction here. And later, we made own braces for make the patient mobile, and he was walking on this brace. And later we remove the brace as well and let the walk on simple walker. Once we realize he can walk on this one. So he was fine enough for 9 months, and somehow he got some discharging sinus at the level of the pelvis. And we were sitting in the ward, and at the time of 3, nobody is sitting in government hospital, but I was there and with the students, because exam was there, so we were discussing something. Somebody came and he said, your patient came, he had some bleeding. So we rushed to him, we saw he some collapse, and we straight away bring this patient to the surgery. And we realized there was a rent in the external iliac artery. And we called the vascular surgeon, he immediately came and we tried to repair that, but that failed in the end. And we did hemipelectomy later. So this happened after 1 year or so when we did the surgery. He woke on this, but because we realized some part of the bone cement was slightly, there was impinging on the vessel that got bleeding. So big surgeries, somehow very big complications. So there's another patient with 12-year-old girl with osteosarcoma distal femur. So look at this. This epiphysis is spared. So this was sent by my one of colleagues. He said, I don't want to cut, and everybody is doing amputation straight away. So please try something. So what we did is we put this is our initial cases where we don't realize there was a fracture. So we spared the epiphysis, look at this, and cure it out. But when we put them into the liquid nitrogen, we have fracture. When we have fracture, but we still manage with floss plate. So later, within 4 months, when this child started, this plate get break here. Though look at this osteotomy side get healed, absolutely normal here. But this disease part doesn't heal. So plate get broken. And later that get infected as well. So see, this bone is absolutely viable. It was bleeding even after this implantation. But because of infection, we did the debridement later and put this bone cement rod with the spacer. And look at this child. She was walking and sent the video from home. She was alive for 4 years or so, and later on she developed mets and died because of that. So this is an interesting case. 10 years by, sarcoma left ulna. Look at this. There's no bone visible, nothing lying. If you see, there's everything is gone away, and this is all involved here. But see, this somehow neurovascular bundle has disappeared. So post chemotherapy, look at the response of the chemotherapy. All the ulna get back. Absolutely, ulna comes back, and we did nothing. Follow the same. Prevent this, preserve the oligoclonal process. Flip this ulna and put it into the liquid nitrogen and put it in the bag. Now look at this, only tension band. This all get fused. Later on we realize this child is having fracture as well after 5-6 months, and this all united. But look at the function of the child after 1.5 years. So absolutely normal function in the elbow joint. So there's another patient with 11 years even sarcoma, right proximal femur. Right from here, from the greater trochanter, some part of the snake is also involved to the diaphysis. And look at this extra ischius component as well. Philip up, hold this. And this time we did prophylactic fixation, maybe because of even sarcoma, somebody put the radiotherapy. So we did the prophylactic fixation at the same time. And look at this child. Initially he was walking with walker. And this is now. Somehow he got some limp. So we think if you dislocate every time we have avascular necrosis. But if you save distal part, only one sided dislocation or one side osteotomy, it means one side vascularity of the bone is still intact. So maybe later on they develop some sort of arthritis, maybe avian, but within 4 or 5 years we have seen still people are now absolutely normal walking with some limp around because of some extensive dissection around the abductors. So there's another patient with 14-year boy, osteosarcoma distal finger. This femur still have single chest metastasis. So we did free freezing. So far I have shown all the pedicle freezing where one side osteotomy, one side was intact. And the another side, this is free freezing, where we have removed this and one osteotomy distal one from here. And then look at the function. So he got 90-degree of flexion at the knee joint. So maximum follow we have is 5 years. So one patient had hemipelectomy external, one had hip disarticulation because of recurrence, one had abony amputation because of infection, and I have shown this calcaneum Ewing sarcoma where we put into the liquid nitrogen that get infected, so remove this calcaneum as well. 7 patients so far died, 5 because of disease, and this is how they have. And I must conclude, there is an excellent method of biological reconstruction. It's a durable, excellent union, pedicle freezing is awesome, then the free freezing, but still infection is a problem in our society. What I feel is one of the destructive, all your efforts gone away. So thank you for this whole team who teach me this technique. Thank you very much.
There was excellent talk by Dr. Badar. And
any question regarding
any question regarding this? Any question from the audience?
Excellent talk, Badruddin. Very exciting. 2 questions. Number 1 is, where do you procure your liquid nitrogen? Where do you get it from?
In SIUT, they have in pathology department the big liquid nitrogen container in pathology department. So we are doing this bone bank with them, and they are doing free of cost our histopathology. So they already borrow this liquid nitrogen in their department. So they are getting free. Number 1 thing, they are getting free. But when we ask the vendor that we need liquid nitrogen for this, initial 2 cases they give us free. Now he is charging 20,000 because he realized there's something special, so he is charging now. So it's easily available. If vendor is there, they are providing this.
I'm asking this question because it's not available in Peshawar where I work. So we need it for our allograft preservation and transportation. But I've tried, but the question still remains there. Where do your pathology department get?
We are basically sending 2 areas, even 3 times, 3 places where we send histopathology. For frozen section, we always SIUT.
No, I'm asking about from where do your pathology department get this liquid nitrogen?
Yes, we have vendor in Karachi. They are providing this gases into the hospital. So
Okay.
They provide this liquid
Okay.
nitrogen.
Okay. I'll take the
No
address
problem.
from you if possible.
This one of my colleague, this resident is sitting. He got the number. You always contact him. So I always ask him to please call him and bring this.
So if you could contact me,
Yeah,
please.
no problem. No problem.
And the other question, you showed a very good series of your cases. One was a tumor of ulna. Could you get away with just excising the ulna and not replacing it?
So with that, you will compromise this elbow joint. Maybe you can
Leaving the olecranon on.
Yeah, you can transport this, bring the radius into this proximal ulna. You can do it.
After your talk, I'll show you a couple of patients. Luckily, I've got in my.
So you want to say only
so
excise
you just
it?
excise it,
Excise,
leave
leave
it.
as such.
Excellent function.
Yeah, maybe.
Thank you.
But because we tried with this liquid nitrogen, so we not think we do excision, too many excisions around the elbow and this. But when we see we can do with the liquid nitrogen, it's doable, we do it. Because too many selection needed. If you have cortical bone preserved, then you can do it. If you have osteolytic lesion, you can't do it. So this is only one thing you have to keep in mind when you're thinking about liquid nitrogen. Your bone should be already preserved. There's not be involved whole with the tumor and this all destroyed. When you remove the tumor, there's nothing left in the bone and you put in liquid and that's failed. So that's why we are very cautious in selection of this patient.
Okay, Dr. Badar, I have great compliments for your extensive and nice surgery. Where you have been doing such a long surgery, it was all the cases you have done in the government setup or
No,
in the
sir.
private also?
It's 99% in government setup. Though when we start, everybody says it's not possible in civil hospital. So Dr. Dilip was with me, Professor Marathi was with me when we borrowed the theatre for 13 years from SIUT that we want to operate such a huge surgery, so give us theatre. So we went there and they provide everything free of cost. And we stayed there, worked, even 2-3 days, patient was there in ICU.
Okay, so it means it was the assistance of suit.
This one patient we did.
You have
One patient we
shown-
did, otherwise we all do in civil hospital.
Okay,
Yeah.
great, thank you.
The same theatre you left. Issue is who will stand, so I stay there till 3, 4, no problem.
Excellent paper, Dr. Badruddin. My compliments too.
Thank you.
It is a tremendous job that you are doing. Limb salvage with the techniques that you use in international literature give results, and the patients, you save lives, and the results are similar to those that are there in amputations. So you are doing a tremendous job. But my request would be, as you said, that if you are there for a few hours operating and you end up with having an infection, you have to make sure that your infection rate goes down. So you can ask the POA to help you procure a theater with laminar flow, etc., so that you can help the patients in a better way.
So we are waiting for PO to give us money. Already we are, PO is our कर्जी है, क्या कहते हैं, हमारा कर्ज है PO की तरफ. Still they didn't give us the money for last 5 years because of Orthocon. The AKU have done it. Then all should be given to the civil hospital.
नहीं,
Yes,
वो तो ये है ना
if they
कि-
will give us, we requested
I'm sorry, but there have to be preferences. But you were doing an excellent job. This is something that has to be commended and helped.
We requested them, even when Sumro Saab given them Orthocon, only we requested them, if you give us, we will make the theatre. We need nothing in our hospital. If you yourself only make the theatre for us so that we can provide all the services free of cost. There's nothing paid by the patient, neither implant, neither liquid nitrogen, neither surgery. Everything is free for the patient.
जो है वो उन लोगों ने अरेंज किए हैं कराची में और they are already rich economically, but they don't give a penny to the government hospitals while they are organizing the Orthocon. That's the main problem. Priorities उन लोगों की नहीं है. आप बैठे हैं सर, आपकी प्रायोरिटी हम गवर्नमेंट सेक्टर में काम करते हैं, हम समझते हैं, मगर ये उनकी प्रायोरिटी नहीं है.
So thank you, sir. Thank you very much for your compliments. Thank you.
So there is a second talk of Dr. Badruddin, giant cell tumor, grade 3, with denosumab effect, prospective history 94 patient.
This is again a big debate. It's still going on in the world. So either denosumab have a role in giant cell tumor or not. So I present this in ISOL's University of California, even this time in Taiwan. Even no people have such a huge data except India around the world. So this is again a big study we have conducted now. We have more than 150 patients with giant cell tumor treated with denosumab. But from 2000 onward, when denosumab was available in Pakistan, we tried to start it, and we tried to bring this all from the donations. Somehow people, if they can buy it, we allow them to buy it. So why denosumab? Whenever before this denosumab, we were operating such a huge tumors, what we thought, why denosumab is so important that we even operating and need the denosumab. So we used short-term denosumab because of people are doing in different way. We are tried in our setup according to our situation. So we give only 4 doses. As 120 milligram from 0 to 21 days. Even with gap of 1 week of 28 days. So within 1 month we give 4 doses only. Except some huge palliative giant cell tumors where we did the 6 doses or 8 doses, and recurrent giant cell tumors where we did this 4 doses, the new adjuvant, and 5 adjuvant as well. So it means we use in as adjuvant as well. So this is again a controversial, either there is a use of adjuvant or not. So I will share some of the interesting findings. So first thing we observed when we started denosumab, that as a neoadjuvant it provides excellent pain relief. And pain almost subsides within 4 doses. So patient thinks there is no need of surgery, my swelling gets subside, my pain is relieved, I am going home, I am not coming back. So if once he go back, within few months, initially small size, then tumor return back. So this is the issue with the denosumab, that patient think my disease gone away. And when the patient started, people started denosumab, they realized that denosumab is the only treatment, now no further surgery is required. But later they realized when they left, the tumor come back. So it means denosumab can be used as a tool, as a neoadjuvant or adjuvant. But surgery is definitely there. So I will show you the cases. I will not show you all the theory. Now this is one of the patients with scapular giant cell tumor. But see this. This gets somehow calcified with denosumab. Look at this, nothing visible, somehow calcified. So we did scapulectomy in this patient. I will not show you the patient follow-up, just show you how denosumab affects, because too many videos will be there, so it's very difficult to put in. So this is another patient, this giant cell tumor proximal humerus. We did this denosumab first and did the resection, put the fibular graft orthodesis. But what happened, see this, what happened, within 2 years, at the fibular graft end, there are recurrence. And we started denosumab. And this graft, this area, what the denosumab did is basically delineate only this area. The normal bone is still there. Look at the normal fibular graft is still there. So we go back and remove just distal part, leave half of the fibula intact, and put other fibula down the way. So this is recent patient we have. So this is another patient. See how beautifully calcified distal ulna giant cell tumor. But see this tumor is, this ulna is the medial part, this posterior part. So it's a dumbbell type of tumor involving the distal fibular end. So this, even see this posterior part was not that clear, but this is somehow calcified. If you feel on table, it is hard enough that it will not leak. So we easily dissected out the distal ulna with both the sides of the tumor in toto. So another patient, giant cell tumor of the distal ulna, see nothing visible, but with the denosumab all this reappear. And make the dissection easier. This reduces the edema. See this, how big edema is there. Is downgrade the tumor, and we resected the distal ulna only. This is another interesting patient. Is distal radius, even proximal row is not clearly visible, but see this, no, nothing visible. Extensive soft tissue edema, huge involvement in the proximal row, but everything is calcified. Even this proximal row get clearly visible. But see, he already have squamous sarcoma cheek. For that he had a mandible reimplantation and flap and everything. And when we sent this biopsy after excision, we found there was some metastasis of squamous sarcoma in the giant cell tumor. So double pathology in single area. So we will report this in histopathology, and already we have sent, hopefully we will publish. So this is another patient. You see this articular surface on the distal, this radius is not visible, but with denosumab, this somehow reduces the edema. This distal radioulnar joint is spared. So we did hemiresection in this case. So preserve this distal radioulnar joint, did the hemiresection, put this proximal fibular graft, and see this, it's united. And this distal radioulnar joint is one of the most common problem when we do the resection in this distal radius. Is distal radius ulna is subluxed. Always there is a subluxation in this. So we preserve this distal radioulnar joint with hemiresection. So what is the role in soft tissue recurrence? So see, there's a huge tumor here, already operated somewhere else and sent back to me. We gave the patient denosumab, only small part get delineated. But when we go inside, we found there was some calcified nodules were present in the soft tissue. So we just go outside the soft tissue and resected from distal ulnar all the soft tissue as well. So this is again a patient already operated 3 times somewhere else, and they send the patient to us. See this huge mass, deviation in the wrist joint, this all deformed. But with the denosumab, even see the some flexes of calcification appear up till the bone. So whole get calcified, remove this area, centralize the ulna, and orthodicese it. So what we think, this peroperative denosumab advantage, make dissection tumor easier, is one of the best we feel being a surgeon. No tumor contamination, because tumor is hard enough, there is no leakage. There is a more easier dissection of nerve, especially around the nerve. When even we dissect it out when there is a nerve entrapped into the tumor area as well. So we easily dissect the nerve, dissection easily around the artery, but there is a problem with the vein, because once the vein adhere to this tumor, there are always chances of bleeding. So vein get always ruptured. So I will show other cases. So proximal femur giant cell tumor, see this. So this patient came to us, we give the denosumab, and in between 1 or 2 weeks he got a fracture. We leave nothing. We ask the patient, take the denosumab, do nothing, keep immobilized, and see this fracture heal within 4 weeks. Is it possible subtroch fracture heal within 4 weeks? It's very difficult. Even with fracture, that doesn't heal. But later on, what happened? Patient run away, and somebody put this curettage and did the DHS. And after 5 months, this old DHS come out, and now he came back to me and said, see this, from here, iliac crest, down to this thigh, this whole extensive tumor is there. It's not this only this area, very small initially, but see this huge tumor round around. We gave denosumab, but see this only calcification around the bone, nothing visible in the soft tissue. Huge tumor around. So we did this Wagner processes because we don't have megaprocess at that time. And later patient developed infection, then dislocation, then we remove everything, and then put the bone spacer. And now recently, once the infection free, put this megaprocess with the total lip. Now this is his recent follow-up. Now he can fully mobilize. So simple mistake, there was nothing wrong, you can do simple surgery, but with everybody operating giant cell tumor, so this is an issue. So what is the role in extended curettage? The big debate. People who are giving this denosumab, they are giving 6 months, and then their study, if you go through literature, they have 27, 23, 35% of recurrence when they did the extended curettage after denosumab. So this is a big issue. So what I shown to them, don't give patient prolonged 6 months denosumab, because all the tumor get calcified. If you curate it, you will find nothing, and the tumor lying behind the cortex, that will remain there. If you stop this, tumor will recur. So with this, if you see this thin rim once appear, articular surface get formed, extended curettage, put some graft at this knee joint, curate it, put the plate. So that will decrease the chance of recurrence as well, and it preserves the joint. So this another patient, see this huge tumor, but once it's walled off, even this posterior surface was the tumor. So once it walled off, what we did hemi-resection. Some part, save this articular surface, remove this area, and again tried with this allograft. Oh, sorry. We put the allograft here at the articular surface with this femoral head, and then put the bone cement. So pathological fracture, again a big debate. So see this pathological fracture in the supracondylar femur with osteolytic lesion. We did nothing. Only give 4 doses. Within 4 weeks, pathological fracture get healed. So what we tried, we leave nothing. We find out that the epiphysis is still spared. Epiphysis is still spared, so we saved the epiphysis and did the resection only at the fracture area. So what we observed, that denosumab heals the fracture early, organizes the hematoma, and make the joint preservation possible even in pathological fracture. Even in previous books it's written, pathological fracture is indication for amputation. Even in melanoid bone. So see this, we just preserve this joint, put double fibulas, and now let's look at the function of this female. This all fibulas get even healed. So excellent result. She is achieving 90 degree of flexion with this as well. So this is another pathological fracture. This healed within 4 weeks. We did the resection, preserve the joint, put the double fibula in the plate. So this is how, when you use adjuvant denosumab. So this was, we did extensive giant cell tumor of the patella, few years back, and later on we realized there's something wrong with this posterior part because we didn't remove this. So we started denosumab, and we see there's some calcification only visible at the posterior aspect of this area. And we are still observing for last 4 years, there's no recurrence in this area. We are managing it conservatively just to observe whether there's a recurrence or not. So this is another patient with giant cell tumor with pathological fracture. Here we did denosumab, all organized hematoma. Because of organization, it was easier to dissect in toto. So we did the dissection, cut the distal femur and replace it. So see another patient operated somewhere else, they put the bone cement, and there's nothing visible in the proximal fibula, this tibia. All disappears. So we get the denosumab, all get reappear here, and even in the posterior side, and we did the resection and put this megaprocess in the proximal tibia. So this is another interesting case where this giant cell tumor was operated somewhere else, and somebody put the elizero, transported it, but there's a recurrence. So another surgeon put the nail, then there's a recurrence. So we did only denosumab, and all this recurrent tumor in the soft tissue get reappear. And we dissected out, put the flap, and this all after the healing. So proximal fibula, this is after denosumab, the response was not that good enough. See this, it was not that clear after 4 doses. But dissection around this common pivot nerve was so easy, even the branches can be spared. Because of hardness of the tumor, this easily dissected the whole common nerve, preserve it, and just resect this proximal fibula. As another patient somewhere operated, huge mass, even in the soft tissue, is clearly delineated. After denosumab, somehow this tumor edema subside, and we just resect and put the double fibula, and this is after union. So this is another patient with giant cell tubular distal tibia, where this old tumor get calcified. So we did extensive curettage, put this yellow graft, and put the plate. So this is another patient with giant cell tumor of the naviculum. So one of my colleagues has just curated out, but he discussed and I asked him just to give denosumab. So see this, after denosumab, whole this navicular is this calcified. So we asked him, don't do anything, leave him, we will observe, let's see what will happen. Because if you remove the navicular, your tibial anterior insertion will lose, it means your all arch will be problematic. So we just leave as such. Let's see what will happen in the future with this patient. So we have another patient with calcaneum giant cell tumor. So see, there's nothing visible, but all get calcified, and we just curated and put the bone cement. So this is again is extensive. If you go into the pelvis, huge mass. If you see, this pointer is not working. If you see this tumor here, this whole, right from here, this extensive involved in the whole pelvis. So we just give the denosumab 6 doses. Only the bony part get delineated, not the soft tissue. Look at the soft tissue here. Look at the soft tissue component here. Huge soft tissue component. Only delineation in the this bone, nothing in the soft tissue. And huge this vascular. So we just remove this area. This is another patient with the pelvic giant cell tumor, clearly delineated with this denosumab, only bony component, nothing in the soft tissue. Look at this in MRI, how big soft tissue component is also in the giant cell tumor. But this doesn't delineate it. Only bony component was clearly visible, no soft tissue component was expressed. And we did this hemipelectomy. And this is after a few years also follow-up. So he's walking with this hanging hip. So this is again another pelvic giant cell tumor treated with chemotherapy and then later sent to me that chemotherapy for giant cell tumors. This is something. So just give 4 doses, it's calcified, some part of the sacrum is involved, so we just resect this area along with the sacrum. And leave no reconstruction was done in this patient. So we experienced, one patient has a malignant transformation after 9 doses of giving denosumab. And remember, if you think you give the denosumab and there's no response, think about other diagnosis. This is one of the most important things. Yes, one patient with malignant giant cell tumor in our CZ doesn't respond to the chemotherapy, even this denosumab, because we even gave 5 doses, 6, she doesn't respond. So always think about the other diagnosis. So I must conclude, denosumab provides excellent delineation of tumor, easy dissection, preservation of nerve and artery, smaller bony lesions consolidate, excellent. Soft tissue lesions become hard and well defined. Recurrence in soft tissue is variable, sometimes calcified, sometimes less calcified. Can be used as adjuvant, heal fractures earlier, preserve bone, preserve joint, tumor progress. Once denosumab stops, so this is a big issue. So don't think denosumab is the only treatment. And there's a risk of transformation in the malignancy. It's a big problem. So with all, I must share, neoadjuvant denosumab, but surgery is still the definitive treatment for giant cell tumor of the bone. Thank you very much. Yes, sir. Thank you, sir.
Another great paper. 2 questions. First of all, the transformation percentage that you gave was for your cases, because in the international literature, there is an increasing number of cases being presented where their sarcomatous change takes place, number one. And number two, do you have any experience with using zoledronic acid with denosumab? Thank
No,
you.
sir, we did zoledronic acid only in giant cell tumor of distal radius in 2 cases. Smaller lesions, zoledronic acid we observe is a good responding. We put into the giant cell tumor proximal tibia, doesn't respond anything. So we think the smaller lesions, definitely zoledronic acid works. Larger lesions, it doesn't work. And if there was an issue, you give 5 milligram, the literature say, give for 1 year. And nothing written about giant cell tumor, how much you will give, with how much duration you will give. Either you give intralenal, either you will give IV. So there's again problem with the zoledronic problems, how to give. So they didn't still define for the role in, yes, people doing, even putting zoledronic acid into the bone cement in giant cell tumor for after extended curettage. So people are trying with zoledronic because it's a bit cheaper. This is 30,000 something, and that will cost only 10,000. So the people are trying with the zoledronic acid around the world. So it's still a debatable.
The denosumab acts only on the osteoclastic cells.
Sir. Ji, sir?
Denosumab acts only on the osteoclastic cells. How about the stromal cells, which are the tumor cells? They still exist, and how can you say that the tumor progression is reduced or it's cured?
This is what I said. Denosumab is only reducing osteoclast, doesn't do anything with stromal. That's why people think disease gone away and within few months tumor comes back because stromal cells are growing. So denosumab do nothing with the stromal cells. That's why I'm saying what the people in the Europe did initially, they gave patient 6 months denosumab. All tumor calcified, they leave, okay, tumor regresses, leave as such, then tumor comes back. Then they realize this is tumor coming back, then again give the denosumab. Then they curated it, then they realize there's a 30% chance of recurrence. Because they have money, they tried denosumab too much. Then they did the resection. And some of these surgeons have some cases around why you are giving denosumab such a huge lump. So this is again debatable. People are trying, but this is clear for our society. 4 doses only to reduce the size, delineate the tumor, do surgery. Don't wait for something miracle will happen. Yes, sir. ये किसी ने आर्टिकल आप पढ़ेंगे ना तो उसमें कहीं मैंने देखा था. If you go through this, you will find out. The people putting zoledronic acid into the bone cement and then are putting into the after extended curettage. We are not trying. We don't have too much facility to try all these.
I think zoledronic acid is heat bile, not heat stable.
I don't know why they are doing it, but they are trying.
Can Professor Irfan Saab comment on this?
Sir, mobile खोल लें अभी देख लें सर.
So it must be IV rather than putting inside the zoledronic acid with bone cement inside. It is going to demolish its function.
So everybody is basically, when you don't have anything, everybody have too many facilities for research. They are trying everything. Do this way, do this way. We don't have facility. We are doing what we can do easily.
No, but the trial should be on some basis. If you add zoledronic acid in the bone, I think everything will be destroyed. Yes, nothing. Because it's just...
It's not about, is it stable? So you can use it, no, but people are still using.
May I intervene?
You can
please?
find out, sir, because I've gone through one of the articles. It's not done by us. Yes, sir.
May I intervene? You have mentioned just a paper.
Yeah,
and people are putting questions on you that
Ah,
you are doing
no
it.
problem,
You are not doing
sir.
it. You are
No.
not doing it. So I think...
I can't do it.
Yeah.
I know my
I
restrictions.
think we are putting the question to the wrong person.
The wrong practice should not be practiced.
Yeah, definitely I will not. I don't have too much facilities to do it.
Excellent.
What I learned so far when doing tumors, when reconstruction, I always prefer to do the method which is easily accessible to us, which is simple, which is not costly because we don't have anything, because 90% of this old denosumab we arrange from donation. Because the people who are coming in the civil hospital, they can't buy this. We are arranging from some donations, some people gave, we gave the doses to them, and then we follow them. And some people can buy better enough that if they can buy, we don't give them zakat and everything. Think. 120 milligrams subcutaneous, four doses only. Tried 4 doses. I have shown in the first slide, 4 doses only.
Thank you,
Excellent,
sir.
Dr.
Thank
Badar.
you. Thank you, Professor Badar. The next talk is a management of fracture related with infection by Dr. Syed Imran Bukhari. Okay. Next talk is again periprosthetic infection by Dr. Syed Imran Bukhari. Now there are free paper. Denosumab in giant cell tumor of the bone, a review of current prospective and clinical trial by Dr. Muhammad Muzammil. Another is a free paper, is aneurysmal bone cyst in a 11-month-old girl, a case report by Dr. Mumtaz Hussain. Another free paper is Dr. Badruddin Sato, the fungating synovial sarcoma at a posterior aspect of neck, an unusual site, and a rare case report.
I think Dr. Mumtaz was here around, so he left somewhere else. I think Dr. Mumtaz I have seen. Yeah, he came, I think. So this is again a case report. It's one of the interesting cases we see, and this is one of this very important thing, how bad system we have and how people present to us. So Bismillah ar-Rahman ar-Rahim. I think this will be last talk as well. So this is synovial sarcoma, the posterior aspect of the neck. So this is a 20-year male, is a fungating present to us with a fungating swelling in the mid of the posterior calf, posterior aspect of the neck for 5 months, and foul smelling from the swelling for 2 months. Even foul smelling was so that bad that even we can't stand with this patient. So when we admitted, everybody left the ward. So swelling was small initially, rapidly growing, and he had a history of fever and weight loss when he presented to us. So we left him in an isolated single cube because nobody was sitting with him. And he was treated with a bone setter with a huge neck mass and sent back to us. So young male, pale, and this huge mass at the posterior aspect of the neck. So huge mass here, right from the occiput back to this C7 and lateral and mid, both sides of this whole neck was occupied with this huge extensive mass with maggots running in this wound and with this old fever. This is another aspect. So see this extent, this is extending up to this sternocleidomastoid muscle anteriorly as well. So with cervical examination, we find out this swelling, some bleeding, maggots, pus, everything was there. And we can't assess the range of motion, though shoulder was normal. This hemoglobin was 6, 20,000 was TLC, 52 was ESR, 15. So this was the parameters. Now if you see the MRI, from the occiput, huge fungating mass involving up to this spinous process of this vertebra and up to this area of the C7. But the card, if you see this, is spared. See this, some of this nearby to this card, but this one view, but if you see on others, the card was spared. And if you see axial, now look at this neurovascular bundle and the carotid sheath here, the tumor is up to this area. The huge involved, some part of this is also involved, and this is how huge the tumor was lying in this spinal region. So, but at that time even there was no metastasis. So already he had a biopsy, and that was monophasic synovial sarcoma. So we did the diagnosis of infected fungating monophasic synovial sarcoma, the posterior aspect of the cervical, posterior neck. So we discussed this case. Till that, we only give antibiotic and analgesic to that patient. We did nothing for 2 days, leave the patient optimized, give the billet, and then we planned for wide margin resection and reconstruction with the latissimus dorsi Philip and the SSG. So this is antibiotics and billets. So we just dissected out. So we didn't get the pictures. I forget to put. So this is again happened. Some part of the flap get necrosed. So we remove the flap, did this dressing, and then later this whole aesthetic grafting. So excellent work done by the plastic surgeon as well. So this is how progressively heal. And this is when there was heavy rain in the scene. Few years back, he sent the window, everybody in the family left him to take care of all these belongings at the home, and they saved themselves. And he sent the video from there to me. And this is all, he sent the picture to me. So there are few cases around reported on the world, not that big tumors were present and so forth. And he sent me this. This, if his video works, is nicely. He was a TikToker, so he was. So there was some song he put into it as well. So thank you very much.
This was an excellent unusual case. And any question regarding this?
Thank you.
Thank you, sir. Thank you, Professor Badar sir. There is the next free paper is the effectiveness of antibiotic-coated nail and beads in an infection eradicated in chronic osteomyelitis by Dr. Muhammad Waqar Khan.
Bismillahirrahmanirrahim. I am Dr. Waqar, final year resident in KTH Peshawar. I am presenting this paper on behalf of Professor Dr. Muhammad Shoaib Saab. Today my topic is effectiveness of antibiotic-coated nail and beads in infection eradication in chronic osteomyelitis and infected non-union of long bones. Treating chronic osteomyelitis and infected non-union has remained a challenging goal for decades due to poor penetration of systemic antibiotic into involved area, along with nutritional status, comorbids, age, complexity of trauma, and surgical skills, leading to work on prolonged local release of antibiotic in high concentration to control infection. Non-observable antibiotic beads and coated nails has been used for this purpose. We did retrospective study in our ward in KTH to assess its effectiveness in chronic osteomyelitis and infected non-unions. Objective of this retrospective study is to assess infection control rate in long bones caused by hematogenous root or occur secondary to trauma or elective surgeries. Our method was to view our department database to identify consecutive patients treated with antibiotic cement-coated nail and beads for chronic osteomyelitis and infected non-union in 2021. The diagnosis of chronic osteomyelitis was on basis of clinical, laboratory, and imaging parameter. Our hospital treatment protocol consists of removal of implant, aggressive surgical debridements, reaming of medullary cavity, and wash. We take samples for CS. Afterward, we implant an antibiotic-coated nail about vancomycin about 2 to 4 gram, gentamicin 160, and delacin about 300 to 600 mg, and make antibiotic-coated nail and beads. And we give follow-up visit after 2 to 6 weeks. Our results are here. We have total 96 patients, and most of the patients' age was 16 to 60 year. That is 84 patients. Below 15 year are only 8, and above 60 are 4. Femur cases were 56, tibia 34, humerus 4, radius ulna were only 1. 96 patients were included. Infection control rate in first and second attempt was 90%, while the overall infection control rate was 97%. Infection control rate in first attempt was 74%, 71 out of 96 patients. 15 patients needed second surgery for infection control. Patient need multiple surgery are about 7%. There were 2 patients in this group not improved. Conclusions were use of antibiotic cement-coated nail and beads proved significant useful in infection control, keeping in view the nutritional status, comorbid, age of the patient, complexity of trauma, microorganism, and surgical skills. This is our assembly for antibiotic-coated nail, mixing antibiotic with bone cement, ACN assembly in KTH hospital, application of cement to the nail. And prepared ACN was there, and ACN in situ in femur bone. And these are some images of post-op X-ray of antibiotic-coated nail. Post-op X-ray of antibiotic-coated nail plus antibiotic-coated plate were also seen in this picture. Slides were not changing. Okay. We have one case presentation. A 70-year-old HCV positive male patient presented with an infected external fixator applied for femur fracture. These are images of external fixator which was removed and ACN was done. After 6 weeks, after 6 weeks, ACN was removed and followed by PFLP fixations, which failed. We again remove ACN plates and then reapply ACN second time, and then we follow-up was arranged after 6 weeks. On follow-up visit, ACN was removed and chipping and bone grafting along with PLP fixation was done again. A subsequent follow-up visit was done, and this is the current X-ray of femur fracture with implant in situ. Also, the callus is quite visible on the X-ray. These are the recent X-ray. He is the patient, HCV positive, and he is quite satisfied. Thank you.
Any question?
Yes. Good. I appreciate that, but I just have a few comments and questions to ask. How do you coat the nail?
How we?
Coat the nail.
How we can mate the nail?
Yes, you are doing coating over the nail.
Yes,
How do you do that?
Sir, we have assembly in our KTH, which our professor brought it, and we can apply that nail in that assembly, and after that, when sir, I will show you the assembly. ये presentation थोड़ी लगा दें? Presentation लगा दें? सर ये असेंबली है हमारे पास KTH में. यहाँ हम एंटीबायोटिक जब मिक्स कर लेते हैं इस असेंबली में अप्लाई कर लेते हैं और IMN वहाँ पे अप्लाई कर देते हैं. असेंबली इसके ऊपर बंद कर देते हैं. आफ्टर 1 मिनट्स जो हैं जब खोलते हैं सर हमारे पास बिल्कुल प्रिपेयर्ड नेल सर इस तरह बन जाती है.
Are you using any metallic implant for coating?
Yes, sir.
That's
ये
what I'm
assembly
asking.
है, sir.
Which
ये-
metallic implant you are using?
ये metallic assembly है, sir.
नहीं, assembly metallic नहीं है. This nail is only the cement.
No, no, sir. IMN है इसके अंदर. Rational या IMN दोनों use कर
That's
सकते
what I'm asking.
Okay,
Is
sir.
that, yes, yes. It's a very nice paper. Let him answer. He is giving him confidence. I know it. Yes, I know that. I have done a couple of cases. That's why I'm asking. No. There's a simpler way also. See, that's what I just want to tell you. Yeah, you take a chest tube, and you put a small diameter, let's say 8 millimeter diameter K nail, and when the liquid cement is still in liquid form, you press it with the syringe, 20 cc syringe, and then once it settles down, just cut the chest tube, and you will have a beautiful nail. This is just one, instead of having this assembly, you can do that also. It's just, but my question is that, in which type of osteomyelitis did you use this nail? Was it osteomyelitis involving the cortices or only the medullary cavity?
ओके सर, पहला क्वेश्चन तो ये कि सर जब मेरी ट्रेनिंग शुरू हुई थी उस वक्त हम भी यही प्रोसीजर कर रहे थे, जो चेस्ट ट्यूब हैं उसी में सर नेल बना रहे थे. फिर सर ने ये असेंबली डिज़ाइन की तो उसके बाद असेंबली में करने लगे हैं.
It's good. I appreciate that.
ठीक है. सर जो दूसरा क्वेश्चन था वो अच्छा सर, मोस्टली जब कॉर्टेक्सेस इन्वॉल्व हो जाते हैं और क्रोनिक ऑस्टियोमाइलाइटिस हो जाता है तो सर उन केसेस में ये यूज़ करते हैं.
Well, to my knowledge, and the indications are that they have to be used only and only in intramedullary osteomyelitis.
Yes, sir.
And you should not use them when the cortices have been involved because they don't give good results.
Ji, sir.
Another question that why did you apply a plate over a nail?
सर वो भी एशियन थी. हम स्टेबिलिटी मोस्टली एशियन के केसेस में बाज़ दफ़ा सर स्टेबिलिटी नहीं होती. कुछ केसेस हमारे पास इस तरह आए हैं कि वो एशियन में भी हील हो जाते हैं सर, वो फ्रैक्चर हील हो जाते हैं. तो इसलिए ये हमने फर्स्ट टाइम ये प्लेट अप्लाई की थी एंटीबायोटिक कोटेड नेल, ओनली सोलो एक्सरे ये सर डाल दिया था, तो उससे स्टेबिलिटी हो जाती है और बाज़ दफ़ा सर ये हील भी हो जाता है.
If you have this beautiful assembly and the kit to prepare, then you should find out the diameter of the medullary cavity and prepare the nail according to that diameter and snug fit it and ask the patient to walk on the next day, and you will have very good results.
Yes, sir.
Especially in the mid-diaphyseal fractures or the fracture you have shown.
Yes, sir. Mostly, sir.
No, sir, you can measure it per operative. That depends upon the reamer. Let's say you have used a 12 size reamer, then make it, if you have this assembly, beautiful assembly.
And the temporary purpose, put them for the 3 or 4 weeks, then we remove that rod and then put the definite rod or nail or plate, whatever we have to do fixation after that.
No, you can achieve union on this rod also. It's not mandatory. No. It's not that. Because if the indications are very strict that for intramedullary infection and there's a non-union, this rod helps in achieving union as well as getting rid of the infection. You have to have a very strict indications for that. But if you are using for cases like this, that there is loss of the cortical bone and there is instability of the fracture and the infection is involving the cortices and all that, then I doubt that results. I doubt about that. Then obviously you will have a first procedure, putting in the rod, getting rid of that infection, and then going back and going another procedure for that. That obviously is different. Like that.
Thank you, sir. Thank you, sir.
Thank you, sir. Thank you, sir. There was an excellent paper, an excellent presentation by Dr. Badar and Dr. Wakar. And now there are the concluding marks. And for the...
You know, if you keep it for more than 6 to 8 weeks, maybe 3 months or more, you will see yourself, there's a beautiful sleeve, the soft tissue sleeve around the nail, which prevents the infection, further infection. And if once you remove that nail, then you can go for the fixation. So I would suggest don't keep it for 4 weeks, try to keep it for 4 months. And then you have a beautiful sleeve covering the nail. And that will prevent all types of infection. Then go for the fixation. Try it and you will love it.
How you will remove? That is not possible to remove.
No, it's very much possible if your nail is smooth while preparing the nail, while you are coating the nail is smooth. It happens only when you coat it and the nails become irregular in shape. It's very easily removed. You try it.
Okay.
Now there are concluding marks by I'm inviting Dr. Professor Irfan Kadir to come on stage and to conclude the marks.
Thank you very much for inviting me, first of all, and it was a very, I'm very thankful to Badruddin. If he has not been here today, there was only one more paper, and it would have been gone waste. Thank you very much, Badruddin, for presenting very excellent papers and sharing your very marvelous experience. And I think it was quite learning from your papers as well. And I think it has given food of thought to other people as well to try what you are doing as well, depending upon the availability of liquid nitrogen. One paper from Khyber Teaching Hospital presented by a junior, I think I appreciate. It's your beginning, and I think you should be able to defend these sort of questions from gray hair professors as well. Thank you very much for coming. And thank you to everybody who is here. By the end of the day, सारे लोग सो रहे होंगे ना इस वक्त. Thank you very much.
I will invite Dr. Professor Zamir Sumro and Dr. Irfan Kadir to give a shield to Dr. Badr.
कैमरामैन सो गए कैमरामैन चला गया छुट्टी पे आ रहे यार आ रहे खैर है बदरुद्दीन साहब के इतने अच्छे पेपर्स थे और should be a proper photographer here. किधर चले गए थे यार
शाम हो गई
बैटरी खत्म हो गई
Now I'll ask Dr. Irfan Kadir, Dr. Zamir Sumro to give a shield to Dr. Irfan Kadir. Dr. Zamir Sumro. सर ये फ्री पेपर उसको Dr. Muhammad Waqar, come on stage for the receiving a research paper, free paper. Thank you, everyone. Thank you, everyone.